Rep Carpino, I like your flag. It looks nice. Is that new?
Thank you. We made them over the summer. We have more talents than perhaps you folks realize. I made it with the kids and some neighbors over the summer. We made a bunch. So thank you for noticing.
It's beautiful. Every time I try and make something with my daughter, it could end up on like an Instagram or one of those Pinterest fails pages. So I'm super jealous.
This is only because I'm actually in the office. Normally I take our public hearings in my small closet. So that's why you see a different background.
Branching out. What's it made of?
Reclaimed wood.
Really? It is beautiful. Nice job.
Maybe we need a public health committee Instagram page or something.
I will not share the bloody fingers on that page. There were some mishaps, I assure you all.
Yeah, or maybe you can do a craft class for us all.
Well, on that note, let's bring the
thank you, Mr.
public
Chairman.
hearing of the Public Health Committee to order. Good morning, everyone. I'm State Representative Jonathan Steinberg from the 136th District Westport, co-chair of the Public Health Committee with my wonderful co-chair, Senator Mary Doherty Abrams. We have a number of bills to discuss today. I should also note that many of us have conflicts with other meetings and hearings going on. There are votes in transportation. Both Senator Abrams and I will have to run to that, and I know there are others as well. So we're all going to roll with the punches as well as we can and try to make sure we hear as much of the testimony as possible. And without further ado, I'll ask Senator Abrams, do you have any opening comments?
Nothing other than to say let's get to work. And many of us on this committee are stretched today, but I think the good news is we can go back and watch on YouTube anything that we missed. So I think that that's a good thing to keep in mind if you have to run back and forth. So thank you so much.
It's nice that we have a plan B. Representative Pettit.
Thank you, Mr. Chairman. And you're correct. I believe Senator Summers is at Transportation, and myself, Representative Kennedy, and Representative McCarty will be bouncing back and forth to Education starting at 10. It looks like we have a busy morning, and I am hopeful on the over-under that we can be done before midnight tonight. Thank you, Mr. Chairman.
I'll take a piece of that action. Senator Wong.
Thank you, and I'm hoping for the under. That being said, I'm very eager to hear some of these particular policy questions. I do want to make a note, if possible, that as we have had many questions in previous proposed bills that needed input from the Department of Public Health. And unfortunately, the last number of hearings, we did not get them to come and testify. I hope that they will be readily available to answer the questions that we have raised as a caucus in regards to concerns of previous bills. I know it is not, I don't want to take away from the focus of bills today, but I find it a little bit challenging to process that as I look at the rosters, that there's virtually the entire Department of Public Health who's made themselves available to testify today. But in previous hearings of potential controversy where we need some guidance, they chose not to make time to do it. And I just want to point that out, that I hope that they will make themselves available to address the important questions that need to be answered on issues that this committee may be taking up and voting on. And I'm glad to see them today. I want to extend my thank you for their incredible work during this COVID pandemic, but I do want to make a note that I find it quite surprising and that they're here today, but weren't available in other previous committee discussions. So thank you, Mr. Chair, and I'm eager to get into this discussion.
Yes, thank you. And to your point, it's not too difficult really to understand why so many DPH staffers have signed up today. If you recall, when we do hearings in the Capitol, the commissioner's subject experts are often right behind him or her and are available to answer detailed questions. My surmise, that's exactly what they're doing today. It's not that every one of them intend to testify. I'm willing to bet that very few of them will need to, depending upon the questions that we ask them. They're simply there to be available to the commissioner to help answer any questions this committee may bring forward. With regard to your other comment, It really is up to the commissioner's office to determine which bills that they will testify on. Discussion of bills that came up previously technically are non-germane to this conversation. We will allow a little latitude on that because there seemed to be such a strong feeling about it. But the chairs reserve the right to move on to the subject matter at hand, in fairness to all those who have registered to testify on the bills that are actually before us today. So we will allow some limited leeway on that, but we want to make sure that we don't spend several hours talking about bills that have already had public hearings.
I appreciate that. I appreciate that, Mr. Chair. And I just simply make that point of a statement that I hope that the department will readily be able to meet up with people, legislators that have significant questions, and that the questions that we posed will be answered. So again, I appreciate the opportunity to speak on that issue, and I do respect the germaneness of respecting the issues at hand. Thank you, Mr. Chair.
Thank you, Senator. I think Senator Summers is still over at transportation, so we'll get on with the agenda. First up on the agenda today, we're starting with elected officials and agency personnel, is Commissioner Delphin Rittman from the Department of Mental Health and Addiction Services. Welcome, Commissioner.
Hi, good morning, Representative Steinberg and Senator Abrams and members of the Public Health Committee. It's good to see everybody. I'm Miriam Delphin Rittman, Commissioner of Department of Mental Health and Addiction Services. With me testifying, I also have Tobias Wasser, Dr. Tobias Wasser, who is the Medical Director at Whiting Forensic Hospital. I appreciate the opportunity to provide testimony on House Bill 6398, an act concerning various revisions to statutes concerning the Department of Mental Health and Addiction Services, and also House Bill 6450, an act implementing the governor's budget recommendations regarding public health. You have my testimony before you, so I'll just summarize some of the high points from each of the pieces of testimony that I've submitted, and then happy to take any questions. Section 1 and 2 of House Bill 6398 balance patient and staff safety by amending the Patient Bill of Rights, so the Demas Patient Bill of Rights, to allow patients receiving treatment at Whiting Forensic Hospital building to be present during the search of their belongings. There is one exception to this, and that exception is when there is probable cause exists that there might be hazardous items in the patient's rooms, in which case the patient would not be present. The bills also allow 2 individuals with lived experience of behavioral health to be added to the Whiting Forensic Hospital Advisory Board. So that's an addition there as well. Section 3 of House Bill 6398 is a first step in a process to allow Demas to implement essentially an agency-wide electronic medical record. A single EHR will allow for more seamless, real-time sharing of patient information as needed. Our current process, unfortunately, is that we're using fax machines to send information across facilities. We know that it just lacks the efficiency. So a goal ultimately for us is to be able to get an electronic medical record. This bill in particular largely is about recognizing Demas as a single healthcare entity that would allow us to essentially down the line get just one EHR as opposed to multiple EHRs. In addition, Demas fully supports House Bill 6450. This bill, so Demas is has a tobacco prevention enforcement program that works with communities to inform retailers and the public about tobacco and electronic nicotine delivery systems or vapor products. Demas supports prevention, education, and awareness. The program also works with the FDA. Because we know adolescent brains are uniquely vulnerable to the effects of nicotine and nicotine addiction, Demas strongly supports the governor's proposed interventions designed to reduce the likelihood of ENDS products being used by youth. Some of these specific proposals are a ban on the sale of electronic nicotine delivery systems or vaping products with flavoring agents other than tobacco, so no flavored ENDS products. Also a cap on the maximum level of nicotine ENDS and vapor products allowed to be sold in Connecticut. That cap will be 35 milligrams per milliliter, so reducing the strength of the nicotine. In addition, increased penalties for the sale of these products to minors. We believe that these measures will reduce the likelihood of the products being sold to youth. The law would also require DEMIS inspectors to conduct unannounced checks to retailers to ensure that retailers are not selling the products to minors. If the retailers do sell the products to minors, then there's education and potentially fines as well to ensure that, that they're properly educated in terms of not selling to minors. Those are some of the high points of the pieces of legislation that I'm here to testify on. I'm happy to take any questions that you might have at this time.
Thank you, Commissioner. With reference to Section 3 of the first bill you commented on, my understanding is this is effectively enabling legislation. This does not actually fund a new system and has no fiscal note attached to it. Is that correct? I think the Commissioner's a little frozen.
Though it's not my specific area, maybe since it appears the commissioner is having some IT issues, I'll just say that is my understanding as well, Representative Steinberg, is that this is an enabling legislation that would allow DEMIS to be considered a single healthcare entity for the purposes of an EHR, but there's no request or fiscal note at this time specifically for an EHR product. Sorry, Commissioner, I was just filling in while you had some IT issues.
I know, I'm not sure what happened. I just got booted out. I got booted out all of a sudden. Thank you, Dr. Wasser. So yes, there's no fiscal note to this.
Yeah, we usually give you 2 minutes before we boot you out, or at least 3. The second question relates to the vaping and tobacco flavors bill. Once again, DEMIS is charged with the responsibility of mystery shopping retail establishments for compliance. This was very much part of the initial Tobacco 21 bill we passed a couple of years ago. Does DEMIS have adequate resources for this level of enforcement? And given some of the concerns we have about legislation, and I'm not going to go too far off the beam and talk about recreational marijuana, but I'm very concerned that the agency is already stretched pretty thin. Is this going to involve a greater obligation upon the agency?
I mean, it would require additional surveillance that we would be doing. We do have teams of individuals that currently do go to different retailers to ensure that they're not selling to minors. So my sense is those teams would add some of these checks to some of the existing things that they're looking for when they go to a retailer. It would, though, add additional areas that they'd be looking for when they connect with retailers. But again, we do have staff on board that could take on these activities.
One last question. Has the agency done any analysis of the expected net benefit from a public health standpoint in reducing nicotine addiction in the state via this law, or has even sort of a broad side of the barn feeling about its impact?
Yeah, I mean, I think the impact would be significant. We know that if we're able to reduce the use of nicotine for minors, that it can help to offset health effects down the line. Minors who use nicotine products when they're underage are more likely to go on to use other tobacco products, and some studies would even suggest are more likely to use other substances. There are also immediate health effects for minors that use nicotine. There's some studies that show that some minors may have difficulty sleeping. It may contribute to anxiety and depression because of the high level of nicotine. And so those health effects have ripple effects in terms of school performance and just the overall health and wellness and well-being of young people. So just the overall impacts in terms of reducing the likelihood that minors will be able to go to retailers and buy these products, but also through the not allowing the flavored products, they're less appealing. it does have the potential to reduce the usage among young people. The data, unfortunately, in Connecticut and across the country is really striking. When we look at 2015 data, the usage rate among minors was 7.2%. When we look at 2019 data, the usage rate went up to 27%. So that's quite an increase in a short period of time. And so this bill certainly can help to bring some of those rates down by reducing access of tobacco and ends products in particular to minors.
Thank you for that. It does sound significant. I'm looking for other questions for the commissioner. Seeing none, it seems like you end up, Representative Pettit maybe having difficulty raising his hand, or maybe I'm not looking at it right. Now I
There's
see
a lot of hands. There's a lot of hands,
people.
Representative.
Let's start with Representative Pettit, and then we'll get to the rest. It's all a matter of whether you're paying attention.
Thank
Representative
you,
Pettit.
Mr. Chairman. Thank you, Commissioner. At a high level in section 1, lines 109, where it talks about establishing and utilizing an electronic health system that allows authorized department personnel to have access to patient information, including psychiatric records. Can you just talk to very generally who would have, or maybe Dr. Wasser can, who would have access and what you feel are the protections for people's privacy in terms of their psychiatric records? Thank you.
Yeah, thank you for that question, Representative. Yeah, so the sharing of patient information would still happen with the appropriate approvals and clearances. So it wouldn't be the case that because a person's information is connected to the EHR, that a healthcare provider from, let's say, Capital Region Mental Health Center could look at information from somebody at Whiting Forensic Hospital. We would still look to have the appropriate approvals and protections related to sharing of information. But what having a single electronic health record will do is it will allow us to share it real time. Right now, particularly for people who've been in our system for a long time, if they're being transferred to another facility, their chart may be really thick. And so to have to fax that whole thing is just not efficient. And then in some instances, we have people entering data. But in terms of protecting health information, we would still have the various approvals that are necessary in place. And so once a patient gave their consent to share information, let's say from one facility to another, then we could do it instantaneously.
And a quick follow-up, once someone has permission, say, within a facility to access that information, can people at other facilities access it, or do they need an appropriate code? And are there checks in place where there's some IT review to see who's been accessing records to see if all the accession is appropriate or not?
Yeah, so it's a good question. I mean, we would look to put all of that in place to ensure that that health information within a facility is protected, and with the appropriate approvals across facilities, people could access information as necessary. We are still in the process of working to identify which electronic medical record is going to work best for us. There are many out there, and there's huge variation in terms of the utility and whether they will work for us. We did try one in the past, WITS, and it just didn't get us there. We've looked at Epic, and we're looking at other. Epic's really, really expensive, though, I do have to say. So we're looking at which EHR will work best for us.
Thank you, Commissioner. Thank you, Mr. Chairman.
You're welcome.
Thank you, Representative. Representative Foster, followed by Representative Carpino.
Thank you so much for being with us today, Commissioner. I have a question about the governor's tobacco bill's implementation and your department's capacity for smoking cessation programs. I'm a little nervous that the e-cigarette ban without the combustibles ban may result in children transitioning from e-cigarettes to combustible products. And I think that there is some data to support that is a likely pathway. So I'm worried that if we don't ban flavor combustibles in addition to the flavored e-cigarette products, that there's going to be a problem where we're going to have youth who are already addicted. I think there's protection moving forward, but I think for the youth who are already addicted, we have a problem. So my question is twofold. The first is that something that you're worried about and that you have recommendations related? And then the second is, do you feel like your organization is prepared to support the youth who are already hooked in transitioning? Do you have plans in place as this ban would come into effect, if it did, to make sure that the children who are already addicted? We heard a tragic story during the public hearing about the flavor ban of a child with significant mental health challenges that the mother felt were exacerbated by addiction. And so are we ready, or are you ready for the transition? And can you talk a little bit about what that plan would be?
Yeah, certainly. So, to your first question, I mean, I think anytime there are flavored products, whether they're the ends or the combustibles, a lot of the studies show they are more appealing to young people. I think that's certainly one of the reasons why in this particular legislation, a goal is to ban the sale of flavor products in the ends devices and products. Certainly the combustibles, the flavors may be appealing to young people, and so that's something to certainly continue to take a look at and continue to watch the research there. In terms of the cessation, in many ways, there are DPH and DEMIS tag teams on this. So, and DPH can speak more about this later on when they testify. DPH will often fund and do some of the work related to tobacco cessation. DEMIS is a treatment agency. Will often do work related to treatment. So for young people, or even adults for that matter, who are looking to decrease or discontinue their usage. There are medications that are available that can help with cravings. Often, though, we will like to sort of couple that with, medications along with counseling and combined. So it's not just the medication, but so that the individual is speaking to their provider as well. And so that we already have in place. So in terms of the capacity, I would say we could use our existing infrastructure. We have a pretty broad infrastructure with local mental health authorities in all regions of the state, as well as addiction providers in all areas of the state that we fund. And so I think, we will certainly build on our existing infrastructure to be able to, work with individuals who are looking to either reduce or end their usage of nicotine products.
I appreciate that answer. So one of the things that I'd ask, and it's okay if maybe this is something we could talk about offline down the road later, but I think it would really behoove the state, especially given that there's variability in implementation of bills like this, flavor bans, and outcomes by age group. I think that it would behoove the state to make sure that they have like a very coordinated communication strategy between youth services and schools. I'm sure there are already identified children who are addicted to vaping products. And I think that this would be a really important time for there to be a really robust communication campaign to make sure that people know of the resources that are available to them as they transition. And I think what we heard in our first public hearing is that there are resources and there is education, but it might not be saturating every community or every, there were legislators who were familiar with stuff that has been happening. They felt like there was need for more education. And I think that more never hurts. And if it's something that you need additional resources for, it would be helpful for us to know, because we don't want something that's meant to protect health to have an unintended negative consequence. So if we can be prepared knowing what the potential negative consequences could be, that would be helpful. My last question, if you don't mind, is I know that there was a lot of conversation in the first public hearing related to tobacco, related to health equity and these flavor bans. And I know that there is mixed opinion in the public hearing, but I feel like it's pretty consistent in the research that banning combustibles has the potential to offset health inequities in communities related to disproportionate rates of smoking, particularly flavored combustible products. And so can you speak a little bit to if you feel like there's another way to achieve that end, or if banning flavored combustibles is one of the best ways to sort of achieve health equity issues related to smoking and addiction?
Yeah, I mean, I think in many ways the combustibles, I think, or banning the flavors is one important step. In terms of addressing some of the other equity issues, I think there's ongoing work that we can do there as we are sort of across the board doing ongoing work related to addressing behavioral health equity. So at Demas, we have an Office of Behavioral Health Equity, and the goal of the office really is to look across different health challenges and then to come up with strategies and recommendations around addressing them. We also have an Evaluation Quality Monitoring Improvement Division, EQMI. And so we'll often look at our data to see, are there particular trends based on whatever the issue is, based on race, ethnicity, gender, and age. That will then allow us to do targeted interventions where we see trends. So in many ways I can see, doing a multi-layered sort of approach here. The, banning the flavors is one approach. I think then looking at our data and identifying what trends we're seeing by region will allow us to then do more targeted interventions. We also have regional behavioral health action organizations in each of the regions of the state. And they are available and often do real targeted work with communities when it's clear, or when a pattern that's troubling or that needs to be addressed has been identified.
Thank you, Doctor. It was a pleasure to hear you speak and to understand a little bit more about what your department's plans are. Thank you.
You're welcome, and happy to talk offline as well. I know you'd suggested that earlier.
Thank you, Representative. Next, we'll hear from Representative Carpino, followed by Senator Huang.
Thank you. Hello, Commissioner. It's nice to see you.
Hi, Representative. Good to see you.
I'm going to switch gears a little bit. It's probably not going to surprise you. 6398. You've been kind enough to give me a lot of your time over your tenure and our quest to make sure our patients at Whiting get the treatment they have. So I just want to confirm something in the first portion of 6398, lines 8 through 10. I know how we got here, and I appreciate the language, and I know it's a step forward. And if Dr. Wasser is the best one to answer this, by all means, please do. But I just want to be clear that the search language also means that in practice, if the individuals cannot be present because of the potential for a contraband or hazardous item being hidden in their living area pursuant to the language, is that documented as well? And I ask for no other reason than I want to make sure that each and every one of our patients there are know that they are treated fairly, and if they cannot be present, that their records indicate why they cannot be present.
Yeah, and so the search sort of process and sort of what happens is documented. I will ask Dr. Wasser to talk about that a little bit more in terms of what that process is and in terms of the documentation as well.
Sure. Thank you. Good morning. Good morning, Representative Carpino. So in Whiting, there, I think the distinction that maybe to draw is regarding two different kinds of searches. So the searches where we're talking about patients now being able to be routinely present are going to be conducted by staff as are conducted in other DEMIS facilities in order to make sure that their rights are respected. I think the language you're referring to has to do when there is a significant concern, as you're saying, that there's some sort of harmful item, contraband, things that somebody has smuggled into the facility or crafted while in the facility that could be used as a dangerous weapon. And when we're going to need to involve the DEMIS police force in that search. And those would be the one exemption when we would say that the patient would not be able to be present. We would clearly document that process. The police have one documentation process that they would go through to elucidate the reasons that they were conducting the search, the manner in which they conducted the search, and for whom. On the clinical side, there would be a physician's order stated in the patient's chart stating why the patient could not be present during the course of the search. And really the reason is because, again, we although we obviously are highly respectful of the patients and we want to make sure they get the best possible care, we are the only maximum security psychiatric hospital in the state. And at times we do have patients whose degree of risk and their psychiatric pathology places them at a significantly elevated degree of risk beyond what we would see in other settings. And so we need to make sure that when we're searching for their room for those kinds of items, that we have the ability to do that it safely, and that we also are not sort of allowing them to understand other places they might hide such items if they're able to observe the search and learn things about the patterns of the search by the police, things of that nature. But to your specific question about would it be documented? Yes, it would be documented in 2 different places, both in the police records of their processes and their conduct, as well as in the patient's clinical record.
Thank you. And I do understand a bit of what you speak about because I've walked the floors of the facility multiple times during my tenure. I just am looking for transparency on behalf of all of our patients. And I think at the forefront is better than after the fact. We've certainly learned that on the grounds. So as long as you can assure me that every search is documented in their records, whether it is by staff or by campus police, and that, well, then my second question is, are the findings put in their record too? Because I would want to know if a patient had 10 searches and nothing illicit was found, is that also in their records?
So the short answer is yes. So it would be, if searches are conducted, there's a record that the search was conducted and whether there were any findings from that search. So yes.
Thank you. By staff and by police, because as you well know, there were allegations in the past for some of our newer committee members that some patients felt as though they were perhaps in the crosshairs of staff, and this is just their allegations. And I think this would be a big step in making sure that that didn't take place. So I just want to make sure that it's documented with both staff as well. Yes?
Yes.
Thank you. Thank you, ma'am. That's my question.
Thank you, Representative. Senator Huang.
Thank you, Madam Chair. Commissioner, welcome. And I want to acknowledge your efforts to constantly improve patient care and the operations at our psychiatric hospitals and our community-based centers. So I know it's a continual work in progress, and I know you've made yourself available to correct some of the challenges that may have existed before you. So I wanted to acknowledge that it is continually a work in progress. And I want to acknowledge my legislative colleagues for continually to work with you. I'm actually really intrigued about the electronic records. I mean, the idea seems normal, right? From the concept of we want to consolidate efficiency, but the devil's in the details. So my question to you would be, who are the vendors that are going to accomplish this if this bill gets passed? Is it going to be internal vendors, or are we going to send an RFP for outside vendors to bring state-of-the-art technology and utilizing that? Because you have privacy considerations and HIPAA protections. So who are we going to use if this bill passes?
Yeah, good question. I mean, so this bill really would be the first step to set us up to be able to get an electronic record, medical record down the line. We likely would do an RFP because it is such a, these are, they're pretty costly. And as you mentioned, there's lots of different areas that need to be addressed in terms of the specific content areas in behavioral health, in terms of the different firewalls and protections and all of the pieces that you mentioned. So we likely would, do some form of RFP to be able to find the best product that's going to work for us. We're doing very high level searches now including, talking with other states to see what other states have used or are using. And there are many different products out there, some of which work better than others, and some which are, quite frankly, just very, very costly and may not fully get us there either. So it's definitely been a process through looking and doing the work to see which product is going to work best for us.
So what you're pretty much saying is this bill is just truly the beginning of a very complicated and a delicate process of trying to merge all the computer data. I just still remember the challenge we had in DMV many years ago with trying to centralize system and how it turned out to be a complete disaster. So I wanted to ask that question. And also my follow-up question is consistent. I wanted to respect the chair's chats earlier about staying on the germaneness of the bill. But obviously a colleague of mine brought up and engaged in conversations related to flavored tobacco. I think you're going to have a general consensus that we're all very supportive of it. But I wanted to pivot and ask, has the Commissioner on Mental Health and Addiction Services, do you have any thoughts and ideas in regards to the proposal underfoot by the administration on legalization of recreational marijuana from a standpoint of substance as well as potential addiction services? I haven't heard anything from our public health commissioner, nor from Demas in an area that is a significant impact if this legalization effort was to pass. Any thoughts?
Yes. Thank you for that question. So the bill does propose that resources would be set aside for Demas to be able to do similar to what we're talking about with the vaping products, to do secret shopper-like programs related to cannabis as well. So we would set up a very similar program, and I believe there's language in the bill around additional resources to bring in a few additional staff to be able to do this work. But the idea would be very similar to the tobacco and to the vaping products, to be able to go into retail establishments. And if the retailers sell to minors, then same thing. There would be fines. There would be education and training. And so I think that's something certainly that could help. The other piece of the bill includes is language around, Demas doing a pretty large scale sort of prevention and awareness related campaign, associated with underage usage or even overusage. And so there are resources and language in the bill that would allow us to do that. I think that's important. I mean, I think often young people don't know sometimes what they don't know. And young people getting more information. In Senator Wong, I know you know the work of our regional behavioral health action organizations. They're just awesome with getting out there and working with schools and towns and communities to put together forums and other education, awareness approaches to help increase the awareness for young folks and others. So we would look to do a public awareness campaign related to cannabis, underage usage of cannabis as well.
Thank you. And I have indeed appreciated and working and collaborating with you on prevention programs, Awareness Week. And I think one of the themes that comes out of all of that from a standpoint of prevention, particularly in your department, because you sometimes see the aftermath of addiction and the impact on mental health caused by substances and the abuse of them. But I still remember things that are said in many of our prevention programs. The best prevention is not doing it at all, and not increasing access or having a state in essence saying it is now legal. So I will leave it at that, and my hope is to continue to work with you on the better mental health and supporting addiction services. But as your great work on prevention re-emphasized to me is, let's not do it at all and stay safe and maintain a healthy lifestyle. And I hope we get that message out that perhaps we should reevaluate. And I hope that your department in seeing the devastation of substance abuse occur, and particularly amongst our young people, that you have a louder voice in this discussion as we deliberate over legalization of recreational marijuana. Thank you, Madam Chair.
Thank you.
Thank you for your work, Commissioner.
Thank you, Senator.
Commissioner, good to see you. We had a few more hands get raised. Representative Claire,
Okay.
followed by Representative Arnone.
Thank you, Madam Chair. Thank you, Commissioner, for being here today. And thank you for all the hard work you do every day, day in, day out. Have you heard Or do you know of any other states that currently have the electronic delivery sharing system?
I believe there are other states that, that have it. You mean that have it legalized or?
Yes, that are doing what we're proposing, this year, today.
Yeah. I know that there are other states. There was a period of time we were in discussion with New York and the sort of surrounding states. I don't know in particular though, in terms of specific legislation and what legislation other states have proposed.
Right. I mean, just meaning if they're doing what we're proposing, if they're already sharing the electronic records.
Oh, so you mean in terms of the EHR, so the electronic, yes. Yes, so there are other states that do have, I'm sorry, I thought you were talking about the nicotine devices.
Oh, no, sorry.
It took me a little bit to catch up with you there, but yes, I'm with you now. Yes, there are other states that have electronic medical records.
Do you know if it's more where if half the states do it? I mean, are we in the beginning of doing this or are we catching up to other states that are currently doing it? That's.
I don't have that sort of comparative data overall. Okay. From my calls with other commissioners, so the regional commissioners, will have regular calls. I know there is one other state, not to call them out, but one other state in the Northeast that tried the initial vendor that we were working with and also didn't get there and also stopped in terms of that vendor. Okay. And last we spoke was looking for another EHR as well. Okay. I think states are probably in different places, but by and large, I think across healthcare, particularly in behavioral health, as we're talking about healthcare integration, that the goal, for most states is to have an electronic medical record. It allows for sharing of information not only between behavioral health agencies, but many of our individuals, the individuals that we work with also have, comorbid medical conditions. Mm-hmm. And so there is often, there may be an interaction between sort of what's happening. And the long and short of it is it's helpful to be able to share information, not only, within and across DEMAS agencies, but with other healthcare providers, of course, with the appropriate protections as well, to include primary care providers in case there are things going on across sort of primary care and behavioral health.
Okay, because you had mentioned that you'll probably have to go out for an EFP for this. But I guess my suggestion is by talking to your fellow, the states around us to see the problems they've had, or if they've had a problem with a certain vendor, that we don't make that same mistake and use that same vendor as sometimes we've done in the state. I just want to make sure we get the appropriate support for this so everything goes smoothly. But thank you so much for your testimony today.
Thank you. And thank you for that recommendation. We are actually working with a vendor now who is doing some of that work, sort of looking across different electronic medical records, also looking across what other states are doing. So we do have somebody, a provider that we're working with, or a vendor that we're working with that's helping us to ensure that, as you said, we get a product that works for us, that it's efficient, that it's fiscally reasonable, and that we get to where we need to get with it.
Okay. Thank you, Commissioner. Thank you, Madam Chair.
Thank you, Representative.
You're welcome.
Representative Arnone.
Thank you, Madam Chair. I just want to point out today with a lot of talk about prevention and how important your department is for grants to towns, committees to do media campaigns throughout our towns and allowing the individual towns the time to use their own campaigns, because they actually know best how to reach their people. And I just want to make sure that our board knows, our committee knows that those dollars work. The tobacco campaigns that we've done through your department has worked here in my town. We saw the numbers fall until the vaping started to decline again. And then, of course, we were able to move quickly using DEMA's dollars to start those campaigns, to start pushing those numbers back down again and making parents aware of it. School climate data that we've, through your department, have gotten for a number of, probably 15 years now, we have data to show exactly how well these programs work. I know the federal government now has cannabis. We have some grants from the federal government to follow your lead locally on cannabis awareness for teenagers. We've been running this now for at least 2 years. So, I just want to make everyone aware of how important the funding is for your office to fund us locally, because we know how to spend that money correctly and give us that freedom to handle our own individual fires here in towns. And it works phenomenal. And again, I just from up here in Enfield, thank you very much.
You're welcome. You're welcome. I appreciate that comment, and absolutely. I mean, I think the towns and at the local level are often able to craft messaging that really goes right to what the needs and what the where the areas are that need particular messaging. Earlier we were talking about health equity as well, and I think that is certainly one way to be able to be contextually competent. That is to sort of work with the local prevention councils and their regional behavioral health action organizations, because they're able to pull in messaging and develop narratives that sort of match and fit the context of their town. And so there's in the health equity work, there's often discussions around, context competence is so critical when we're trying to reduce and address disparities for diverse racial and ethnic and cultural groups. So the prevention councils have just been awesome there in terms of, tapping into some of those local needs and trends. And so we would look to continue to partner with them.
Thank you, Representative. Thank you, Commissioner. It looks like we have no other hands. Thank you so much for being here this morning and for your testimony and the work you do.
Oh, you're welcome. You're welcome. Thank you. Take care, everyone.
Take care. Next, we'll hear from Commissioner Deirdre Gifford and her team from the Department of Public Health. Welcome, Commissioner.
Thank you very much, Representative Gilchrist. Good morning, and good morning to Senator Abrams, if she's still there, Representative Steinberg, Senator Summers and Wong, Representative Pettit, and all of the members of the Public Health Committee. Very glad to be with you this morning. I'm Deirdre Gifford, the Acting Commissioner at the Department.
Counseling piece. It was nice early on that we could meet individually, but it's really just talking to students.
One of your, they muted. All right, go ahead. Oh, now you're muted, Commissioner.
Thank you. Joined by a few members of my team, subject matter experts from the Department of Public Health, to be able to answer if you have more detailed questions on the bills before you. Thank you for raising the department's bills. And I'll just jump right in, Representative. With respect to House Bill 6449, an act expanding economic opportunity in occupations licensed by the Department of Public Health. This bill would allow DPH to issue an occupational or professional license permit, certificate, or registration to individuals that have either established residency in the state of Connecticut or to spouses of active duty members of the armed forces that hold a similar credential if the person is qualified based on the requirements outlined in the bill. It also requires DPH to convene a working group to determine Connecticut's ability to participate in national licensing compacts for certain professions. And lastly, the department is required to review examinations administered by the state to determine if there's an examination administered by a national organization that can be an acceptable substitute to the department. The department is supportive of this bill and respectfully requests that the committee review our written testimony to include the substitute language that would narrow the scope of the exams only to those that fall under the purview of the department, and to insert the words United States before jurisdiction. With respect to House Bill 6450, an act that the governor's budget recommendations concerning public health, the department strongly supports sections 1 through 6 of this bill to eliminate flavors in vapor products and electronic nicotine delivery systems. This will help, as you've just heard from my colleague, Commissioner Delphin Rittman, help reduce youth initiation of tobacco use. Our written testimony also includes specific information regarding the use of vape products in youth who began using these products with flavoring agents. We respectfully defer to the Office of health strategy for testimony on sections 7 and 8 of this bill. Senate Bill 847, an act concerning newborn infant health screening. This bill would require our blood spot newborn screenings to be sent to the state public health laboratory no earlier than 24 hours after the birth of the newborn and not later than 48 hours after the birth of the infant. Our written testimony talks about the need to align the collection and shipping of newborn specimens with current standards. There are multiple federal standards with which this would align. The Health Resources and Service Administration, HRSA, Advisory Committee, the Clinical Lab, and Standards Institute on Newborn Screening, and also recommendations of the laboratory's Newborn Screening Program Genetic Advisory Committee. The bill also requires the administrative officer or other person in charge of the institution who performs testing for cystic fibrosis to report those aggregate numbers of newborn infants screened, as well as the results of such testing on an annual basis to DPH. The aggregate data regarding the test results for cystic fibrosis testing in newborns to the department can be used for data provided to the Title V Maternal and Child Health Services block grant. So it'd be very helpful for the department to receive that data on an annual basis. Senate Bill 922 is an act pertaining to revisions to the statutes regarding residential care homes. This bill is would enhance the rights of residents in residential care homes that are experiencing involuntary transfer or discharge. It allows a residential care home to qualify, importantly, as a home and community-based services under the guidelines from the Federal Center for Medicare and Medicaid Services. Over 260 individuals currently reside in residential care homes and receive services under the Connecticut Home Care Program for the Elders waiver. So it is imperative that the state ensures these RCHs can be considered a home and community-based setting under federal regulations to make certain that these residents will not have to move in order to continue to receive these services. These appeal and discharge requirements are in fact a requirement by the Federal Center for Medicare and Medicaid Services in order to qualify these residential care homes as a home community-based setting. Pursuant to the Code of Federal Regulations, residents living in home and community-based settings must have comparable protections regarding involuntary discharge to those provided to tenants under the state's landlord-tenant law. So that's the aim of this particular bill. It contains provisions that enhance the appeal rights of RCH residents who are notified of a pending transfer, and it allows a facility or resident who's aggrieved by the final decision of the commissioner to appeal the decision to the Superior Court. House Bill 6489 concerning the Department of Public Health's remote access to medical records maintained by hospitals and healthcare providers. This is a bill that would significantly enhance the department's ability to do our work in a number of areas. It allows the department remote access to medical records for infectious disease surveillance, tumor registries, maternal deaths, and creates a pilot program to access to medical records for vital records data. In our written testimony, we explain how important the ease of access to remote medical records is for us. Currently, the department, in most cases, needs to drive to the hospitals and look through printed electronic medical records that may be hundreds of pages in order to do our work. The department has been allowed remote access to 3 hospitals, and this has saved staff time, not only with travel to the hospitals, but to facilitate the ease of search of the medical records. And to be clear, we are only looking into those medical records relevant to our tumor registry, infectious disease, maternal deaths, or vital records in the pilot program. This bill also allows, I just said that about a pilot program for use in vital records. That concludes my verbal testimony. Thank you for the opportunity to speak on these bills, and I'm available obviously for your questions as well as the agency's subject matter experts. Thank you, Representative.
Thank you, Commissioner, and thank you for doing double duty and for all that you're doing in our state to help with get vaccines out and make us all safer. I do have a question. I've had the opportunity and pleasure of working with your department in terms of licensure. And so I was hoping to ask with regards to House Bill 6449, I had conversations with Chris Anderson, so I'm pleased to see this bill moving forward. Wondering what licensure holders will benefit most from the reciprocity with other states?
Well, I think I'll ask Chris to weigh in, but I think it would obviously be in those states where there's either significant difference in type or quantity of requirements between that state and Connecticut. I think the important thing to point out here is that for the largest and probably most significant categories of licensure at DPH, we are already using sort of national standards, and there is an interchangeable requirement from state to state, or the same requirement generally for licensure from state to state. And so this would pertain in many cases to the larger number of smaller professions that we also license, and would allow the flexibility that those individuals need in order to be able to relocate to Connecticut without an onerous process for changing their licensure. Chris, I don't know if we've done an analysis yet to see which categories of licensure might benefit the most from this.
Yeah, no, we haven't done an analysis yet, but I think your overview was perfect. You know, as you mentioned, most professions, larger established professions like physicians, nurses, dentists, the requirements from state to state are pretty close, pretty much the same. I think this would be most helpful for those professions where there's a lot of professions that aren't licensed in every state. So maybe 25 states license them, and there's sort of a hodgepodge of requirements. Sometimes some of the professions that come to mind are things like hairdressers. Sometimes there's little nuances where someone's been cutting hair for 20 years in another state and they come to Connecticut, and for some odd reason, their experience or training doesn't fit Connecticut's. We try to work to tweak those year to year, but this would avoid that kind of delay for someone coming here, or things like opticians. Who, you know, in Connecticut, there's a requirement for a 4,000-hour apprenticeship. We've got an applicant right now who had an apprenticeship in another state for 3,000 hours. And they've been working for like 20 years as an optician safely in another state. And the requirements in Connecticut right now do not line up with this person's experience. So it's not going to be a huge influx, I don't think, of people, but it will help certain categories of professions, particularly those that are not the highest risk, you know, like, you know, we don't want unqualified physicians, but for some of those professions where they're not regulated in every state and there's a hodgepodge of requirements to become licensed, that's really where we'll see the impact.
Great, thank you both. We're going to hear from Representative Pettit and then Senator Huang.
Thank you, Madam Chair, and thank you, Commissioner, for all your hard work, sort of fulfilling the role of the junior resident, the senior resident, the fellow, taking on all tasks. So thank you for working 90 hours a week and always looking for.
Yeah, you didn't include medical student in that list, Representative Pettit.
We're making you still have to do Scott work. Okay. On 6449, I think that's critical. So hopefully we'll move forward, and I think you're in agreement with that. I still serve on a credentialing committee, and we are credentialing people from all over the country on a regular basis for teleradiology, teleneurology, a variety of things that can be done online. So that would certainly make the credentialing, I think, easier and safer. And I assume you're completely in favor of sort of the interstate compact kind of idea.
Yes, sir.
And secondly, the thing I get the most questions on is 6424 in terms of access to information, and the concerns, as you won't be surprised to hear, are privacy concerns. So the questions I typically get, and I don't know if you or someone in your group can give give sort of an overview. Who has access to the records when they have access to, say, my medical record? Is it just to lab results or pathology results, or can they get in and read my entire record, my social history, my family history, other issues? And typically, is it always identified ID or is it de-identified ID? These are, for the people who are watching, those are the questions that when people are concerned about this, they ask about an entity such as DPH accessing their records. So I wonder if someone on your staff could allay some of the fears and let people know how you go forward with that kind of process.
Yes, and just to be clear, you're talking about 6489, Representative Pettit, the medical records access electronic.
Correct. I think I said 6424, 6489. Yeah, getting my sixes mixed up.
Yes. So really important question. And I think it's important for the public to understand that we already have access to these records, as I mentioned, for limited public health purposes. These records are only accessed when they need to be for purposes of disease surveillance, or in the case of the other categories listed here. For example, when we are investigating the very rare case, but very important case of a maternal death, a death after childbirth, when we are doing the work of the tumor registry, and we need to have detailed clinical information, which helps us understand the stage of cancer, the precise diagnoses, et cetera. And for vital records when we are confirming, for example, cause of death, and we need to look at the medical records. So what this legislation does is it merely allows that access to take place electronically rather than to take place, to needing to be physically on site. And as you know, Representative, now since virtually all hospitals are using electronic medical records, they don't really lend themselves to being printed out on paper very easily. So in some cases, we travel on site to the hospital and then are allowed to view the electronic record, or it's printed out for us on site, which is a very inefficient process. But this would be data that under current statute, we already are able to access, but this would allow the access to be electronic.
Thank you, Commissioner. And with the chair's indulgence, I'd like to just go back to a statement made by one of my colleagues early on. I had spoken with some of your staff, and I thank you and DPH in advance for agreeing that we can get together and review some of the data, specifically some of the vaccine data, so as we go forward and make decisions on other bills, people are armed with as many of the facts as possible to make an appropriate decision. So I thank you and your staff for agreeing to meet and discuss those issues. And that's all I have. Thank you, Madam Chair.
Do that, Representative. Thank you.
Thank you.
Thank you, Representative. Senator Huang.
Thank you, Madam Chair. Commissioner Gifford, I want to thank you and extend my gratitude from myself and all the people in my district for your leadership and grace during these very difficult times. We may have challenges and exchanges where, for me as a representative, I am sometimes voicing the frustration and the challenges of constituents. But I have to tell you from the bottom of my heart, my gratitude and appreciation to the work that you've done. It's truly impressive. And to add to it a dual commissioner role, there must be 10 of you for the remarkable work that you're doing. And it is not to be said without the grace that you demonstrate as well. And it's comforting for many people that see your leadership. So I wanted to offer that and really reiterate how grateful I am of your service to our state. So first and foremost, thank you.
I appreciate that, Senator, very much. And I might be off in the public face, but there is a very large team of very dedicated, very skilled, and very hardworking people at VSS and DPH working alongside me. So I appreciate the kind words, and I know that they apply to those teams as well.
And I appreciate you saying that reinforces the grace that I've described of you as, and sometimes our exchanges with your staff aren't always the most engaging, and because we're hearing so much of the frustration in these difficult times. So I wanted to also extend to your staff that as much as we may call and extend our frustrations, that ultimately we're really grateful of their work.
Talk to today. And we're going to.
Yeah, can you please mute your, thank you.
So let me get to Bill 6450, which is the governor's recommendation on the issue of public health. Obviously, I think you're going to get great support and acknowledgement that the banning of flavored products are an important public health consideration. I fully support that. We may have some businesses that challenge that dynamic, but for me, and on a policy basis on public health, I fully support your statements that you made. So I'm going to pivot again, like I did with the commissioner in Demas, is the fact that obviously, as a public health leader and advocate and a voice, do you have any thoughts to share with this committee in relations to the public health impact, not monetary, but the public health impact of potential recreational marijuana legalization? I know I may be a one-trick pony on this, but it really is important that the two major committees related to addiction services and public health should have a much larger voice as we talk about this. It shouldn't be about money all the time, but what are your thoughts on that? I would really welcome your perspective of how we approach this from a public health and safety issue.
Madam Chair, could I raise a small point of order if it's acceptable to you? Is that a bill? I may have missed the opening of this meeting, but is
Sir Haskell, you did miss the earlier conversation about germane discussions.
Okay.
I will allow, but I do have the discretion to cut it off if it goes too long.
I appreciate that. We had that conversation earlier, Madam Chair.
Go ahead, Commissioner.
Senator, I appreciate the question. And I'm glad that I'm able to follow my colleague from Demas, because I think her response illustrated that the two departments will work collaboratively in areas of education, prevention, and monitoring. And I think those components are acknowledged in the proposal, and we will continue to work on those things. We acknowledge, the importance of education, as Commissioner Delphin-Rittman said. We acknowledge some of the importance of some of the constraints that are articulated in the legislation, and the resources that are provided to DPH for surveillance and monitoring, and the partnership with Demas. So I think we are in lockstep in terms of moving forward on those elements should the bill become law.
Thank you, and I appreciate the emphasis on education and prevention, without a doubt, absolutely. But from a public health and development basis, I still vividly remember learning the history that maybe even 60 years ago, tobacco smoking was considered health enhancing. Obviously, we know that to be incorrect, and we have all been unified in addressing that it is a public health hazard concern. So I ask that not from a standpoint of education and prevention, but from a public health, a medical perspective in regards to the potential of legalization. And the challenge that you have from an inconsistency of it still being a federally controlled substance under statute. So, but for me, most importantly, I wanted to get the expertise from a public health and the potential impact on development, brain development, and youth impact to addiction.
Senator, I think one advantage we have as a state that's not the first out of the gate here in proposing this is to learn from the experiences in other states and ways that we would want to approach legalization that may be different from the way that Colorado or other states approached it because of some of the issues that you're bringing up. So we fully intend to look at those issues, adjust our strategies and approaches, and make sure that we don't make trade-offs that would adversely impact public. Thank you.
Well, I thank you for the opportunity, and I hope we'll have further discussions about that. But let me close by saying again, Dr. Gifford, from the bottom of my heart, and for all the residents of my district, I want to extend my thank you and gratitude for you and your entire department's work in these very difficult COVID-19 dynamics. So thank you, Dr. Gifford, and thank you, Madam Chair.
Thank
You're
you.
welcome, Senator.
Next from Representative Zupkis, followed by Representative Carpino. Representative?
Thank you, Madam Chair. Good morning, Commissioner. And I too echo what Senator Wong just said about your grace and your hard work and all of your team. So thank you for working so hard for the citizens of Connecticut. I do have a question on bill number 6488. And in a section, it says that the hospitals shall print the top 15 languages spoken in the state. And in some communities, there's only a couple of languages spoken. Right now, they're, I guess, in former federal legislation, but there's always been in the hospitals that I'm close to do a tagline to guide people on how to get any language they need. So in talking with some of the hospital systems, I think to say they shall print the top 15 languages is really a burden on them when there may not be 15, 10 languages spoken.
Representative, I apologize. You said 6488.
Yes.
Which is not on, can you clarify which legislation you're referring to?
It is concerning the Office of Health Strategies recommendations regarding various revisions to hospital or health systems.
Yeah, could I defer on that to my colleague at the Office of Health Strategy?
Sure.
Thank you. Unless one of my team, Bree or others, wants to pipe in there, I'm not sure that that's a DPH issue. Am I clear on that, Bree?
Commissioner, you are correct.
Okay.
That is a bill that is authored by the Office of Health Strategy. So Representative, thank you. We would appreciate you direct those questions to Vicki Veltri.
Okay, I will. I didn't see, hopefully they're testifying today, but thank you. I will do that.
All right. Are you all set,
I'm
Representative?
all set. Thank you.
And Vicki Veltri is scheduled to testify. Representative Carpino.
Thank you, ma'am. Commissioner, I'm going to ask you about the newborn infant health screening bill 847. There's a quirky line in here. I was just hoping you can help me understand. It's 19 and 20, and I'll read it to you because it's very short. It says the test shall be administered as soon after birth as is medically appropriate. Language comes in and out, and it says, and subject to the approval of the Secretary of the Office of Policy and Management. And unless I'm reading it wrong, and I don't think I am, I'm trying to understand why the Secretary of OPM would be involved. If you can comment.
I'm looking.
And I always admit to perhaps not having the most current draft, but what I'm looking at seems a little odd.
Right. So there's language. It appears that the language is deleted that says the test shall be administered as soon after birth as is medically appropriate. And that clause, and subject to the approval of the Secretary of OPM, then would follow the previous sentence. So it would read as prescribed by the Commissioner of Public Health and subject to the approval of the Secretary of Office and Policy and Management.
Exactly. That's exactly how I'm reading it. So I'm looking for some explanation as to why the Secretary of OPM, who is traditionally versed in finances, would be making decisions with DPH as to what newborn screening tests we'll be looking at in the state of Connecticut.
Yeah, I think that's merely refers to the fact that when a new test would be added There would be consultation because of the financial implications of adding that to our newborn screening program. That there would be the usual collaboration with the Office of Policy and Management on that issue. I don't think it's meant to imply that OPM would be making the public health decision about which newborn screening tests would be appropriate.
Sure. And I'm going to push you on this because this is really important because I think we're setting bad precedent. We're adding OPM to this. And if we're talking about who should have the final say about which tests and an open and honest discussion about the costs, I'm curious as to why we're adding OPM to DPH. If we're going to be adding somebody else, why isn't it this committee and the chairs? Can you speak a little as to why OPM particularly is being added?
Again, I understand your question, Representative. I think it's routine that as the agencies implement policies that have fiscal implications, we do so in partnership with colleagues at OPM, and that's merely what that language is referring to.
And thank you, Commissioner. And I appreciate your explanation, but I will let my committee members know that I think we are setting very bad precedent by having OPM involved, not only in statute, as blatant as this, but in making these public health decisions. And if it's going to be anybody, it should be this General Assembly. Thank you, Commissioner. And I think, thank you, Madam Chair. I'm not sure who is in control. Thank you, Representative Gilchrist, if it is you.
It is. Thank you, Representative. Senator Abrams.
Hi, it is Representative Gilchrist. I just wanted to get on quickly just to thank you, Commissioner, for bringing these bills forward. And I think it epitomizes the incredible job that you and the whole department has done, not only in your leadership through the pandemic, but keeping business going. And I think these bills all speak to that, as well as some other bills that we'll have coming forward to look at what's happened in nursing homes and other areas of public health. So I just wanted to take this opportunity to highlight that and to thank you and your entire department for the incredible work that you've done. I was watching, as you know, our new Secretary of Education is a fellow Meridanite, and we're so excited about that. And yesterday, when he was being sworn in by our Vice President, she made a comment to him about the fact that, you know, he would be affecting so many lives, and there are so many people that would benefit from his work, and they might never know who he is. And I just thought of you in that same regard, and your staff, that there are people in our state who might not know who you are and who all these staff members are, but you've done an incredible job and that benefits all of us. So thank you so much.
Yeah, you're very kind, Senator. Thank you.
Well, thank you, Commissioner, and thank you, DPH team. I don't see any other hands. I hope you have a great afternoon.
Thank you very much.
We have gone past the first hour, so now we will go between public and state officials. And so we are now going to hear from, I had it a second ago, Sal Luciano, followed by Johnny Dock. Sal with us? Sal, are you with us? All right, then we'll go to Johnny Dock to give Sal a little more time.
Great, can everyone hear me?
Yes, go right ahead.
Thank you, Vice Chair Gilchrist. Good morning, members of the committee. I'm Johnny Dock. I'm Governor Lamont's Policy Director, and I'm here to speak on 6449 and to support the governor's proposal to expand economic opportunity. As most of you know, the governor's first priority is getting Connecticut's economy growing again and making sure it's an economy that works for everyone. And that means talking about licenses, because 25% of the workers in our economy need a state license to earn a living, up from about 5% in 1950 and more than in any other New England or mid-Atlantic state. DPH alone issues about 250,000 licenses, and some of you on the committee hold one of those. Our guide to licenses and the inspiration for this proposal is the Obama administration's comprehensive report on the costs and benefits of those licenses. And you'll have an opportunity to question one of that report's authors, Ryan Nunn, today. The report found that licenses benefit public health and safety as well as consumer confidence, but also that they impose costs. Among other things, they create barriers to entry that deter low-income people who tend to be women or people of color from middle-class jobs. And they create barriers to interstate mobility that make life more difficult for those like military families who have to move between states and discourage others from moving at all. Members of families with licensed professions are basically as likely to move around inside a state, but somewhere between a quarter or a third less likely to move across state lines. And it's not that they're applying and being denied by our licensing boards, it's that they're being deterred from applying in the first place. They're missing from our data as well as from the streets of Connecticut. And so the Obama administration recommended that states harmonize licensing requirements and form interstate compacts that make it easier to move. And this bill is Connecticut's opportunity to act on those recommendations. It's also Connecticut's opportunity to learn two of the lessons of COVID-19, which is that a mobile healthcare workforce is critical to crisis response, and that healthcare workers can be mobilized across state lines in ways that not only protect patients, but actually improve care. So what would the bill do? Section 1 is the heart of it. It makes licenses more portable between states. You can take it from a transplant like me. Connecticut's an incredible place to live and to work and to feel welcome. And we believe that every person who moves here not only benefits from life in Connecticut, but also makes life richer here for the rest of us. Those new residents are new customers for our small businesses, newly vibrant neighborhoods and communities for ourselves and our children. But too often, people who are considering a new life in Connecticut have to navigate intricate or job-specific requirements to determine whether calling Connecticut home is even an option. And in too many cases, our agencies can only recognize your license if you're from a state that has initial education and training requirements similar to or higher than Connecticut's, no matter how many years you've spent mastering your skills on the job. So this section and a parallel section pending before the General Law Committee would fix that. Together, they applied occupations from architects and accountants to veterinarians and vascular surgeons, and they would allow new residents as well as military spouses with licenses from other states in the US to apply for a license here in Connecticut, subject to certain safeguards. One safeguard is they have to have a license from that other state. There's no evidence I'm aware of that lax licensure rules lead to worse public health outcomes anywhere in the United States. The second safeguard is they're going to have to take and pass the Connecticut test, unless the department determines they've already taken a comparable one. Tests are what make sure that people have the skills to do the job and have mastered any Connecticut-specific knowledge required to do the job here. There are paths in our statute to licensure without examination, but this is not one. Also, you have to have really moved here. We borrow a definition of resident from the state income tax code. And finally, the department will be able to choose the practice level and to deny licenses in the best interests of the state. Similar language has been passed by unanimous vote or bipartisan majorities in other states across the country. And there's a nice rundown of that legislation by the National Conference of State Legislatures that you can find linked in our written testimony. If the language were passed here, it would augment the current patchwork of job-specific licensing requirements with a clear and consistent and welcoming policy that you and I could explain without paging through different chapters of the CGS. It's a modest but an important change that we think will make it easier to attract workers and employers here to Connecticut. And I say modest because our boards are mostly in the business already of admitting and not denying people, and because the most sensitive license types, as the commissioner referenced, are standard across the country. But this would address technicalities that sometimes prevent interstate recognition, and it would allow us to send a clear signal to people that if they move here, there's a good chance that their license will be able to move here too. Sections 2 and 3 are study bills on compacts and the best practices.
Sorry, you hit your time limit. If you wouldn't mind concluding your remarks.
I'd be happy to. Together we think these changes, including the results of the studies, will benefit licensees, aspiring Connecticut residents, the state as a whole, and I look forward to the opportunity to discuss them with the committee.
Thank you so much, Mr. Dock. Good to see you. I have a question. Having worked on with the Department of Public Health, the licensure of nail technicians, I saw firsthand how Connecticut not having a license denied those professionals from transferring their work skills to other states. but also working with a variety of entities on potential new licenses. I'm wondering, going forward in the state, will this bill allow for additional conversations later on about interstate licensure compacts? Or do you see us in the future deferring to what other states are doing in terms of their licensure?
Thank you. Thank you very much for the question and for your prior work on these issues that I know have been valued by the department and valued by a lot of constituents across Connecticut. This is not intended to reduce Connecticut's future ability to license occupations or to examine the standards or testings required for current licenses. As I said at the top, this is a balancing act, right? There are benefits and there are costs to licenses, and we need to look at those on a case-specific basis, both as it applies to our current licenses and other professions. But I do think that trusting other states to strike that balance and sort of backstopping that with the Connecticut specific test and the department's discretion will help us strike that right balance here in Connecticut.
Great, thank you. We have a few hands. Senator Haskell, followed by Representative Steinberg.
Thanks so much, Madam Chair. Mr. Dock, great to see you, and thanks for taking the time to testify before our committee today. Just two very quick questions for you. We've got a similar bill regarding licensure in the Higher Education Committee, and I was really struck by feedback I heard from the Department of Defense that this is an issue that particularly impacts military families, given that they are often moving between states and the spouses of service members often have trouble finding employment in that new state. I just wanted to see if that's something you'd considered as the governor put forward this legislation, and if you had any thoughts to add to that.
Yeah, thank you, Senator, and thank you for tackling this issue in the Higher Education Committee as well. That's critical to what's happening here, and it's one of the issues that's specifically highlighted in the Obama administration report. I apologize to the committee that my colleagues, Bob Ross, the executive director of our Office of Military Affairs, and General Yvonne from the Guard, did not have the ability to appear before you in person today. There will be written testimony from them in the record, although it is not up yet, and there will also be written testimony from the U.S. Department of Defense, because as you referenced, this is an issue that's critical to military families. It's critical under U.S. statute to DoD's decisions about what bases to keep and to open, and it's critical to national security, because it affects military decisions, military families' decisions to remain in the military. And it's an issue on which, as Bob Ross testified in General Law last week, Connecticut sometimes sadly underperforms. It's important because 35% of military spouses work in licensed occupations. Those spouses are overwhelmingly women, and their families are 10 times more likely to have moved across state lines in the last year than their civilian counterparts. And so these interstate barriers to licensure contribute to an employment rate pre-pandemic that was 4 times higher for military spouses than for the population at large, almost 16%. This bill is an important opportunity to do something about that here in Connecticut that'll benefit those families, national security, and the Connecticut economy. And I'm sure my colleagues in those departments, if you have questions you're not able to ask them today, would be more than happy to spend time with you after the fact.
That's incredibly helpful to know. It. Anything we can do to help military families in my book is a good thing, and it makes me even more eager to support this legislation. If the chair will allow just one more question, Mr. Dock. You've mentioned today that there's a report from the Obama administration that endorsed and actually suggested some of these changes. That goes against something that I've been hearing from folks about this legislation and other bills in the building, that this is somehow sort of a Koch brothers fueled conservative effort to undo the progress and the importance of licensure. I just wanted to give you an opportunity to try to reconcile those two things. Is this something that the Obama administration proposed, or is it something that is fueled by sort of right-wing super PACs?
We come at this from the Lamont administration because it's something the Obama administration has proposed and recommended in no uncertain terms. And the suggestion that we were doing it at the behest of Koch Industries was a surprise to me because I've been quite open about our reliance on that report. I think it would be a surprise to the Obama administration officials who wrote that report, including Jason Furman, the chair of the Council of Economic Advisors and a former Obama administration cabinet member who testified in General Law last week, a surprise to Jennifer Hunt, now a professor at Rutgers, but then the chief economist at the U.S. Department of Labor under President Obama, who testified in General Law last week. Her written testimony is available up under 6445. And I think it would be a surprise to the states around the country that have passed versions of this bill with unanimous or bipartisan majorities, including in Colorado, where it was championed by a Democratic governor, passed unanimously through chambers that are dominated in both cases by Democrats. But that's not to say the Koch brothers don't support it. I haven't read their materials on it in depth myself, but I think the fact that there are members of both sides of the aisle who recognize that there are costs and benefits to occupational licensing, and we need to preserve those benefits while mitigating the costs, including the barriers to entry and to interstate mobility, suggests that, as we've seen in those other states, this is an issue where bipartisan progress is possible, and I'm hopeful we can copy that progress here in Connecticut. I think it'll make a big difference to individuals. I think it'll make a big difference to the state's economy, and I think it'll make a particularly big difference to individuals who don't have the privilege to navigate the current and complex systems for transferring their license from state to state. Complex systems privilege people who have the ability to navigate them, and having a system that is predictable, easy to explain, will make it easy for practitioners who may be a little less well-versed in the art of coming before state boards to do so and to come live in Connecticut.
Well, that's really helpful to know. Thank you so much, Mr. Dock, for your time and for your testimony. I think I read in your testimony that we've got a higher percentage of occupations that are subject to licensure than any other state in New England or in the Mid-Atlantic. And in my mind, of course, some of our neighbors are governed by Republicans, but many of them are governed by Democrats. So hopefully this is an area for bipartisan agreement where we can look to our neighboring states and follow their example. Thank you so much for your time today. Thank you, Madam Chair.
Thank you, Senator. Representative Steinberg.
Thank you, Madam Chair, and thank you for your testimony today. I'll start by apologizing. I am toggling between two public hearings and trying to listen out of one ear, so I've already got a headache and I may have missed your comments earlier. Do you have a sense of the order of magnitude benefit to the state of Connecticut by passing such a law? Particularly, we're concerned in public health with problems with access to certain specialty areas. Do we expect that this will actually enhance the ability to bring in some highly skilled workers in areas of need here in the state of Connecticut?
So thanks for the question, Representative, and thanks for doing double duty on behalf of the people of Connecticut today. We all appreciate that, and I appreciate your paying attention here while you can. You know, I think if you saw the governor's press conference last week, for the first time in a generation, really, tens of thousands of families, including young families, have been spurred by this pandemic to look at life in Connecticut. And to the extent we can make it easier for members of those families with licensed professions to come work here, we could see thousands of more families considering Connecticut. That's good for our state as a whole. It's good for consumers in the state. And it's good in certain professions that are facing shortages. You know, if there's a glut of workers in a particular industry, I don't think people are going to move to Connecticut to try to apply for jobs that are full or don't exist. But if there are places where we need to hire, and we can make it easier for skilled workers from other states who pass Connecticut test to come and serve here as members of our community, as new residents of our state, that's good for consumers because it'll expand access to care. And it's good for workers who may be currently overburdened in professions facing shortages.
Well, thank you for that answer. I hope we do actually attract some workers who would help us deal with some of our access gaps here in the state. Just one last question, Madam Chair, if I might. You reached your minute limit before you really commented on sections 2 or 3. Was there anything else you wanted to add, just so we can get it into the record?
Thank you for that opportunity, and I'm happy to take specific questions on those as well. You know, section 2 is about interstate compacts. Again, that's a specific recommendation that comes out of the Obama administration report. Since that report has been issued, there are a growing number of interstate compacts, particularly in the healthcare professions. Those compacts are different from compact to compact, and that's why we think it makes sense to pull together working groups through the Department of Health that involve the licensing board, professional associations, labor unions, other representatives, to make sure that each compact would make sense in the Connecticut context. But my strong hunch is that at least some of them will. Connecticut is one of only 8 states in America that is not party to a single compact. They exist for nurses, for physicians, for psychologists, for physical therapists, for EMS. And I know there's particular interest here in Connecticut from the Psychologist Association in seeing Connecticut join PsyPact this year. And so the department and I have been spending time with the experts behind that compact to kick the tires on it here in Connecticut.
Thank you for that, and particularly focusing on PsyPact. We've actually received some testimony suggesting that it could make a significant difference in an area where we know we have access issues. So that's a perfect example of how this may benefit us here in the state of Connecticut from a public health standpoint. Thank you, Madam Chair.
Thank you, Representative. And thank you, Mr. Dock. I don't see any other hands. Thank you for your testimony and your time.
Thank you very much for the opportunity to be here today. And of course, the administration is always available to you all after the fact for follow-up questions. We appreciate it, and we look forward to working with you as this moves forward.
Wonderful. Thank you. Next, we'll hear from Sal Luciano, followed by Myriad Painter. Sal, go right ahead.
Hello.
Hello.
Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Sal Luciano, and I'm proud to serve as president of the Connecticut AFL-CIO, a federation of hundreds of local unions representing more than 220,000 workers. The American Legislative Exchange Council, ALEC, with its own deep connections to the Koch network, has been a willing accomplice to this type of bill. ALEC has written a model bill for legislators to copy and paste in state capitals around the country. Their, quote, model Interstate Mobility and Universal Recognition Occupational Licensing Act has recently passed wholly or in part in a handful of states, including Arizona, Colorado, Utah, Idaho, Missouri, Montana, and Iowa. Now you have it before you in House Bill 6449. Section 1 of House Bill 6449 is from Section 110.02 of ALEC's model bill. The link is in my written testimony that I handed to you. While we understand the intent of the legislation is to streamline licensing and professional occupations and facilitate license reciprocity between states, we should be careful about making changes to standards without significant discussion and input from all vested stakeholders. That did not occur. Further, reciprocality should be reserved for states with preparation standards similar to those in Connecticut. The bill seems to be written in reverse. It seems logical that the Department of Public Health should first do its due diligence about exploring the feasibility of joining interstate licensure compacts and adopting national competency exams as sections 2 and 3 require. EPH is required to complete its review and report by January 15th, 2022, yet the effective date of section 1 is October 1st, 2021. It is irresponsible to weaken reciprocity standards without first hearing DPH's findings with regards to sections 2 and 3. So I would hope that they would do the study first. The similarity, but there is no real similarity between what Barack Obama's administration has pushed. They have pushed against needless, useless licensing, as do we. Let that study happen. Thank you.
Thank you, Mr. Luciano. I don't see any hands. Thank you for your testimony today.
Thank you.
Next, we will hear from Myriad Painter.
Good morning.
Good morning.
Good morning, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Myriad Painter, and I am the State Long-Term Care Ombudsman. Thank you for the opportunity to offer you testimony today on Senate Bill 922, an act concerning revisions to the statutes pertaining to discharges in residential care homes, which is before you today. I support this bill because it offers enhanced protections for residents we currently serve living in residential care homes. Requiring notice to our program will allow the opportunity for regional ombudsmen to intervene and to facilitate conversations between the parties, if given permission. When we do that, we find we often have the opportunity to resolve issues and concerns, potentially staying the discharge. If we're not able to find a resolution, the plan now would be given to the resident, and it would offer the opportunity for the resident to really review the plan, see if it's appropriate, and if not, have the right to appeal that plan. We also think it is very important that if aggrieved by the final decision by the commissioner, that the resident can make the appeal to the Superior Court. This language provides what we see as necessary protections for potentially an individual losing their home. We're actively working in our state with the partners and the industry to find a balance between independence and individualized supports. And it's going to be really important that we have and continue to support our residential care homes as we move forward. We need them as a component of our long-term care service and support system. This is one step in that direction to help them become home and community-based qualified settings. By doing this, we will be able to have enhanced services that will be a stabilizing factor for these individuals. They can support the individual as well as the care team members trying to offer them assistance. I believe moving in this direction will reduce the need for involuntary discharges and therefore really improve the quality of life for these individuals. So thank you, and I'm available if you have any questions.
Thank you, Ms. Painter. I don't see any hands raised. Thank you for your time and your testimony.
Thank you.
Next, we are going to hear from Kathleen Callahan. Kathleen, go right ahead.
Good afternoon, honorable chairpersons, ranking members, vice chairs, and all other members of the Public Health Committee. My name is Kathleen Callahan, a resident of Stratford and the Community Programming and Development Lead at the Connecticut Women's Consortium in Hamden. I'm also the chair of the National Association of Social Workers, Connecticut Chapters, Education and Legislative Action Network. Sorry, just running out with my dogs and trying to get here on time. I am testifying on behalf of the chapter, which represents over 2,300 members. We call upon the Public Health Committee to support HB 6424, an act revising data collection requirements for healthcare providers connecting to the statewide health information exchange. I've submitted my full testimony for your review and will provide a brief version now. The legislative agenda of NASW Connecticut emphasizes advancing racial, economic, and social justice by promoting anti-racist policies and culturally responsive practices in all aspects of community life, including access to health services. Additionally, we support legislation that specifically promotes elimination of inequities and disparities. We believe the collection of race, ethnicity, and language data is critical to identify and evaluate health disparities in access, treatment, and outcomes, inform targeted interventions, and support systemic change that addresses the issues and ensures health equity for all residents. A recent report commissioned by the Connecticut Health Foundation highlights major race and ethnicity disparities, whereby people of color are more likely living in poor health, and for Black residents, dying younger. Socioeconomic factors play a role with accessibility, but when analyzing the outcomes, the report also implicates disparate treatment within the care system, as well as the psychological impact of racial trauma. The COVID-19 pandemic has only worsened this health divide, with people of color in Connecticut bearing a disproportionate burden of illness and death. Race and ethnicity data are necessary, whether during this crisis or the next, to ensure that resources are targeted to the hardest hit communities. We fully support the inclusion of language collection as necessary to ensure access to care, promote culturally responsive practices, and prevent discrimination based on national origin or limited English proficiency. Social workers are diverse, skilled professionals with multiple skills along a broad continuum of practice, individual, family, community, and system levels. We consistently leverage data to inform interventions and evaluate outcomes. Of high importance to social workers, an individual's healthcare data will remain private, protected, and confidential, while the addition of self-reported race, ethnicity, and language data will help identify trends that are essential to understanding and eliminating inequities and disparities. In closing, NASW Connecticut urges the committee to vote in favor of HB 6424. Thank you for your consideration and your time.
Thank you, Ms. Callahan, and I apologize for the dog in the background. Thank you for all you do on behalf of the state through National Association of Social Workers. There's working from home. I do see a hand raised. Representative Foster.
Yes.
Thank you so much for allowing me the opportunity to ask a question, Representative Gilchrist. I am really excited about the idea of this proposal and the type of data that be collected, but I was wondering if you could spend just a brief minute talking about what type of tailored or altered change interventions you, from a social work perspective, you think might be necessary and this data would help inform? I know from like my expertise as a dietitian, there's often programs that can be tailored by race, ethnicity, language, and have significantly more robust outcomes with behavioral weight loss interventions. But I was wondering if you could sort of talk a little bit about it from a social work perspective.
Yes, absolutely. And again, there's the all different levels, you know, the clinical, the micro level, the meso level through the community, and then macro through the systems level. So there's different answers for that. But you know, I think about the health data where it can identify and address differences in care and also optimal interventions for people. So we're thinking about a clinical intervention with a licensed social worker, that some models don't work with different populations, you know, and the data would show that if someone is dropping out of treatment earlier or not coming back, that it possibly is because the intervention itself was created for a different population. So that's specifically clinically that happens. There's also the basic needs in communities. So the data can be compared and matched with food insecurity, transportation, all different basic needs and rights that people may not be receiving based on this data. So matching it with other things so we can develop more patient-centered, and especially with the language, there's an opportunity where people aren't even getting the information to know how to access the systems. And I think of COVID now too, without having internet, possibly being able to sign up, trying to sign up for vaccinations, we'll get this data in, and that data will be available to other people, the health data, and compare it and use with other data.
I appreciate that. So it's interesting because I think a lot of times there are folks who think they hear like, oh, we're going to collect data and then we're going to propose additional interventions. But I think that something that's commonly overlooked as we talk about having appropriate data is that you might identify that an intervention that has a significant cost isn't working in a specific area, and you could actually find opportunities to save money and improve programming by understanding better populations that are being well served or not well served. And so I think it's not only best practice from a healthcare standpoint and from a public health standpoint, but also it's economically responsible to understand what's working well for who and making sure you're tailoring programs appropriately.
Absolutely. And I just want to add that, like, recognizing the intersection of complex needs, which this data will help show, that's resulting from the inequities and disparities, exposure to racial trauma, and multiple barriers to support and care. It's collecting this data, we would be able to decide that we're not providing, you know, and we'll be able to measure if practices are providing culturally competent care. And also in social work, we use the person and environment perspective. So potentially individuals may be okay, but when you bring it out to their environment, there are other issues associated. So it's a complex, it's not just individuals, it's not just community, but the mix of the two would be able to see and measure whether we're providing the care that is needed, especially with COVID now. You know, that's highlighted something we've known for a very long time.
Thank you so much for your work that you do and for testifying. I appreciate your answers.
Thank you very much, Representative.
Thank you, Representative. And thank you, Ms. Callahan. I don't see any other hands raised. Thank you for your time. And your testimony.
Thank you very much, all. Have a good day.
You too. Next, we'll hear from Representative Winkler, followed by Ryan Noon.
Yes, thank you. I'll dispense with all the good morning to the chairs, vice chairs, and ranking members. I'm here to speak on Bill 6449. I'm all in favor of interstate compacts, especially if they identify minimum criteria. I'm all in favor of doing something special for the spouses of veterans. But I do have a problem with the idea that if you have a license in another state and 1 year's experience, you can get a license in Connecticut. In my testimony, you'll see that I looked at one criteria for a mental health profession job, and I found that in other states, the requirement for supervised therapy was half, or in one case, a third of what's required in Connecticut. And the question becomes, do the criteria that we've established through the Department of Public Health have any legitimacy whatsoever? If they have no legitimacy whatsoever, then we should just reduce our standards to the lowest in the country and tell everybody that we're open for business. But if they have any legitimacy at all, then we should require that people meet those criteria or some version of them. People say, oh, the year will take care of that, the year of experience. Well, not only is the number of hours not defined in that year, but if you only went 6 months with learning mental health therapy in a supervised situation, and you didn't learn how to handle certain situations, and you run into them in the when you're on your own, and you mishandle them, then the year doesn't really help. You didn't learn in the first place, and now you're just dangerous. So I'm hoping that we can agree that the criteria have some meaning. Now we hear about reciprocity in other states. Massachusetts has reciprocity, and here's their requirements. Written proof, license, good standing. Written proof, the requirements for the license you hold are equivalent or exceed the Massachusetts standards. Written proof that you received a passing score on a particular test. Written proof that you have been actively practicing full-time counseling in mental health for the past 3 years. None of that is in the governor's bill except for the license. It's just a complete, it's like we're saying our standards mean nothing and we're going to dispense with them. And I don't think that's what we should do. Thank you for the opportunity to testify before you today.
Thank you, Representative. I appreciate that, and I will certainly be taking a look at your testimony and we'll follow up. I don't see any hands, so thank you for your testimony and your time.
Thank you.
Next, we'll hear from Ryan Noon. I don't know if I'm pronouncing that correct.
Good morning. Thank you to the chairs and ranking members of the Public Health Committee for the opportunity to testify regarding Bill 6449. I am the Assistant Vice President for Applied Research in the Community Development and Engagement Division at the Federal Reserve Bank of Minneapolis. I'm an economist by training, and one focus of my work has been analysis of labor market institutions, including occupational licensing. My testimony is based on my own research, reading of the academic research on occupational licensing, and many conversations with stakeholders when I was previously a fellow in economic studies at the Brookings Institution, and prior to that, an economist in the US Treasury Department. In that last role, I contributed to the 2015 report on occupational licensing that was issued by the Council of Economic Advisors, Department of Labor, and Department of the Treasury. However, the views I express today are my own and not necessarily those of the Federal Reserve Bank of Minneapolis or anyone else associated with the Federal Reserve System. Appropriately designed and implemented licensure benefits practitioners, consumers, and patients. Most importantly, well-designed licensure can enhance safety when consumers or patients would find it difficult to personally assess the quality of services they receive. But this does not provide a justification for any conceivable licensing restriction. Excessive or poorly designed restrictions can generate a number of costs, including lower employment in the licensed profession, lower wages for practitioners whose activities are unnecessarily limited. And excessive restrictions can even impair public safety if they reduce access to high-quality licensed services. One key aspect of licensure implementation is how it affects practice for professionals who move across state lines. As with most states, it's difficult for professionals moving to Connecticut to seamlessly continue their licensed practice. And this is both a deterrent to the in-migration of workers with valuable skills and an unnecessary obstacle for those who have already moved to Connecticut and are qualified to safely practice their profession. The COVID-19 pandemic has provided a stark demonstration of how important it is to focus on these issues. Throughout the pandemic, medical practitioners from across the US moved to the areas of greatest need at any given moment. In many cases, this was only possible because of the suspension or modification of licensing rules. But even after the pandemic, there will be considerable value to lowering interstate barriers to licensed professionals. And broadly speaking, there are two approaches to improving policy in this area. The first is for a state to unilaterally lower its barriers to those with licenses from other states. The second is to participate in profession-specific interstate compacts. I believe both approaches have merit and indeed can be explored simultaneously, allowing states to reap the benefits of stronger labor markets and improved access to care. Thank you, and I look forward to any questions.
Thank you, Mr. Noon. And I do see a question, Representative Steinberg.
Thank you, Madam Chair, and thank you for your testimony today. You heard the previous witness, I suspect, who expressed some concerns about significant differences in licensing and certification requirements. To your knowledge, having evaluated other states, has this been a problem?
So the best evidence we have about the quality benefits of licensure really pertain to occupations that are universally licensed and that tend to have more harmonized standards across states. So there are very clear quality benefits to many of the healthcare licensure regimes that we have in place, where again the standards don't really differ a whole lot. Where I think the evidence is not there is that there's really any quality diminution from less restrictive requirements when those requirements vary quite a bit across states. And so I would say that I have much less concern on that score.
Thank you. To your knowledge, have any other states put some conditions upon qualification for the reciprocal licensure? In other words, that some body has to ultimately determine whether or not one is eligible, even if they meet the minimum requirements?
So I think there have been a number of approaches taken with the profession-specific interstate compacts. Of course, many years of preparation go into forming those. There are a lot of difficult issues to be resolved along the way, and they do involve those kinds of considerations. I think states that have taken a more unilateral approach across a number of occupations have done a number of different things. Some have imposed stronger, more stringent requirements as to what they'll accept. Some have gone in a different direction. And again, I think that we don't have any strong evidence to suggest that this kind of unilateral recognition is associated with worse quality or worse care outcomes. But we do have evidence that the barriers that exist to interstate practice are associated with pretty substantial reductions in the mobility of licensed professionals. And we believe there are economic distortions associated with that.
Thank you for your answers. We appreciate a perspective from outside the state of Connecticut. Thank you, Madam Chair.
Thank you, Representative. I have a question. And am I pronouncing it correct? Is it Noon?
Ryan Nunn,
okay.
Actually.
Sorry about that. When it comes to the benchmarks that we've outlined, or that the governor's office has outlined in this bill, is the having practiced under such license for at least 1 year, is that something you see across the country in these reciprocities, or does the time vary?
I think the answer is that it does vary. I would have to look a little more closely at exactly the way that it has varied across the state. So unfortunately, I don't have a great answer for that question.
My dog is barking again. If you'd be able to, would you be able to follow up with that information?
Happy to do so.
Wonderful, thank you. I don't see any other questions. Thank you for your time today, Mr. Nunn. Next, we're going
Thank you.
You're welcome. From Vicki Beltry and her team. Vicki, go right ahead.
Good morning. Thank you, Representative Gilchrist, and good morning to the chairs and ranking members and vice chairs of the Public Health Committee. I'm Vicki Beltry. I'm Executive Director of the Office of Health Strategy, and we have at least 5 bills I just want to mention briefly to you today. The first is Governor's Bill 6450. OHS clearly supports the Governor's Bill 6450, but specifically we want to call out sections 7 and 8 of this bill, which relate to OHS. The All Payer Claims Database, which this legislature supported back in 2012, collects health insurance claims across the state of Connecticut, currently holds about 850 million claims. And that database helps us support policymakers and consumers on identifying healthcare trends. It helps us with our certificate of need compliance process, with prescription drug price analyses. Most recently was also used in a pricing analysis for the Rand Corporation. We also use it for our cost estimator and quality scorecard, and other agencies use it. So it's necessary to support that APCD, which is a highly complex technical database. And Section 7 enables the continued support of that database. Section 8 clarifies that support for the Health Information Exchange, which is included in the governor's budget for the Office of Health Strategy, includes a mechanism to file an administrative claim with the federal government by DSS. DSS is a partner with us on the Health Information Exchange. We partner with them on a funding stream that supports the HIE, and we are supporting the HIE through our budget, but we are recouping from the federal government expenditures related to the HIE, and Section 8 operationalizes that recoupment process to return funds to the insurance carriers who help support the HIE. So that's Governor's Bill 6450, which we support. I also want to touch briefly on House Bill 6398. We also support the section to that bill which support DEMIS's setup of an electronic health record. We think this is really important for the reasons that Commissioner Delphine-Rittman laid out. We're excited about it and offer our support to DEMIS in this process, as we think the exchange of health information is critical to overall better healthcare in the state and addressing people's needs. So we are in strong support of that section of those bills. Now, finally, to OHS, which has 3 bills before you today, I want to touch briefly on House Bill 6397. This is a bill that would have incorporated workers' compensation claims into the all-payer claims database. It's important from our perspective that the committee know and understand that the same patients who go through the workers' comp system also are treated daily for healthcare needs. These are the same people that cross both systems. People are injured on the job who have propensity to maybe develop injuries based on their underlying health conditions, and people who are injured on the job may also end up with further health conditions. We thought that by collecting workers' comp data, in addition to healthcare data, that we would have a stronger picture of the healthcare delivery system in the state of Connecticut. So even though workers' comp is really in the purview of the Workers' Comp Commission and property and casualty insurers, we thought it made sense to bring these data sets together. However, I will say in further discussions with the Insurance Association of Connecticut and CBIA and NCCI, which does collect some data for workers, for the property and casualty carriers, we have decided that we are going to pursue probably another option rather than collecting this data directly at a patient level through the APCD. So we are in conversations with them now and wanted to make sure the committee knew that about an approach that will work for both the P&C carriers and the Office of Health Strategy in terms of having a better picture of what we see in healthcare across the state of Connecticut. So finally, to the last 2 bills that are OHS bills, I will turn first to the facility fee bill. So House Bill 6488 makes some changes to a bipartisan bill that was passed several years ago on facility fees. Facility fees are fees that are associated with care that's delivered in hospital outpatient departments and on-campus facilities. This bill only ties to hospital outpatient departments, as the underlying bill did. And it makes some clarifications. It provides, we think, better notice to patients about these facility fees. Last year, $437 million was collected in facility fees across the state of Connecticut, and we continue to see consumers who are confused about whether a facility fee will apply to them in the amount of those fees. So this bill makes some changes on that score. I did hear somebody earlier question notices, in this bill. It was our intent, and I think the language we submitted would have merely asked for taglines for the top 15 languages spoken in the state of Connecticut to provide notice to consumers. We have found, I think, a couple things in the language, so we'll follow up with the committee that we think are maybe different from what we had proposed. That is one of them, and that's an important one. I will say it is very clear that the population of Connecticut speaks dozens of languages. There isn't a county in the state that I think speaks fewer than 10 languages. So it's really important that we get notice to people. The other clarification that this bill makes is that there's a set of codes called Assessment and Management Codes that CMS, the Center for Medicare and Medicaid Services, proposed that is really in the vein of evaluation and management codes. And evaluation and management codes that were tied to facility fees were banned in certain circumstances under our previous bill. This bill just clarifies that. It will not reach that many codes. It only applies to commercial carriers. We cannot obviously touch Medicare, so we would not be telling providers they can't do anything that they could otherwise do under Medicare. But we do think it's important to close that loophole. The bill also clarifies some reporting and the way we would like services to be reported to us. Right now, we get facility fee revenue in a bucket, and it's hard to identify which services specifically facility fees apply to, and we think this bill will clarify that. So between all of that, those are encapsulate the changes in this bill. Like any bill that we've put before you today, we're happy to work with anyone on the bill to make sure it works for all the parties who are affected by it. Finally, the bill that I think is a feature bill from OHS that we've been working on for several years, House Bill 6424, requires that entities that connect to the health information exchange make an effort to collect self-reported data on race, ethnicity, and language. I want to correct a couple of things based on some of the testimony I've seen filed with the committee that I think might be misunderstandings about this bill. First of all, this bill does not require anyone to supply race, ethnicity, and language. It asks the providers to try to collect self-reported information, but it does not require that patients provide it. Secondarily, this bill does not give OHS the authority to collect the data. It gives the Health Information Exchange a tie to providers. Providers are collecting these data. We think it's critical that providers collect these data in a uniform manner. And that's because we have major disparities in the state of Connecticut. Despite being one of the healthiest states in the United States by any rating service, we have deep and ongoing disparities in the state of Connecticut that pre-existed COVID-19, which is why we've been working for years with advocacy organizations, with hospital partners to try to find a path forward to collect these data. Our bill proposes a standard of collection. We are open, obviously, to changes to that standard. We're also open to making this bill as operational as possible for the people who need to participate in it. And that might mean, developing a roadmap, which OHS is committed to achieve the goal of collecting this information. However, we think it's also important in saying that we can't afford to wait to collect this information for years. It's been years in the making, and we really need to get there. So I just want to also mention that the Connecticut Health Foundation had convened a group of people with the Institute for Health Improvement that included our office, included the Health Information Exchange, Connie, and included some of our hospitals and community health centers. And we think we're on a very good path to a roadmap to implement the collection of these data. And we're happy to work with folks to ensure that the language reflects an implementation timeline that's both realistic, but reflects the urgency of collecting the information. Finally, want to commend a couple of the hospitals that I think may have submitted testimony today in support of this bill. OHS has supported several hospitals in the past to collect these data and health centers through a program that we had through a large grant from the Center for Medicare and Medicaid Services. And we commend our hospital partners that took this on, and our health center partners. They've done a fantastic job with it. And what it shows is that the data can be collected in a uniform manner, but now we need to make it happen across the state. And that's what this bill is about. It's about closing gaps. It's about targeting interventions to improve and eliminate disparities. And it's past time that we do it. So with that, I'll conclude my testimony and open myself and my team who's on to questions of the committee. So thank you.
Thank you, Ms. Beltry. Good to see you.
Good to see you too.
We have a few hands raised. Senator Huang, followed by Representative Zupkis.
Thank you, Madam Chair, and welcome, Vicky. I greatly enjoyed talking to you and from your past and regarding the being part of the Office of Healthcare Advocates, and to right now. Your work is invaluable and your passion is to be envied. We all agree, and I'm going to address 6424. We all agree that COVID has created an environment where data and being able to address and target the disparity of care is critical. I just simply wanted to ask this real data. Is it a federal process or is it a state process in regards to how this data collection requirement is undertaken?
So there are a couple ways to look at that. First of all, as a condition of getting federal funds, many providers are required to collect information, and many providers already have collected it. So there's obviously existing requirements tied to technology at the federal level and to the receipt of Medicaid funds or Medicare funds that certain data be collected. So systems have already been collecting some of these data. The challenge has been the lack of uniformity across systems, although many of our hospitals in the state have been collecting it the same way. The state, I think as a state, our position is the data that's being collected is not necessarily deep enough to get us to addressing the kind of disparities we're seeing. So some of the categories are very high level categories. Some of them have detailed categories underneath them. For instance, if you look at the Asian category, if we collected data specifically as Asian, as you know, many countries are included under the category of Asia, right? And there are very different experiences among people in those groups that belong or that come from those countries or whose families come from those countries. So the disaggregation and knowing, a little more detail about the race and ethnicity and language, particularly language of patients that come for healthcare is critical. And we think we need to do more than what the federal government asks. We need to be more robust than what they're asking.
And that raises a question for me. The disaggregation issue has been shown itself to rear its ugly head in data being used in education, in many other sectors that go beyond the intended of this. But it's interesting you say that from a standpoint of categories. So why wouldn't you then disaggregate African-American populations that come from various other countries? Why would you not look at Latino Americans that come from a wide variety of national backgrounds? Why not break it down by Caucasians that come from many countries with many different backgrounds? I think that when you talk about uniformity, to pick one ethnic group or the Asian Pacific population in this point, why would you not look at the African-American population, Caucasian, to disaggregate?
You would. And the short answer to that is you would. And I think the categories
does this program implement these kind of disaggregation for every racial group that you're looking to kind of narrow down on?
So we have a set of, so I guess the answer is going to say it depends on which standard is used, right? So in the program that we funded the hospital sector, the hospitals for and the health centers, we used a set of standards that did break down those categories further. And that's important for the reasons you suggested. And should we come to an agreement, I think, among this committee and other providers, then that kind of information would be seen. So it is not meant to target any one category like Asian versus non-Hispanic or Latino versus Black Americans who may be Caribbean, maybe other things. So we have those categories broken down, and I think we fully intend to explore using those. So I think the short answer is we don't have a specific standard yet. That's the subject of further discussion, I think, among the parties to finalize a bill here, is what is the exact set of standards we want to use? Because the overall importance is uniformity across programs. So there needs to be enough specificity to be able to act on it, but not so much that it's unworkable, unrealizable, or raises some of the concerns you're suggesting. So I think there is a balance, and I think we can strike it.
And that's my point. Is it's interesting that you in your our discussion, the Asian Pacific community came up, maybe because I'm Asian Pacific. But my concern ultimately is, before we go forward, and this bill is proposed to initiate this process, why would we not create that subcategory? Because I think if you do, you will get much more interest in many other racial groups that would offer their context to use the disaggregation and what it means. So I would say, in some ways, without a doubt, data collection to be able to address the needs that are in various communities are absolutely critical, from a social justice, from a access to care and preventive care, absolutely essential. But my point to you is, why are we looking at a narrow band, as we just talked about in this conversation?
And
Why is this bill being proposed without having a broad proposal that encompasses all groups, and so that no group feels though that they are being selectively chosen, and that would allay some of the concerns that you may be hearing and seeing. But if we could, Vicky, be able to submit a proposal under the Real Act data point to make sure that every single racial group is disaggregated, that the Caucasian population would be looking at Scandinavian to South America, that we can get that disaggregation. The fact is, we're pointing out the Asian Pacific community, and you say that, as you said earlier, the vast diversity. Well, I would beg to differ that there's tremendous diversity in our Latino communities. There's tremendous diversity in our Caucasian as well as African American, either they're American born or African based or from different areas of the world that they've been able to migrate to. My concern with this is not about the value, incredible value of data collection, of being able to use this to provide critical health services. My point is on a fairness basis, a respect for various ethnic groups that feel as though that one group versus another, or at least the presentation of one group versus another, is not fairly being evaluated.
So I don't disagree with you, Senator. I guess my point.
We agree a lot, Vicky.
What's actually in the bill does not single out any group. What is in the bill is a potential set of standards that is very broad. What we put in the bill has categories, subcategories among all the populations you suggested. So we have not come to this with the idea that we are targeting one. Obviously, clearly, you know that we're not targeting one specific community. So, but you're right. We have to get to a set of standards. And I think we will. And I don't think it's very difficult to do that, because I think you're going to hear from a lot of people who agree that we can get there. And the standards we put in there actually do that already. But my point in saying where there may be a different set of standards is that I want it to be operational, right? For this to be meaningful, people have to be able to do it. People have to be able to have electronic health records so they can capture information. We have to be able to train providers on how to collect this information. We have to be able to talk to patients about why it's important to collect such information. So there's a lot of detail work that has to go behind it, not just picking the set of standards, but the set of standards that will be picked will address the very issues you brought up, I promise you.
Well, and I appreciate that, and I have complete trust in your belief and your advocacy, without a doubt, Vicky. I think my point is, when you cite the broad parameters, that raises concern. Why are we not indeed narrowing down and giving specific statutory guidelines so there is no broad interpretation? And just on the basis maybe of our first interaction in this is the fact that as we talked about many of the other groups that may be impacted and should be evaluated, that we gravitated to the conversation of the Asian Pacific marketplace. So and I have to share with you that one of the concerns you're going to hear is the fact that we have been, as a racial ethnic group, segmented. Data is used against us, back from the origination of the Exclusionary Act to the current lawsuits against higher educational institutions of Harvard and Yale right now that is exclusionary or disaggregate and single out Asian Pacific Americans. So I beg your forgiveness in the sense that there is a heightened sensitivity that if we are collecting this data and there is no specific guideline and parameter to ensure that no single group is focused on, maybe you think there's an incredible need. I think there's an incredible need for every racial group in this state and in this country to get important health care. So
Right.
I share this with you.
Agree with you completely. I can't disagree with you at all.
Without a doubt, without a doubt.
Right.
So
So-
I think my concern is, unless this is an important bill, and I support the idea, I really do, because there are groups, you and I talked about it, even in the Asian Pacific community. I know there are the Laotians, Cambodians, Hmong population that are significantly underserved, either because of language, comfort with government systems, and we need to get to them. But then there are equally important communities, African-American communities in our in our cities, as well as in our rural area, that don't trust the system. I mean, one of the basic issues here is in our vaccine system, you have a disproportionate African-American population that still have a history of distrust relative to the vaccine system, going all the way back to the Tuskegee experiments. So it doesn't always make sense, but we have to respect people's feelings, people's sensitivity, and past demonstrated governmental action that have had an adverse impact to those racial groups. So when we talk about collecting data, you have every intention. I know you shared about the sense of privacy, and I think you made great effort to emphasize that this data will be protected and it will be only shared for medical data. But there is no guarantee. There is no guarantee, unless you can provide it right now, that this data cannot be used for any other purpose than within the purpose of OHS and healthcare.
Well, that is, I mean, look, you know, there is the potential to alter language or offer language, you know, to specifically say that, right? The goal here is not to identify specific people. Like it's not my job to look at every single patient interaction, right? Our job is to look at what we're seeing systemically, right? When these data are rolled up and you see the level of disparities or gaps in like regions of the state, there are actually protections in law now, right? Around HIPAA, sharing information, around sharing information only at a certain level, a certain number of people. So you cannot identify certain people. The idea is to hotspot, to target places where there is that level of underservice you're talking about, or there are gaps in access, or we're seeing worse outcomes in terms of, as you said, Black residents of Connecticut who have far worse disparities when it comes to diabetes, when it comes to asthma. The thing is, you cannot address these problems unless you collect data, right? We're in agreement on that it's hard to improve what you're not measuring. If you don't measure it, you can't address it. So in some ways, we would create a self-perpetuating problem if we didn't take on this problem of measuring and knowing where there are these pockets of disparities and underservice. We actually have to do it. But I'm in full agreement with you that no one should be targeted. That is clearly not the intent. And if there are safeguards that need to be in place in the bill to ensure that happens, we're open to that, because that is not the intent of this bill, clearly.
And I understand that, but I would also offer that those safeguards need to be in place before this bill is enacted, because the broad interpretation leaves the opening. And let's change the subject matter. Our African-American population has been dramatically impacted, and the disparity of care is quite evident. But have we looked to disaggregate the reason why among the African-American and Latino population?
Yeah, well, that would be part of this work, right? And we do know from anecdote, we know from some public health measures, right? When communities are broken down, even at census level data, you know that there are impacts. That kind of data is already available out there. So we do know there are disparate impacts, even in subpopulations. And that's the kind of thing, in this bill, just to be clear, this is around healthcare and healthcare delivery, right? We know there's implicit bias. We know there are, certain areas where there's inadequate access to care. We know there are language barriers. There are some counties in this state in which 60 languages are spoken. I mean, these problems have to be addressed. Now, I understand where you're coming from on guidelines and having things in place, which we fully agree with, which is let me give you two responses to that. One is, that's why I mentioned this roadmap that we've been working on. We've been trying to evolve the players in the system to ensure that before implementation, things are appropriately set out, safeguards are in place. Secondarily, the mention in our bill of the OMH guidelines, versus let's say OMB, which we could have used. The point there is those are recognized kinds of standards, whether we use those or another set of standards. It's important to have recognized standards that people can agree on and collect uniformly. It would be very difficult, in my opinion, to list categories in statutes because obviously things evolve over time. And what if you want to change something? Now you're not in compliance with the statute the next year because you want to add a category or something like that. By aligning with recognized standards, I think that's the best path forward. I will say some of the systems that have been, obviously people have been collecting this information. Some systems have been collecting more than others, as we noted. Hartford Healthcare, for instance, who I think is on schedule to testify here today, they operationalized a set of standards that we worked with the Health Equity Solutions and Data Haven on. And those standards were created with a huge amount of outreach to communities across the state before they were created to ensure that people were behind them, that they made sense, that they addressed the areas in which we're seeing huge levels of disparities. Then they were incorporated into this grant program that we offered Hartford Healthcare and others. And Hartford Healthcare actually operationalized it and is using it to identify disparities in their populations, to direct resources, for instance, COVID outreach and vaccination sites. That's the kind of thing we're talking about. But you have to have a set of standards, as you said, by which to operate, right? That are agreed upon. And we agree with you.
And
So
I'll make a
that's-
pivot away from racial disaggregation. And
Senator, I'm going to ask also that we try to make this your last question so others may also ask questions. I'm glad to come back to you after that.
Absolutely. Thank you, Mr. Chair. Let's pivot away from racial ethnic groups. Socioeconomic factors are huge factors that impact healthcare as well. So would you then take a look at maybe collecting data for myself as an immigrant, talking about immigration status, non-resident status, because that has potential impact in regards to access to healthcare, comfort, and concerns about that? Would we be looking to look into that and maybe looking at asking the questions of gender identity? Because all of that has dramatic impact on healthcare decision-making and healthcare access. So as we're looking to collect data, are you looking not just at racial disaggregation, but how about socioeconomic factors such as income, immigration status, non-resident status, gender? All of those categories are equally important determinant factors on healthcare access, comfort, and delivery. What would you say to that? Would we be looking to disaggregate that data as well?
So let me just say some of that data is correlated. We know that from census data and from other performance in the system, that often there's intersectional factors there where disparities can be compounded. Let's say if you are African-American and you're gay, you probably have even more challenges coming across your space. We have worked, actually, I will mention to you that in the grant program that I was talking about before that we worked on, we also asked for the collection of sexual orientation and gender identity data. We do think that we're going to have to get there as well because there are disparities, significant disparities on the basis of sexual orientation and gender identity that exist in the system, as well as documentation status, income status. So that could be, part of an ongoing discussion. We chose REL or real data. We think those are particularly dramatic impacts on health status by race, ethnicity, and language. But there is no question that SOGI data, we call it SOGI data, sexual orientation, gender identity. In case anybody else says that in another meeting, you all know now what that is. We talk about SOGI data, and we also talk about income data. The Office of Health Strategy has done a lot of work on an affordability index for the state of Connecticut, and we know very well that income status affects not only affordability of healthcare, but obviously outcomes in healthcare. And we also know documentation status does too. So I would say, stay tuned. We didn't throw that in this bill, but those are also other factors that we think are important.
Well, Vicki, thank you very, very much. I always appreciate talking with you. You're so insightful. And that being said, I want to be clear. I do believe it is absolutely critical for us to be able to have the necessary information to be able to deliver healthcare to the most needed, most vulnerable in our population. So I think the devil's in the details. And obviously, I want to work with you, and I hope we'll have further conversations. And again, thank the chair for the indulgence and the time given. So always a great pleasure. Thank you. Thank you very much.
Thank you, Senator.
Thank you, Mr. Chair.
Thank you, Senator, for your willingness to yield, and we were glad to come back to you at the end if you need. Representative Zupkis, followed by Representative Foster.
Thank you, Mr. Chair, and good morning.
Good morning.
For a little while longer. And first of all, I would just like to say thank you for the work that your office does. I've used it quite often with constituent work, and everybody in your staff has been so helpful. So thank you. I appreciate what you do for sure, and what your staff does, the work y'all do. So I have a couple of questions, and I'll just say I'm not going to go into depth as Senator Huang did, but I do agree with him. Instead of being so broad, we really need to narrow it down and go across the board in all of these subcategories, because there's so many different categories that could be put under each population of or ethnicity or race. So I would encourage that as well. But my questions for you are actually under bill number 6488.
Yes.
And I apologize, I came in late because I've been on another committee meeting, and I came in the middle of you speaking. So if you've already addressed these, I apologize for asking again. However, in a section, it talks about the languages, and that hospitals shall print 15 languages. And every hospital in every community does not have 15 languages. Some could have more. Yeah, I think you mentioned some have 16 and some have less. So to me, that's a burden placed on them that should not be placed on them.
Yeah, let me clarify that, because I actually did address that. And I heard your question before, so I appreciated you asking. I know you asked it of Commissioner Gifford, so.
Yeah, wrong person.
So that's okay. She deferred, which was really nice. So the language we had intended, which I'm not sure made it in the bill, so we're going to follow up with the committee, was taglines, as you were talking about. Right. And we had proposed taglines on purpose because of what you just said. There are languages, and I think I said earlier, there are counties with over 60 languages spoken. 22% of the population, the primary language is not English. And so it's really critical for us to make sure that people get proper notice. So that we propose taglines, we'll go back. But I believe our proposed language included taglines and not a requirement to print it. We don't think that's necessary.
Great, thank you. So that will be taken out, I'm hoping. My second question is regards to lines 226 and 234. And it talks about the number of patients notified, the manner in which they're notified, and the methods of which each patient is notified, and the date on when they were notified. Can you tell me, because it's unclear to me, what the reason is for this information?
I'm just trying to get the lines.
Oh, yeah,
here.
226.
Oh, I've got it. I've got it. Yeah.
Yeah, so it doesn't
26, right?
state
226.
the policy of why this is required. So why
Yeah.
is this information required?
Well, well, right now it's not, and it would be obviously under the proposal. And one of the reasons for that is we keep hearing that people are not notified. So the original bill has a notification in it, and I'm not suggesting the hospitals have not made their best attempt, but we still get many, many people complaining that they have not gotten notified, and then they are surprised by a facility fee bill. It continues to happen. And the language suggests a little stronger compliance or oversight of the notice policy. Now, could that be worked out? Yes. I mean, I think that could be a subject of discussion, as is all bills. As I think I said earlier, I'm happy to work with anybody on language of bills, but it has been a problem for consumers. So while I completely respect the burden it may place on the hospitals, I also am very sensitive to the burden on consumers when they get some of these bills as a surprise. So again, I think that's an area where we could also strike a balance on the language.
Thank you, because I agree with you, and consumers need to know. We just need to come up with a way that it's not so burdensome and, again, over-regulating every little thing that they do. So I would appreciate some conversation on that one. And then my last question is on lines 286, and I have the bill up. I'm going to it also. On 286 to 295. Yep. And it requires detailed information about patients requesting. And I guess it's kind of similar to before, requesting this. And it's how are hospitals supposed to identify which patients are specifically requesting this information, which are not? How is that?
Well, I think the language is, the language is written says that they're supposed to report on people who've contacted them to ask for a reduction. So I guess I would say it's if somebody's asking for a reduction, then they should know that because they're contacting the hospital.
And so again, you would want that reported.
Yes. I think, I mean, we're asking for that and the number of patients who do get the reduction. And that's because some of these fees can be thousands of dollars. And so there are people who request them, and we'd like to know who do, not who, the number, and whether they're being given. And that's because, we need, it's hard to really decipher what a facility fee is. Mm-hmm. There really is not a clear, there isn't like a fee schedule of you had procedure X and therefore the facility fee is B. You had, and we think it's important because we're talking about hundreds of millions of dollars a year that are being collected in these fees that contribute to increased healthcare costs. Now, they may be appropriate. I'm not suggesting they may not be because they're allowed.
Right.
But to sort of decipher what they are and see what the impact is to consumers, I think we need to see that.
And I'm not saying I disagree with you because healthcare is expensive. And, that's a whole nother issue. We could talk hours and hours
talk
about.
All day.
But, I mean, I could see where maybe a patient would ask at registration, maybe they would ask the doctor, maybe they would ask, in so many places. So just logistically, how, not that it might not be important. I'm not saying that. I'm just saying how it all transpires seems like
Well, again, I mean, I think we could discuss it and figure out the best route on how to handle it.
Mm-hmm.
I do think what we're seeing is very impactful to people. So if there is a way for us to kind of refine the language to make it easier, I'm all for that.
Right.
But we still would like to see it because they are so impactful to people.
Great. Well, thank you. Thank you for being generous and trying to get these little quirks worked out. I really appreciate it.
You're welcome. Always open to getting quirks worked out.
Thank you, Representative. I think we all agree that a couple of the points that have been raised here today offer an opportunity for further refinement on these bills, and we're pleased the Commissioner is willing to engage with the committee and maybe others to get them right. So thank you for that, Commissioner. Representative Foster.
Hi, Commissioner. Thank you so much for being here with us today. I really appreciate this effort and your diligence in trying to accomplish this. So I think I know the answer to this, but I think that the context is important for us as a committee to know and understand. So I apologize for asking a question that I think I know the answer to. But is the standard for real data consistent with other data collection efforts in the healthcare sector that exist in evidence-based best practices for understanding health disparities in research that's commonly published?
Yes, so what we put in is consistent with that, and so is OMB. So just to clarify for the committee again, the standards like that's cited in our bill as well as the OMB standard, that's not one standard. When you look at it, it has hundreds of categories, but they're recognized. We would not choose one that we did not think was workable for, researchers and that was evidence-based for use for interventions, which is why I think we're looking at what we propose, potentially what we put in place and the hospital's already collecting, or OMB, which is a federally recognized standard. Those are the standards that I think are easiest to adopt because they are recognized, they're uniform, and they can be translated across sectors. So I'm not sure I answered your question appropriately, but I do like that you asked the question saying, I think I know my own answer because you must be a lawyer. We only ask questions we know the answers to.
I'm not, I'm an academic, but it's a little similar, I suppose. So my one follow-up question to that is, so I'm hearing, and I'm not sure that I understand it, but I'll be sure to follow up with my colleagues on this so I can make sure that I do. But I'm hearing that there's some apprehension about proposals of collecting data because of concerns about aggregation or disaggregation, and perhaps identifying something that might disparately impact in a negative way one group or over another. And so I think it's important, and you can sort of, I'll say what I think the answer is, but and then you can correct me if I'm wrong. But I think that as a society, in the research sector, healthcare sector, policy sector, have all acknowledged that there are social determinants of health that relate to race, ethnicity, language spoken, socioeconomics, country of origin, places that you live in, the built environment in those communities. And that is like well commonly understood in the research. It's not really up for debate in the academic sphere. It's not really up for debate in the medical sector or in the policy space. We know that there's disparities, that the more that we can describe the landscape, the better that we can intervene. Are there occasions where you have known that understanding health disparity has negatively impacted a group? Because I hear that there's concern that could happen, but I'm not familiar with that.
I'm not familiar with that either. I am not.
Okay.
And that is certainly not the intent, but we have not seen that. This is basic information that needs to be known to improve conditions, right? And to address ongoing issues, including structural racism, which we all know exists. So we have not seen any examples of that. I mean, if somebody can point that out to me, I'd be interested in seeing that. But in the healthcare space, I have not seen this. So,
and I think, and I am like speculating here, and I know that there are other folks who will ask questions after me, and I will be certain to follow up with my colleagues to learn a little bit more about their concerns. But I am curious. I wonder. I mean, I think that understanding that it doesn't necessarily. I think maybe perhaps people are worried about reallocation where things are taken away from one group and given to another, and I'm not sure if that is the concern, but that's like, as I try and process what I'm hearing, perhaps a concern. But I do know that when we know more, we can use resources more efficiently. And I think that that's sometimes a missed part in talking about real data and any data really that we could talk about. At knowing and understanding the landscape of where there are challenges, barriers, opportunities for improvement, in the for-profit sector, people talk about like SWOT analysis, like
yes,
strength.
Exactly.
And I think in essence, we sort of need that in the healthcare sector, to look at policy across the board, to look at allocation of resources. And so I guess, I'm sorry that I didn't form this appropriately as a question, but I guess it's helpful for me to know and understand people's concerns, because I think that as Senator Huang put it, like when people are worried about some being disproportionately impacted, that's important. But that's actually one of the main reasons why this data is important, because being worried about having adverse health outcomes in the healthcare sector is a health crisis for communities that receive disparate health care currently. So I guess I will sum by asking if you think that if there's room for improvement in this, that you'd let us know what that is. But if it's following best practices and standards, that's helpful to know.
That is the direction we're going, is following best practices. And I do think, I would love to have a conversation with you. We could talk offline about the kind of work we're doing to address the social determinants, social drivers of healthcare, chief among them racism and other things that affect people's health. Everything affects people's health. So there are improvements across the board that need to be happen on the upstream side to improve healthcare experience and outcomes downstream. And we have a lot of work to do in that space. But I will say, it's true that the government has played a role over time, historically, in enshrining discrimination in some cases, and we have to undo that. But ironically, one of the ways you have to undo it is to know what needs we have to address and how we have to improve. And we need to do that by, in some ways, collecting data. Well, I assure you it will be done in a way that follows.
I think offline is a good way to end this dialogue. I'd like to move on to Senator Summers, followed by Representative Pettit. If you're done, Representative Foster. Very good. Senator Summers.
Thank you, and good morning, and nice to see you, Vicki.
Nice to
I
meet you
have a
too.
question on 6424. I'm not going to give you a speech. I'm just going to ask a question. So, as Senator Wong had indicated, there are certain populations that are uncomfortable with the collection of this data. We all have heard repeatedly about the social determinants and, the positive aspects of collecting data will help us provide better health care and hopefully better health outcomes for those communities that have been discriminated against or do not have access to health care. But I do think that there are certain communities that are extremely uncomfortable with having this data collected for whatever reason, whether it is from the countries they come from, what they have experienced in the past. So, and they do feel singled out, whether we want them to feel that way or not, that's how they feel. And I think that needs to be respected. So my question is, if someone does not want to have this data collected on them, is there a way for them to opt out so their data will not be shared?
Short answer, yes. So at the beginning, when I was testifying, I noted that there's nothing in this bill that requires anyone to provide information that they don't feel comfortable providing. This is about voluntary self-reported data to physicians. So it's not
tell me how that works. Because if I go into a physician's office, am I just checking the boxes, or are they going to ask me the question? And how would somebody know they don't have to fill that out?
You have to tell them. Obviously, that has to be part of the training. And that was done, in the work we've done with the hospitals, right? And this is not a snap process, right? You need to, as I think I said earlier, we need to train providers on how to be sensitive to the issues that have been pointed out here today, but also to train their staff, frontline staff, on how to appropriately talk to patients, explain that it's voluntary, explain why it's being collected so people understand it, and that it's not being collected by OHS. The state is not collecting it. So that has to be part of a process, which is why I think it's really important to work on this roadmap with the clinicians and maybe people affected by it. That's what we think should happen. So we identify the right tools to use and practices so that people understand they don't have to give this information if they don't want to. They're not obligated.
Are you imagining somebody coming into a doctor's office and they would have a form to fill out, like a HIPAA form, giving permission to collect the data? Or would it be the opposite of signing to not allow the data to be collected from the patient?
It could be either. And I think we have to work that. We have to decide what that is. It could
Okay,
be
so
either.
there could be
So,
some,
yeah.
for those communities that are very, very hesitant and very sensitive, and I've heard from so many of them. Do you remember we had a hearing a few years ago where we were packed with folks?
Yes, I remember.
That still
Yes.
has not gone
Yep.
away.
Yep.
So if this bill moves forward, there would be an opportunity for them to opt out at some point. So they
That's
would
correct.
have that as
That's-
a comfort that, hey, if I don't want to be included in this, I don't have to.
That's correct. And that's what happens today. So most people, obviously, if you go into the provider, you're signing forms. Most people are in an opt-out situation. So you don't want to sign it, you don't have to sign it, and you don't have to provide the information. And we would hope that continues. But people do need to be educated, right? Patients need to be educated, providers need to be educated about how the sensitivities around this and the collection. Because for this to work and be meaningful, people have to know how to.
My only other issue with that is that, I've gone to a clinician, you got to sign all these HIPAA forms that you've signed, and you're just kind of blowing through the forms because there's not really, half the time people don't even know what they're signing. I mean, they're like, okay, yeah, whatever. I got some stuff to do. I got to fill this out. There's no conversation about, by the way, your data's all getting collected and blah, 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 blah. So I think that would have to be clear. That could be something that would make certain communities feel more comfortable, but it can't just be a form that somebody signs. And I would rather see it as an opt-in rather than an opt-out. It's like, if you're going to donate your organ, you don't want to have to opt out to donate your organ. You want to be cognizant of making a decision that, yes, I want to opt in. So that's just my two thoughts, but I just wanted to ask that so the communities that are concerned could work on ways where they could feel more comfortable if this data is going to be collected going forward. Thank you.
And thank you. And it's not a simple answer. There needs to be a lot of education. There needs to be a lot of work put into this. This is not.
And I do appreciate all the work that you're doing. And I know it's cumbersome, but we do have to be sensitive to certain communities that are just vehemently opposed to this right now. Thank you.
Yes, of course. Thank you.
Thank you, Senator. And I'll just make a suggestion going forward. Let's try to make sure we don't end up interrupting one another, whether it's the questioner or the speaker, that they get a chance to finish what they're saying. Representative Pettit.
Thank you, Mr. Chairman. Thank you, Vicki. I'm asking a question, slightly different view on it, and I do not know the answer, so I'm looking for education. My previous life and working with the State Medical Society as the chair of the council, I recall the whole HIE concept came in. There's $50 million in federal funding. I thought that once it went forward and was put together, it was going to be self-funding, and now there's $5 or $6 or $7 million in the state budget for this. Do you see that this will need to be a cost going forward, a cost of doing business for the state, or will at some level it somehow be able to become self-funding? That's how I remember the discussion going back a number of years, or maybe my memory's foggy. So I wonder if you could comment on the money aspect of it.
Your memory's not foggy. So there needs to be sustainability planning. There is sustainability planning going on for the HIE going forward. The state cannot be the sole support for the HIE for the future, and everyone knows that. There will always be some level of state funding to the extent that Medicaid patients, right, or patients who are funded, whose care is funded by the state, would be supporting the HIE. So short answer is temporarily, there needs to be a funding stream to support ongoing activity to get to the sustainability path. This path has some funding from the payers. We do think the good thing about that is the payers will get value out of that funding. There's no question. But there needs to be support from the broader community. You're right.
I thank you for that. And just a quick comment, if I may. I hadn't thought about the way that Senator Summers said, but I agree. Opting in makes more sense, because putting another burden on people in busy practices will be very difficult. I don't see a busy practices that'll get done. So I would tend to agree with an opt-in approach. But thank you for your testimony. Thank you, Mr. Chairman.
Thank you.
Thank you, Representative. Before I go back to Senator Wong, if he needs a second time, I just wanted to ask a couple questions of myself. First of all, we've heard a lot of reference today and the good questions that have been asked about your roadmap. Could you just share with us, Commissioner, exactly how what are the milestones here? How do you expect us to get to that point where we can all have confidence in the standards you will establish?
So we've been working with stakeholders on an implementation roadmap for this strategy. I think there's a report that should be coming out shortly about that roadmap that lays out some steps to achieve this goal of collecting the information, and that includes engagement, right? It includes discussion about provider support, particularly for smaller providers who don't have EHRs, electronic health records, and how they're going to get there. It includes things like education of staff and patients. And so I expect the roadmap report to be coming out shortly. I think we're going to have to build in a timeline, which is why I said, even though we have the OMH standards in the bill, I think we're going to have to build in a reasonable time frame for these things that Senator Wong brought up, Senator Summers, Representative Pettit, to be built in to this roadmap to finalize a plan to put in place. But having said that, I don't think we should be looking at a 2-year horizon. Like, we're in a crisis mode, right? We've been in a crisis mode for years. So we need to have a plan in place. I'd like to come back to this committee with our partners, right? With the roadmap and a reasonable time frame, right, to put this all in place. But I will promise you, what I can share with you is a couple things. The standards that we talked about in this morning's discussion, that we have in our bill, and other standards. And I can promise you a copy of the report and let you know how the progress is going on the plan, and come back with a proposal of a reasonable time frame and plan to put this in place.
That sounds great. I think what we've heard here today. It's very important that interested parties affected, have an opportunity for input before this cake gets baked, so to speak. And we would look forward to reading your report and perhaps having an informational meeting to discuss it once the report is available. I think everybody in the committee would appreciate that. One last question, which is more a matter of curiosity. I'm generally inclined that more data are better, and collecting some of the things you talked about can be beneficial for identifying at-risk populations. But my experience is that, to a large degree, America is a melting pot. And when we get down to all these disaggregated categories, I think a lot of people might have a difficulty picking just one that they may have problems identifying easily. What do you do about circumstances like that? You want to collect quality data, but that may not be so easy when we have people who hail from many different backgrounds.
Good question, and I neglected to address it early on. So thank you for the prompt, which is, you have to allow that. You have to allow people to pick more than one category. You also have to allow people to write in, right? So in case something is not there, I think we have to allow people to write in. What if we've missed something, right? So you're right. It's not meaningful unless it accurately reflects what somebody wants to put there. So that is part of this this roadmap, is how we operationalize that.
I guess it gets more and more complicated with the more data you seek to collect.
Who knew healthcare was complicated?
Yeah, well,
it is.
I still like data. Senator Wong, did you have anything else you wanted to explore at this point?
If I may, just thank you, Mr. Chair, for the second time, and very quickly. I think you posed an important idea and concept, and I know it was cited earlier, that the opt-in possibility and giving people a choice is an opportunity that I think should be explored in this bill. I think you will find that there are many people who would be willing at their own choice and to offer this kind of information to help move the process along. But I think ultimately you want to give them that personal choice and not have government dictate that they shall have to. Perhaps the word may is something we should consider. that would be all, Mr. Chair, and Vicky, thank you for your time. And I'm eager to look forward to working with you, not only on this issue, but health insurance, cost containment, and various other things. And your advocacy for healthcare access to everyone is important, and I respect that greatly. Thank you.
Thank you.
Thank you. I think you got quite a bit to think about, and we look forward to when you share the report with us and being of whatever help we can to get it just right.
Thank you. No problem exercising my brain. I need to do that more. Thank you.
Oh, you can count on this committee for that, perhaps ad nauseum, but certainly we appreciate your input. I see no further questions. Thank you. I believe the next person up is Ji Zhao, if I've got that pronounced correctly, followed by Kathy Flaherty.
Kathy Flaherty's here, but I wasn't sure if the person ahead of me is.
It's conceivable that that person isn't. I do not see the name in the room. On occasion, we have little glitches. So why don't we move forward with you, Kathy? And if we see that person return, we will go to that person. Welcome, Kathy.
Thank you so much, Representative Steinberg and members of the Public Health Committee. My name is Kathy Flaherty. I am the Executive Director of Connecticut Legal Rights Project. We provide legal representation to people who are eligible for mental health services from the Department of Mental Health and Addiction Services. I'm here to offer testimony on two bills. Unfortunately, it only seems to be posted online under 6398, but I also submit testimony and comments with regard to 6424. I'll make this quick because you have my written testimony. The Whiting exception for searches under the Patient's Bill of Rights was added to the Connecticut General Statutes for no apparent reason other than one individual legislator at the time, somebody finally put in that patients had the right to be present while their belongings were being searched. Someone said, well, shouldn't we do it different for Whiting? And nobody objected to that. People should know, and I know many members of this committee have toured the facility. Whiting is a hospital. It's not a jail. But when patients go in there, they are subject to a strip search, the same way people going into DOC are, if they have left the facility and they have not remained in line of sight of staff. Therefore, if there's any contraband, it is getting in through staff, full stop. And, saying that people need to have their rights restricted in terms of being present while their belongings are being searched, when every other hospital and psychiatric facility in this state is capable of letting people be present while their belongings are being searched, it simply makes no sense. So I would actually suggest to you that the language you should use for that is just eliminating the Whiting exception. I don't believe the recommendations of the department are necessary. Totally support adding people to the Whiting Advisory Board. We often hear that there are lots of advisory boards that don't have the people with the most knowledge on them. Having people with lived experience of inpatient psychiatric hospitalizations would be a huge help. In terms of 6424, one of the things I'm asking this committee to consider is requiring reporting of that race ethnic language data when it comes to forced psychiatric treatment. When they do restraints and seclusions of kids in school, they already have to report that information to the state. When they do restraints and seclusions in psychiatric hospitals, they collect the data, but they don't tell you anything about the race, ethnicity, and language of the person subjected to those forced interventions. You can see a racial disparity overall between forensic mental health and mental health because the DEMIS puts out all kinds of equity information. And if you start digging into those reports, you can see that our healthcare systems have a disparate impact on people, especially people who are Black. They are at double the percentage in forensic mental health than they are in regular DEMIS. You cannot change things if you don't measure them. So I'd encourage you to look at that. And I also attached to my testimony a suggestion to bring the Patient's Bill of Rights into the 21st century, because limiting people to a shared phone in the US mail for maintaining contact, the same way you guys cared about people in nursing homes being able to maintain connections to family, people who are subject to long-term hospitalizations and demas deserve that too. That's it.
Thank you for that. And you made some good points. I hope you'd share with us any language you might suggest to update the existing statutes. That'd be much appreciated. And it is kind of interesting that even though we're talking about a different bill, still collecting data is a critical component to understanding what's taking place. So it pops up everywhere. I don't see any questions for you, Kathy, but thank you for your testimony. We really appreciate your desire to get things just right.
Thank you. I just want to say quickly, if you look at the documents that are attached to my written testimony, I actually did give you suggested language for the changes that would be needed in the Patient's Bill of Rights statute with regard to communication rights. So thank you.
Thank you for that. That's really what we need. We're going to move on now to I'll see how well I do with this one. Parisa Charmchi Goodwin, followed by John Scher. I probably got them both wrong, but Parisa, please.
Thank you, Representative Steinberg. Actually, you did a perfect job. Thank you so much. Yeah, impressive, actually. I'm very impressed. Thank you. Thank you for the opportunity to testify. Hello, all members of the Public Health Committee and everyone else taking the time to be here. My name is Parisa Charmchi Goodwin. I am testifying on behalf of the Connecticut Oral Health Initiative in my role as Executive Director. We are a nonprofit oral health advocacy organization with the mission of advancing oral health access, quality, and equity across the state. I'm testifying today in support of House Bill 6424, an act revising data collection requirements for healthcare providers connecting to the statewide HIE. And I really echo the testimony of some others in the written and Kathleen Callahan earlier from Nassau. So I won't read my testimony. You do have my written testimony submitted. But I want to note that the ability to measure and track race, ethnicity, and language data disparities is particularly important to me as a policy analyst and as an oral health advocate. As others have stated, this helps us really understand the breadth and depth of the disparities that we have in the state. And it also helps us evaluate the impact of policies and interventions, some of which are meant to remedy those health inequities. So we want to make sure that we are actually addressing them and not deepening any disparities, which is not the intention of, I think, any advocates or policymakers or any of us engaged on this issue. Nationally, we do know that people of color have worse oral health outcomes compared to white people. And in Connecticut, we know Black and Brown children are more likely than their white classmates to have untreated cavities. Black and Brown seniors are also more likely than white seniors in Connecticut to lose their teeth. However, we don't have information from provider entities, and we really rely on state and federal projects in order to get any pieces of data. And sometimes those happen in 7-year swings, which is a long time in healthcare. And oftentimes there's limited racial and ethnic data, typically no data on language, even though we know that language can be a big barrier for people accessing appropriate care. And also the racial and ethnic categories are inconsistent from project to project, which makes it really difficult to track and measure any progress that's being made. So I used to do a lot of research before I did advocacy. I know it's something that we need to be able to identify the problem in order to fix it. So I also echo that it's very important that things be self-reported, that people be able to check off multiple things and to have a write-in option. I myself am an ethnic minority and of mixed ethnicity, so I was always the kid that wasn't sure what to fill out. And over time in some venues, there's been, I think, some great strides there to make sure that we were actually understanding where people are coming from, who they are, and then seeing if they're being treated unfairly in any way, which is what at the end of the day, we really want to remedy. So thank you so much. I'm happy to answer any questions if I can be helpful, but thank you for the opportunity to testify.
Well, thank you for your testimony. You were able to comment from a variety of different perspectives, all relevant to this conversation. You mentioned problem solving in your various backgrounds. Can you give us an example of how data has helped you actually solve an existing problem with a subpopulation?
Absolutely. I used to work actually in financing strategies and getting treatment covered for children, youth with special healthcare needs. And something that we would see is that for certain groups, it would look like people were getting different care depending on the region. And then when you were able to layer region and race ethnicity, you were able to identify where there were actual problems. So for example, sometimes it looks like Latino populations have better access than white populations, but when you layer on region, you can see that in certain areas, you actually need to target things differently. And you need to make sure that you're getting care to rural groups and that you're getting care to communities of color, which might be in urban centers, which you access differently. So it impacts the way you will deliver the care as well. I know that's a very kind of broad example, but there's really so many ways to look at it. And unfortunately in oral health, we have far less data than in health, I think because of the nature of the kind of siloed system. So I'm hoping that dental records and dental providers will be participating in the HIE as they do in some other states, and be able to get us that data, with the willingness of their patients.
Thank you for that. I think we do need to follow up to make sure that we're collecting good dental data as well, because as you say, we have some access issues in the state as other states do, and we want to make sure we're covering the problem areas. I don't see any further questions. Thank you for your testimony today. We really appreciate it.
Thank you.
And we will look at your written testimony carefully. Next up is number 38, Christopher Arnold, followed by Kevin Brophy.
Thank you so much, Mr. Chairman. 21 states have enacted military spouse licensure recognition statutes that provide a right to license recognition, and 29 other states have weaker license recognition statutes for military spouses. Connecticut has no general military spouse license recognition statute. Both House Bill 6449 and its twin before the General Law Committee address this area of public policy concern. My name is Christopher Arnold. I am the Northeast Regional Liaison at the United States Department of Defense State Liaison Office. In last year's letter to Governor Lamont accompanying the Secretary of Defense's report on military spouse licensure, the department noted that Connecticut enacted legislation to accommodate transitioning service members, but has depended on the laws, policies, and practices used to accommodate all licensed practitioners coming into the state to facilitate licensure for military spouses. These temporary licensing and endorsement practices may be sufficient for the usual tempo of interstate mobility, but have proven inadequate for military spouses. House Bill 6449 seeks to address such recommendation through both near-term actions and long-term solutions. The Department of Defense offers its strongest possible endorsement of this bill. The secretaries of the military departments have made the importance of military spouse licensure explicitly clear as they consider the availability of license reciprocity when evaluating future basing or mission alternatives. This consideration was codified by Congress as a requirement in the 2020 National Defense Authorization Act. Notably, sub H of section 2883 requires the department and each of the military services to produce annual basing decision scorecards at both the state and installation level, considering military family readiness issues, including interstate portability of licensure credentials. The secretaries must further consider whether the state in which an installation subject to a basing decision is or will be located has entered into reciprocity agreements to recognize and accept professional and occupational licensure and certification credentials granted by or in other states, or allows for the transfer of such licenses and certifications granted by or in other states. Relocation is the #1 stressor for active duty service members, and I myself am a combat veteran. No military spouse is PCSing with only 1 year of experience. Conversely, the 1-year time frame in the bill recognizes spouses who relocate frequently and may not be able to achieve longer specific time-based requirements when they're moving to a new state every 2 to 3 years. Some states require additional qualifications when military spouses with out-of-state licenses seek local recognition. For example, in order for military spouses to receive a second license, states sometimes require additional education and/or some amount of previous professional experience, while other states sometimes require the licensed military spouse to be monitored by a local professional. A statute that does not require such additional training, experience, or monitoring is more favorable to military spouses. That is why nearby states, such as Massachusetts and Maine, are evaluating removing their requirements for substantial equivalency during this legislative session. DoD recommends as a best practice issuance of a temporary license as seen in House Bill 6407, while the service's basing scoring criteria go even further, identifying and negatively assessing barriers such as substantial equivalency requirements, may accept versus shall accept
you
language.
hit your 3-minute mark if you wouldn't mind concluding your remarks.
I'd be happy to. The rest is in my written testimony. In closing, we're grateful for the tremendous efforts that Connecticut has made to support our service members.
Well, Mr. Arnold, we're grateful that the federal government has chosen to weigh in your person on this subject. Obviously, we learned a lot during the pandemic, and also obviously the state of Connecticut is very proud to be the home base for many military personnel. So this is something that's very important to us. You've heard some testimony earlier about some concerns about the transferability of qualifications from one state to the next, in that Connecticut is later to the game than some others in this. Do you have any comment on the actual track record of experience with reciprocity, where the credentials might be somewhat different?
Roger, I do. So the department encourages states to engage in immediate actions, near-term actions to at least attain a baseline of getting a military spousal license in 30 days based on minimal documentation and removing substantially equivalent language, and long-term solutions for reciprocity through compacts. In nearby Pennsylvania, the State Nurses Association had originally been opposed to the Commonwealth joining the Nurses License Compact, which is now active in 34 states and allows nurses to obtain multi-state license to practice in 35 states, saving them from the cost of having to apply for an additional license in each state. The State Nurses Association, in a letter to the House Speaker, wrote that it now supports joining the compact, as reservations initially expressed by some groups, such as significant lost revenue to the State Board of Nursing or public safety concerns, have not materialized. So they've been able to study that over the last 6 years and recognize the benefit of allowing licensed members to work in other states through privilege to practice policies and more easily transfer their license to a new state.
Thank you. To your knowledge, has any state contemplated or actually taken action to reverse compacts they were involved with for any specialty area?
What an outstanding question. And thus far, the only example of that is the state of New Hampshire, which is one of my states at present, has a bill to leave the EMS compact under the auspices that none of its neighboring states have sought to join it, and therefore it does not derive much benefit.
So to your point, the only instance that you can cite is not actually one in which there was dissatisfaction with the compact. It's rather that they just need more partners.
Roger, that's correct. And also in this past year's NDAA, there was $5 million for my office and a requirement for the secretary to enter into a cooperative agreement with the Center for Interstate Compacts, which is part of the Council for State Governments, to draft new occupational licensing compacts. And we'll have 4 national boards that we're working with to draft even more compacts in the years ahead. But the APRN compact, audiology and speech language pathology compact, the NLC, the occupational therapist compact, physical therapist compact, the psychology interjurisdictional compact, and replica. Thus far, a state has never left after joining.
Well, thank you for that. I know that we live in an age where many of us do not look to the federal government for the ultimate solving of problems, but I, for one, feel more confident about this legislation having heard your testimony. So thank you for taking the time to join us today and to give us that perspective. I don't see any further questions. So again, thank you for taking the time. It's important to us to have heard about the practical ramifications of other states having joined these compacts.
Roger, thank you, Mr. Chairman, and thank you to the committee.
Thank you. Next up, I believe, is Kevin Brophy, followed by number 40, Faye Gobert.
Hello, members of the Public Health Committee. Can you hear me okay?
You're doing great.
Thank you. I'm here to testify in regard to SB number 922, an act concerning revisions to statutes pertaining to discharges in a residential care home. My name is Kevin Brophy. I did submit written testimony, but I'm going to try to condense it because of the 3-minute restriction. I am the managing attorney of the Elder Law Unit of Connecticut Legal Services. a nonprofit legal aid agency. A few years ago, the Department of Public Health and the Department of Social Services invited a number of stakeholders to meet, discuss, and recommend proposed changes to our statutes and regulations in order to implement the new federal home and community-based services regulations. Several work groups were established, and I chaired the housing work group. For background, the federal government promulgated regulations that allow states to receive Medicaid reimbursement for home care services, but only if the services are provided in a home and community-based setting. For example, elderly clients who are on the Connecticut Home Care Program for elders who live in private apartments, elderly housing projects, or elderly congregate housing would all be considered living in home and community-based settings. Currently, there's approximately 250 residents in Connecticut who live in RCHs who receive home and community-based services. In order for those HCBS services to continue to be reimbursed under Medicaid and to be offered in the future to other residents, Connecticut must, among other things, revise its RCH discharge statute to comply with the new federal regulations. In determining whether a setting meets the federal home and community-based settings requirement, the RCH resident must have comparable protections to tenants under the state landlord-tenant law. Connecticut has two options in order to make the current administrative discharge process for residents in RCHs comparable to protections afforded tenants under the Connecticut landlord-tenant law. One is to apply the current court process to residents of RCHs, or two, retain the current administrative hearing process for discharges, but make some important revisions to afford more protection for residents from discharge. We recognize that inherently RCHs are a different model of a home than someone living in an apartment. RCHs are congregate living facilities which not only provide housing, but meals and care for a vulnerable population. If RCHs are found to be home and community-based settings, the RCHs will gain access to more Medicaid reimbursement. Currently, I believe only the home care program for elders is available to RCH residents. All other Medicaid home care waivers, including the Department of Mental Health working for Integration Support Empowerment, the WISE program, would be available if the comparability requirements are met. Last year, we supported the governor's bill, HB 5020, Section 12, which I attached to my testimony, because it provided greater housing protections for residents living in RCHs. However, we oppose SB 922 because it significantly waters down the governor's proposal from last year. It does not meet the comparability of Connecticut's housing protections and requirements, in my opinion, because one, while the notice of discharge described—
You hit your 3-minute mark, if you wouldn't mind concluding your remarks.
In my written testimony, I kind of highlighted where I think SB 922 needs to be improved in order to meet what I believe are the comparability requirements. And so I'm not going to read those, but it talks about extending the time, giving a resident the opportunity to ask for some additional time to look for alternate housing, some suggestions on improving the notice provisions, and a couple of other suggestions. In conclusion, in order to satisfy the federal HCBS regulations, the discharge statute must be significantly strengthened to meet the comparability requirements. Failure to do so could lead to the Center for Medicare and Medicaid Services rejecting Connecticut's RCHs as home and community-based settings. Please oppose SB 922 as currently drafted. Thank you.
Thank you, sir. We will look at your written testimony carefully. Just so make sure I understand, you were happy with the bill that was drafted last year. Do your suggestions go beyond sort of changing it back to last year's? Were there additional things beyond even last year's bill you want to see happen? I testified in support of last year's the governor's recommendation proposal. And so essentially, we did look at last year's proposal, and we suggested some changes to the current SB 922 from last year's proposal that would strengthen the current bill, and we would support if they added those additions. Thank you for that. Again, we will look closely at your written testimony and engage the governor's office to have a conversation as to why they contemplated those changes. And we certainly take your point that if we want to really be supportive of their role, we need to put in the appropriate guidelines. Thank you for that.
Thank you.
I don't see any further questions. Thank you for sharing with us. This was important testimony.
Thank you very much. Have a good rest of the afternoon now.
Yeah, well, hopefully not. We don't have to use all of it. We'll see. Actually, apparently next up is Lin Yang, followed by Takesha Everett. I see Lin Yang in the chat, and I imagine,
Hello.
okay, hand is raised. You're ready to go.
Okay, hi, thank you. This is Lin Yang. I'm the founding board member for the Center for Race and Opportunity, an organization for racial unity and fairness for all. I'm here to testify against HB 6424, a bill that specifically calls for the ethnicity registry for the sake of public health. First of all, health is always an individual matter. Me and my twin sisters will not even share medicine. Now, are you going to prioritize a group identity over any personal needs? I don't think so. And secondly, I want to remind you all that associate with public health issues with any particular ethnic group is always a dangerous practice. Not long ago, it's a common practice that Chinese salespersons are not allowed to landing in port routinely because of the fear of spreading disease. And in 1971 in San Francisco, the largest public lynching in the United States actually happened towards Chinese labor camp because of the rumor that they are the source of the disease that is spreading in the neighborhood. And just look at now, with this pandemic, many Chinese businesses are destroyed. Their customers disappeared overnight. Not only Chinese, even you have a Korean or Japanese on your menu, you lost all your customers overnight. So those are all the problems that you might facing when you try so actively tie any health issue with a very small group of people. And how about the privacy protection? And do we need to provide consent? Are you worried about legal violations? And if you cannot collect the data accurately, and if many people like myself will opt out, what is the value of your data? Why we still need to spend taxpayers' money on this? And I also want to talk about a more broader case that I want to remind you all that every time when government are so obsessed with identity politics, especially with ethnicity data collection, the result is often catastrophic. And some of the most heinous human crime was happened because of that. The Chinese exclusion action, we all remember. Japanese, when they are all camped during World War II, because their association with a certain nation. And Jewish people are forced to register before the World War II. And you all know what that happened. More importantly, I want to remind you all, every time in the history, when government are trying to do this, it's all for a greater good that they are trying to propaganda to their people. It is for workers' rights, it is for nation security, it is for fair and justice for the society, but look at the result. I genuinely believe all of you that supporting this meant well. Not for a moment I doubt this, but I also want to remind you, this is not something new, that a government is so eagerly to engage.
Sorry, excuse me, you hit your 3-minute mark, if you wouldn't mind.
All right.
Your remarks.
Yes, thank you. I want to remind you, this is not new. And the history didn't look very nicely upon that. And thank you all for this opportunity.
Thank you for your testimony. Yes, I remember reading just recently an article that talked about discrimination, crimes against Asian Americans in San Francisco and elsewhere, which just reminds us that we're a long ways away from getting past discrimination against various groups, and there's no toleration for that. To your point about privacy, we've been led to believe the protections are such that individuals would never be identified, and it falls under HIPAA in some ways anyway. And I think that's a critical point that you make, that if people are not confident about the privacy, they will not opt to provide the data. And to your point, unless enough people provide the data, it's not as useful, it's not as reliable. And that's important to us. And this conversation is important because we must find ways to educate people and give them confidence that the data will not be misused in the fashions that you described. Hopefully, if our country is not totally healed from divisiveness and discrimination, we progress somewhat from some of the really horrible chapters that you described from our past. Next up is Senator Wong, followed by Representative Kennedy.
Thank you, Mr. Chair, and welcome, Lynn. Thank you very much for appearing today. And you know, we've had conversations about this before this bill was raised, and I think that the premise was not again, but being said, it's important for you to share, as you did, the history of state-sanctioned discriminatory practices, fever, media portrayal of William Randolph Hearst, to the current events of potential attacks, but even the premise and the stereotype in some cases of, quote, the model minority, where they're built-in stereotypes and perceptions. And I appreciate that, and I hope that you'll be able to support that. We have a bill out there talking about being able to create a curriculum to talk about Asian Pacific American history in this country. And I was present at your naturalization ceremony. So I know you're obviously very proud about being an American. So
I am.
The underlying question I have is, as much as you are proud to be an American, you do have a distrust where this data collection could be used as malfeasance or on a privacy basis. Would that be a correct statement?
Yes, thank you, Senator, very much. And just to roll back a few points you already addressed, that it's actually a very pointed comment that Ms. Vicky Veltri made during her testimony. Again, I comment her for her desire to serve the public. I not for a moment doubted that. But it's a comment that Asians, many of us, we come from many countries, right? There are many countries in Asian community. That's actually, I want to rebuttal that I come to America to become an American. And my children are actually born here. They know no other country as homeland than this country. So any practice that trying to identify their citizens based on where they come from, what language they speak, generationally make us outsiders. And I think this is more true for Asian community. We are the smallest population as a racial group, yet it's always like, oh, you come from so many countries. What language do you speak? I speak English, you know, that's why we are talking. Again, I'm sure it's all good intention. And I'm a physical chemist by major, right? There are histories you can look on how Asian American groups are singled out. And every time it's not singled out for anything good for us. And only recently, many Asian Americans are filing lawsuits because they felt their children born and raised here were singled out based on their ethnicity. When they apply for college, they have to score hundreds of points higher than other groups. Why? Do we all go to public school? Are we all taking the same exam? And Chairman Steinberg mentioned hate crime to Asian elsewhere. We don't need to look further. Just look at Anthony, our Chinese restaurant were targeted, harassed because the COVID pandemic. And they didn't even go back to China in the past 10 years, neither do I. So every time when we trying to talk about classify people to the finest detail so that we can do some research, do some study to be targeted, that actually brings back terribly memories. I don't think I'm speaking for myself or only for Chinese American community. I believe the general public will not be so keen. Let's bring less identity politics to things we're trying to address. Let's address health issue, let's address education issue. I hope it's for all of us. It's not one group versus another. It's not you versus them versus me. I believe this is the only way America can move forward. And thank you.
No, thank you, Lynn. And I think it's important, and I'll be brief on this in saying that you talked about, and as the Chairman Steinberg talked about, violence against any group is unconscionable. But I think in our many conversations, you also cited that what isn't always transparent, what isn't always obvious, the bias and the perception and the race dynamics that other and Asian American communities and other racial minority groups have to endure. That is not always obvious and transparent. That has an impact on people. And I think the third point is you have a representation of a big viewpoint, but I think there's so many people that are so preoccupied with COVID during these times that they may not be as engaged until today on this issue. And I hope we will hear their voice. I know that testimony can be received until the bill is voted on. So please encourage your advocates to have their voices be heard by submitting testimony. Thank you, Mr. Chairman. And Lynn, thank you very much for your advocacy and your passion on this issue and raising a voice for many others.
Thank you, Senator. Next up is Representative Kennedy.
Thank you, Chairman Steinberg, and thank you, Lynn, for being here. I know how passionate, as Senator Wong said, that you are about this issue. If my memory serves me correct, we had a similar bill before the Education Committee about 2 years ago when I first met you, and your son, Kevin, eloquently testified on that bill. And so I'm very glad to see you here again testifying, because you stated how important this is to me. Without belaboring it, are there any other specific comments you want to make regarding why Asian Americans may feel this ethnicity data registry is unsafe to them? Are there other?
Thank you. Thank you, Representative Kennedy. Yes, 2 years ago, I believe hundreds of Asian parents and their children showed up at Capitol trying to stop the ethnicity registry that target Asian American school children. And the reason, a little bit background, is because in 2019, Rhode Island became one of the many states that requires Asian American children only in public school system to identify their ethnicity in the sake of fairness, equity within different groups. I want to remind the community that many children showed up in the Capitol that day. They were born and raised here. This is their homeland. And the result of the Rhode Island bill is for the 0.7% of Asian American children, they divided them into 17 groups. To me, this is not only you constantly talking to Asian kids that, no, you are Asian from Cambodia. No, hello. And I think the psychological impact to these kids are unmeasurable, as we shouldn't do it. And what do we achieve? Do you want to put one kid against another simply because where their parents come from? That's definitely not the intention, but often that becomes the result. And for this bill, the same here. Many of my community members are asking, now they're collecting this ethnicity data for public health, what else they're going to use it for? And how do they make sure this doesn't end into the wrong hands? and what is next? I think this is always the question, and the history hasn't been very kind to us in that regard.
Thank you, Lynn. I really appreciate you speaking so passionately on this issue. And please send my best to Kevin. I'm sure he's
thank you.
College now, but I appreciate you being here. And thank you, Mr. Chairman, for the indulgence. Thank you, Lynn.
Thank you very much. Yeah, I appreciate it.
Thank you, Representative. Seeing no further questions, thank you for your testimony. We're going to move on. Next up is Takesha Everett, followed by Robin Anderson.
Good afternoon. Thank you, Senator Abrams, Representative Steinberg, and the esteemed members of the Public Health Committee. You have my written testimony, so I'm going to provide a substandard oral version of that testimony. My name is Takesha Dewan Everett, and I'm testifying today in my role as the Executive Director of Health Equity Solutions, a nonprofit organization with a statewide focus on promoting policies, programs, and practices that result in the equitable healthcare access, delivery, and outcomes for all people in Connecticut. We strongly support the standardized collection of race, ethnicity, and language data through the statewide health information exchange and all health data collection efforts in the state. We have all, no doubt, seen the deep and unsettling disparities highlighted by the REL data in recent months. The COVID-19 pandemic has disproportionately impacted Black, Indigenous, and Latino and Latina populations, and we only know this because of REL data. Though by its own admission, in reporting the COVID-19 vaccination data, the Department of Public Health in Connecticut has noted the limitations of its current data collection. This is something we must fix in our state. If we are not able to track and measure change, then we can never know the true impact of a problem, and we limit our opportunities to change and course correct. I also want to add that the argument stating that we are one human race or that races for the most part are not genetically different, all of which is true, ignore the impact of racism on the lived experiences of Black, Indigenous, Latino, and Asian people in our state. The issue is not race. We can all admit that. It is racism, structural, institutional, and interpersonal, the overt and covert ways it shows up, implicitly and explicitly. But if we don't have critical race, ethnicity, and language data, we cannot address and dismantle racism and its impact on health. HES respectfully recommends 3 changes to the proposed legislation. Number 1, allow people to choose other and more than one category. Number 2, align categories for REL data with recommendations tested by Connecticut's Community and Clinical Integration Program. These categories were collected by Connecticut providers and created using Connecticut-specific demographic data. So we know they are feasible to collect and reflective of our current demographics. Further, the Office of Minority Health categories only offer granular race categories for people who identify as Asian, while CSIP categories offer a level of specificity across all racial and ethnic categories. We think this is fair and just, and do not think it is right to simply call out one race. Number 3, any Connecticut state agency collecting REL health data should adopt these categories. Stringent guidelines are in place for the utilization of health data in our state. The reality is REL data is already being routinely collected. It is already voluntarily provided, and it is kept private by healthcare providers and state agencies. It's just not standardized, and it's not done in a consistent manner. This proposal simply standardizes how these existing processes are carried out so that the data can be more effectively used to promote equity at the population level. This is not something new that we're asking for. Other states have improved.
Your 3-minute mark, if you wouldn't mind concluding.
Thank you for the opportunity to testify today. You have my written testimony to see any further items. I appreciate your time.
Thank you, as always, Takesha, for your testimony. We appreciate all the great work that you do. And we recognize that your objective is to root out disparities and particularly in this context, deal with the public health issues of the community broadly. You've heard testimony from others suggesting that this is going to be an invasion, that it's going to be a privacy issue, that many people will opt out. Do you have any perspective, any comments about what we need to do in order to instill confidence and to get as many people to opt in as possible, if that's the route we decide to take?
Thank you for the question, Representative Steinberg. I think first off, we need to reassure individuals that privacy is still first and foremost center in the collection of this data. Secondly, I think it's important to make the connection to why the data are important. Again, making the connection of saying we cannot fix what we are not tracking. And so it's very important that we have the data and that we have the information. I will personally give a quick example of how this can effectively be done. I was recently in a doctor's office for an annual exam, and through the collection of the information, asking me about my name, where I live, all this information, the nurse then paused and said, "I'm about to ask you a series of questions that may seem odd to you. It's all about demographics in your history, and it's connected to ensuring that we understand what health outcomes you may be predisposed for example, breast cancer, et cetera." She then proceeded to ask me, how do I classify myself racially and ethnically? I was able to answer that question based on, one, the information where she categorized why she needed the information, and two, based on how I wanted to be identified in the information. Further, when I asked her how would the information be used, she assured me that it was only for the collection and utilization of my care. I think this is critical that we just change in our workflow how we explain why we're asking for the data, why it is important, and how we intend to use it.
Finally click that mute button. Thank you for that. That directly answers the concerns I think that have been expressed by many and will be expressed as testimony continues today. As Commissioner Veltri said, it sounds like they really need to focus on the education, the training, the interactive aspects of trying to collect this data if it's going to be effective. I see we have some questions. Representative Pettit, followed by Senator Moore.
Thank you, Mr. Chairman. Thank you, Dr. Everett. I see a big part of your testimony is about the accuracy of collecting the data. If we have bad data, the analysis is not useful to us. I'm still a little confused about, we have a couple different groups looking at this issue, and viewing it with a completely different lens. What would you say to the people who've testified here and in other times when bills of this type have come up, about feeling that it's unfair or unjust and shouldn't be done? I know you're focusing on accuracy and privacy, but what comments would you make to the people who oppose this?
Thank you for the question, Representative Pettit. I feel deeply that we have to acknowledge, while race has no biological basis, we have a social factor here. Humans have created difference based on racial and ethnic categorizations. We are seeing health differences based on the relationship between our policies and laws and those social categorizations. If we are to dismantle racism, if we are to correct chronic disease, if we are to ensure that no race is overly burdened, for example, by COVID-19, or disproportionately burdened by different health issues or pandemics that come up, we have to be able to track what's happening. People are voluntarily able to select whether to answer a question or not. And I think we do have on the other side of this an educational practice, educational push that has to be made to reassure people why they should collect this information. But I truly believe that if we don't collect it, we won't know things such as, for example, we would not know that Ashkenazi Jews have a predisposition to breast cancer if we are not collecting ethnic data. That's an ethnic categorization, not a racial one. We would not know that individuals who are Black have different needs and different markers that we need to track in relationship to kidney disease if we did not have racial data to be able to do that analysis. So I understand the concerns. I think we need to shore up the information around why we need to collect it and share that information. But I wholeheartedly believe the key to making sure that we don't have disproportionate impact is to track how we are being impacted now.
So in essence, to paraphrase, you think the benefits of accurately collecting data and being able to analyze it outweigh any potential risk to or perceived risk to the individual?
I would say perceived risk, but I also believe that we need to communicate how data is protected, how privacy is protected. The standard ways in collecting data, where if a cell has too few individuals in it, how we mask that data and we don't analyze on that level. This is about population health data, not individual health level data. And I think we need to reassure that and consistently hold that mantra up.
Thank you for that response, Dr. Everett, and thank you, Mr. Chairman.
Thank you, Representative. Yes, apparently words really do matter in this case. The way that we frame it and the words we use are very important for instilling confidence in those we want to share data. Senator Moore, followed by Senator Wong.
Good afternoon, Dr. Everett. How are you?
Good afternoon. I'm well, thank you. How are you?
I'm good, thank you. So I do have some background in data for women and African-American women with breast cancer, knowing that the disparity was created and often left out of any type of research, that several times, like the sister study, they had to go back and redo the study because they didn't have enough data on Black women to be able to come up with good research. But I want to see if you can compare this to currently with the COVID-19, that we didn't have the data we needed very early on. And now we're behind for Blacks and Latinos being screened, being tested, and now getting the vaccination. Because I understand I understand the fear, and I understand people not trusting the system. Beyond that, and start getting the data so we can show people how these health outcomes, you said it, the whole population, not just specifically on any type of ethnic group. But I also understand that there's this hesitancy with the vaccine. But if we don't step up and get the vaccine, we'll still be left behind. So I'm wondering if you can just, if you can compare why it's important to get the data and how it's hurting us right now in current conditions, not having the data on COVID-19, on who's been vaccinated, tested, and who's been impacted by this.
Thank you, Senator Moore, for that question. I want to highlight that we're almost at the year mark of COVID-19 being a pandemic and an issue for everyone in the world, but particularly here in our state. And at the beginning of our collection of data and the reporting of the data, race, ethnicity information was not broken down. We were not receiving the information of who and how who was contracting the virus, who was being hospitalized, et cetera, broken down by race and ethnicity. Health Equity Solutions asked for that information. Department of Public Health and the governor started reporting it, and we were happy to say that we have that. But we did see in that process still some limitations on the data. We never were able to really look at hospitalization rates. So we don't know if there was a disparity in who was being hospitalized versus who was being turned away. We weren't able to see this information from a testing perspective early on. And I'll fast forward now to the conversation around the vaccine. The information that was initially reported was not reported by race and ethnic data. And then we started to get that information, and Department of Public Health readily admitted that they weren't able to consistently and reliably provide this information because the data are not there, which means it's not being collected in a standard and consistent way. When we put all of this together, what does this highlight for us? We're now seeing, when we look at the data we do have, Blacks, Latinx, and Indigenous individuals are disproportionately impacted in the deaths and the contraction of the virus. And now when we're in the vaccine, we are seeing that they're not equitably getting their fair share. And when I say their fair share, you're looking where we can see the numbers. They're demonstrably fewer Black, Indigenous, and Latin American individuals who are getting the vaccine. And that is also true for Asians. I should also add that that's true for the Asian population as well. So what we're facing here is, if we don't have this data, we wouldn't be able to retool and re-guide our efforts. You now see that we see these numbers in the data. The governor is starting to talk about how we need to rephrase equity and retarget and retool our efforts. I think it was just 2 days ago mentioning that there's going to be 25% more vaccine held back in order to target the geographic areas where we know people have been the hardest hit. These are strategies we can only use when we have the data to see it. And I do want to just answer one more part of your question in relation to hesitancy. There is some hesitancy in some populations around getting the vaccine, but let's be clear. Right now, we have an access issue. We can't even get to the conversation about hesitancy until we improve access. And we can only improve our access when we have a scarce resource by best tracking and understanding the information. We can only do that if we have the data.
Thank you. And I know now that we're starting to collect the data, we're looking at zip codes to start to address where they need to make sure that there's a larger amount of the vaccine available. And that all comes from really beginning to collect the data and starting to drill down to where the inefficiencies are. So that's one of the important, I think if we look at what's happening right now with the COVID-19 and we use that as the baseline of why it's important to have that information, it would help people. But I also believe the communication of how you're gathering that data and showing to making people feel really comfortable beyond words that this data is not going to be used against them. I mean, even if there was a disclaimer that said you're not allowed to, and there's an act that says it's under penalty of the law that this data is used any other way than it was intended to. Just like a lot of times when you go in the doctor's office and you have to agree to some things, I think that would be an important part of this, making this change, is that people feel confident and that there's some recourse when people misuse the information. So thank you for your testimony and being here. Thank you, Mr. Chairman.
Thank you, Senator. Senator Wong, followed by Representative Foster.
Thank you. Thank you, Mr. Chair. And Dr. Everett, thank you so much for the work of your organization that are really on the grassroots and trying to get solutions. So thank you very, very much. I'll be very quick. You talked about in your testimony, race, ethnicity, and language as some of the parameters that you're looking at. Why not socioeconomic?
Thank you for that question. Specifically, what we know is race, ethnicity, data, and particularly language, when we look at disparities, are some of the key drivers of what are some of the key root drivers of disparities and disproportionate treatment that we see in healthcare. This is started from the 2000 report from the Institute of Medicine. I'm blanking on the name right now that we're talking, but it's a major report. And unequal treatment. I knew it would come to me if I kind of gave it another second. Unequal treatment that really highlighted the need to collect these data and to make sure that we are using that and tracking that information. Socioeconomics really is kind of linked again as an overlay to race and ethnicity information. It's not a proxy, but particularly here in Connecticut, you can see a relationship between race and ethnicity as well as socioeconomic. The last point that I'll make to that is I always try to start with my own personal examples so that I'm telling the story of myself and not the stories of others. My historical coming to where I am now is very different than my socioeconomic status today. And what I mean by that is I am a middle-class individual who lives in West Hartford, but my origin story is one of a Southerner who is low income and raised very poor. If you collect socioeconomic status on me and not connecting to race, it will mask the fact that I have a history that is rooted in racial difference and racial problems and racial trauma that can connect to my health today. Now, that's something that you will only see if we're having an interpersonal one-to-one conversation. On a data level, it's important to understand that no matter where I live as an individual showing up in the data, I still could have subsequent issues related to things that are connected implicitly and explicitly to race and racism in our healthcare system. Said differently, Senator Wong, it doesn't matter where you live or how much money you make. The fact that we have racism in our country and racism in our state follows you wherever you are, regardless of zip code or socioeconomic status.
Very eloquently said, Dr. Everett, and I appreciate that. And I am very supportive of getting data and healthcare data collection to address care. But I think in our exchange with Ms. Veltri, she cited this is still a work in progress, very broad. Now, for me, I would like, before this bill moves forward, to get a much more clear and more comprehensive detailing so that there is no potential bias building in when you're designing this. But I'd like to be able to have that in language, not a broad interpretation, because we might all experience racism and disparate treatment, either obvious or subliminally. That bias may creep in. So if it's not written down in the statute in regards to a clear, comprehensive guideline of groups and segmentation, it is open to bias. And I think that's where the inherent distrust is. What are your thoughts to that statement?
I think that there's distrust overall that every racial minoritized individual and community and population in the United States has as it relates to the government, healthcare information, and how it's going to be used. I think we have strong privacy laws, HIPAA, and even in Connecticut, we have stronger enforcement of HIPAA than just the federal law that I think protects the data. I think we have a strong ally in the Attorney General, who also believes in the privacy and protection of individual rights, and then particularly as it relates to healthcare. So I think we have in our state the right measures in place to ensure proper utilization of whatever data is collected and provided. I hope that in the testimony and the exchange that you and Victoria Veltri had, that she was open to hearing your concerns and perhaps strengthening or changing the language. But even if not, here's what I would respond is, we're not doing something that's new or different. I think we're going to be a leader state in ensuring that we already have strong protection laws, strong privacy laws, and that now we're standardizing exactly how we collect this, and that it's being done on a voluntary basis. Mm-hmm. I think those are the important pieces that make us stronger, make us better, and make our data collection more powerful and can be utilized in the future going forward.
I appreciate your eloquence, and thank you for your great work. But I again, I hate to feed into the hesitation, because this is a bill that has been through this committee and discussed many years before. And I guess my putting some water on this is the fact that why would it not have been raised in the drafting proposed to this committee from the office when concerns like that were addressed many years before from specific category groups? That is why my hesitation is the fact that, again, maybe in drafting this, there are bias built in thinking that one group may need it more than the other. And to me, every racial, ethnic group and any individual should be afforded that protection and access to quality health care. So again, thank you for your great work, and I'm sure we'll have some continual conversations. But again, this isn't a bill that was just raised this year. There is many years and tremendous advocacy from many people in many years in the past. The fact that it isn't narrowed down when it's a major issue is a concern to me. So that being said, I thank you for your time. I thank you for all of your advocates and your work out in the grassroots. And thank you, Mr. Chair.
Thank you, Senator. Representative Foster.
Hi, thank you so much for the opportunity to ask questions. Dr. Everett, your work is really remarkable, and I feel like the state is very, very lucky to have you doing the advocacy work that you do. A lot of my questions have been answered as people continued on questioning, but I didn't want to miss the opportunity to say, and I think Senator Wong just highlighted this sort of opportunity. There is something that's tremendously different in our understanding about health equity now than the time prior to COVID. Do you think that, especially since your advocacy has allowed us to understand differences related to things that will be captured in real data in COVID vaccine distribution, that the same type of benefit could be seen in a time post-COVID as well, if we allow ourselves the opportunity to focus on the data in that way? I feel like, you know, COVID has given us this opportunity to sort of see, like, magnified the horrors of, you know, the inequitable access to healthcare and inadequate healthcare when you're in the healthcare system. But do you think that the benefits will continue to be realized? And what type of magnitude of benefits do you think are possible?
Thank you, Representative Foster, for the question. I will start by saying none of us listening or present wanted a global pandemic. This is not something we planned for nor asked for, but shame on us if we don't change what we know we need to change as a result of living through this. And what I mean by that is, it is clear that we have disproportionate, disparate access, outcomes as it relates by race and ethnicity in our state. This data has been clearly shown to us through the COVID vaccines, through the COVID-19 virus and death information. We know it. What we also know, and it has been highlighted, is that we don't have that information standardly collected, that we don't have that information in a way that we can consistently report it. This is our opportunity. I know, as Senator Wong mentioned, and as you just said, Representative Foster, this is not the first time we've been here. This isn't the first time we've had this conversation, but shame on us if we don't do something different. And if we don't learn from history, and if we don't learn from our current, and if we don't make a different space and place for our future. So I do think it's important. I do think that we can make a better state. I think we can make better health outcomes. I think we can do better if we have better data. And I think that SB 6424 is a start for us to get there. I think it's reinforcing the system we already have. It's standardizing collection of this data in a way that's important. And I think it protects the privacy of people and still gives us the data we need by voluntarily asking people to provide it.
And I know that it would be helpful for me if you could just speak to for a second. I know that, you know, we have some data that shows disparate outcomes in things like COVID, diabetes, I think maternal mortality, child outcomes, and it scares me a little bit that this kind of data doesn't exist in broad swaths, that we already know of those problems because of targeted data collection and efforts in small communities. I think it's possible that we're going to learn through this data collection that the problem is worse than we've even described so far. I think we likely will find that. But I think we are also likely going to find that there are ways for us to be more responsible in the way that we use. I think that there is a health equity argument to be made here, but also a fiscal responsibility argument to be made here. And I feel like that's an important juxtaposition to make. I have colleagues who do diabetes interventions that are targeted for communities of color. And those types of interventions have such significantly more robust outcomes that it almost seems like we should be considering these tailored interventions in different communities. And if we don't know where tailoring needs, we might be wasting time, energy, effort, and resources with programs that don't work with specific populations. Is that something that you think is possible, that we will see robust fiscal benefit from having this data?
I wholeheartedly think we will. What comes to mind right now, and I know this isn't an opportunity for me to do a workshop, but there are these images that have been circulated for quite some time that show the difference between equality and equity. And one of the most important factors that I like to point out when looking at those two images is that the resources being utilized to solve the same problem are the exact same resources. There are 3 boxes on one side, 3 boxes on the other. The difference is that the person who didn't need the resource didn't get it. And so you're better adequately using your resources when they are scarce or few to target the intervention in the best way. Put into this conversation, if we have few resources, but we have the data that can lead us to making our interventions more tailored, that means we're using our resources better, more fiscally responsibly, and getting the differences that we hope to see without being wasteful. That's the best way I can say it.
I appreciate you being here today. I do research that crosses social determinants of health outcomes, and I still feel like every single time I hear you talk, I learn something new. So thank you so much for being here and for sharing your wisdom with us.
Thank you, Representative. And I really appreciated this last dialogue, Dr. Everett. I think you connected the dots very well in helping us understand. I think, as you said, shame on us if we do not take advantage of even all the bad news that came out of the pandemic. I would argue that when it comes to the funding side of the equation, Connecticut was already in trouble before the pandemic hit. We've shredded our healthcare safety net because of budget constraints for so many years. And to your point, when resources are scarce, every dollar has to be used as effectively as possible. And data helps us spend it as wisely as we can. I don't see any further questions, but again, thank you for your testimony. We really appreciate your being here today. Next up is Reverend Robin Anderson, followed by Anna Doragazi, number 44. Reverend, welcome.
Well, thank you, Chair. Good afternoon, everyone. As has been stated, my name is Reverend Robin Anderson. I pastor the Blackwell AME Zion Church in Hartford and also the Executive Director for the Ministerial Health Fellowship Advocacy Coalition. And I'm coming today and thank you so much, Takesha, Dr. Takesha. It was so to how you really explained everything and how you really was able to clarify a whole lot of things for everyone else. But I think the whole race, ethnic, and language data is very important that we really pass a bill to collect data in that way. As it has already been stated, and I just want to echo that even more so, that, as we know that it has been a disproportionate rate of people of color who have died from COVID-19. And the sad part of it was that during the time in which, there were so many during the pandemic, and here we are a year later, and even at first just not being able to aggregate, put the data together in terms of really stating how many people of color were actually really dying, and not even having a percentage of that truly speaks clearly to the fact that we don't really have a standardized way of collecting data, and that is why it took so long. And that this bill will help to standardize the data that's collected by race, ethnicity, and also language. And as I think about also, and I like to even tell my own story, and that is that, as a pastor and also, even myself personally, and I'll go into that, have seen so many people who have various kinds of diseases, such as diabetes, as we talked about, breast cancer, and also high blood pressure. And those are the number one things that people die from. And yes, I think all races are important. And also, as we know that it's not really about race, it's about racism. And so as I think about the fact that, if we're not collecting this kind of data, then how do we really know in a standardized way, how do we really know what diseases, such as diabetes, and what impact does that have in terms of the ability to be able to deal with various kinds of diseases that may come up, such as COVID-19. And I guess the tragedy, and I want to echo that also, what Dr. Everett said, and that is that, now that we're in the pandemic and we're going through a pandemic, and we see the kinds of things that have happened, it would be such a tragedy if we don't look at being able to do things differently, especially collect standardized data. My question is always, how do you know how to filter even funds into various communities or into various kinds of diseases if you don't really have the data to support that, and you really don't know, whether or not persons are, if even economically, we're actually putting funds into different places to help, not only to help get rid of diabetes or help people to maintain their diabetes in a better way, or asthma and those kinds of things, if we really don't know in a standardized way how many people really are affected by that, and what zip codes are those persons that are affected, and are there funds that are allocated to those various areas because of those diseases that continue to show up. The other thing that I want to say that
you hit your 3-minute mark. If you wouldn't mind concluding your remarks.
Okay, I'm sorry. And then the other thing is that I'm a preacher also, so I apologize for that. But the one thing I just want to mention, I'm also Native American and also African American, so you would not know that unless I'm able to put that information down. And so very rarely I had an eye disease. And so one of the things that was taken for granted was that, we don't know how you got this eye disease because you're African American, and it's only found in people that are African American. that are found in people that have Indian ancestry. So I would say, well, I do have Indian ancestry, and I actually checked off I wrote in Native American. So again, I just want to state that it's so important to me that we do collect data by race, ethnic, and language. And I think it's important that we have a standardized way of collecting data that will help all of us to stay healthy, to be healthy, and to also have an idea of what areas that we need to target and what areas we need to focus on that we might be able to also appropriately make sure that persons in those various different different ethnic groups are able to get the funds that are needed in the communities that they live in, or the communities that they actually receive their medical care to be able to address the diseases that are found within them.
Thank you. Thank you so much, Reverend Anderson. I don't see any hands. Thank you for your testimony and your time.
Thank you.
Next, we'll hear from Anna Dorgazi.
Hello.
Hello.
Hello, Representative Gilchrist, ranking members of the Public Health Committee. My name is Anna Dorgazi, and I am one of the policy directors at AARP Connecticut. Thank you for the opportunity to speak with you today and to offer our support for House Bill 6449, an act expanding economic opportunity in occupations licensed by DPH. We support the full bill, but I want to comment specifically on our support for Section 2 and for the potential of interstate licensure compacts to improve access to health care and to provide better continuity of care for older adults. Connecticut has more than 250,000 people who file taxes as part-time or non-resident filers, and a significant number of those individuals are older adults or retirees who divide their time between Connecticut and other states. If Connecticut were to join interstate licensure compacts, it could become easier for these part-time residents to maintain relationships with their Connecticut-based healthcare providers during times when they are residing out of state. This could be especially beneficial for people who are generally healthy but may need to do occasional telehealth check-ins with their healthcare providers to manage chronic illnesses or to do something pretty straightforward like adjust medication. Interstate licensure compacts also have potential to improve access to medical specialists. Connecticut only has 149 board-certified geriatricians, and while interstate licensure compacts don't solve some of these bigger workforce supply issues, they can help alleviate some of the problems related to not having enough of a particular type of provider. For example, there are more than 1,000 geriatricians practicing in New York and Massachusetts. If those two neighboring states and Connecticut all joined the medical interstate licensure compact, that would open up a lot of potential access to a very needed and growing specialty. And there are lots of geriatricians who are currently practicing just across the borders that we share with those states. A suggestion to improve the bill would be to explicitly include consumers in the composition of the proposed working groups. In particular, older adults, people with disabilities, and medically underserved communities. I think we always get better results when we include consumers and impacted population in our policy conversations. It'd be great to make sure that those voices could be at the table for these proposed work group conversations. I've also submitted written testimony, so I will leave my comments at that. Thank you for the opportunity to speak with you today and share support for House Bill 6449.
Thank you, Ms. Dorgazi. Thank you for your testimony, and that's a great suggestion. So I'll be sure to go look at your written testimony. I don't see any hands, so thank you for your time and your testimony.
Thank you very much.
You're welcome. Next up is Maureen Dinnan.
Thank you so very much. I am Maureen Sullivan Dinnan, Representative Steinberg, Senator Abrams, Senator Anwar, Representative Kushner, Representative Gilchrist, Senator Wang, Senator Summers, and Representative Pettit. I'm very grateful to be here to testify regarding Section 2 of Bill number 6449, the act expanding the opportunity, economic opportunities for occupations licensed by the Department of Public Health. I am the Chief Executive Officer of Haven. Haven is the Healthcare Professional Assistance Program. I think we have a unique perspective, and I think we represent some voices that are often afraid to speak up. Haven, we were created in 2007 as part of a legislative initiative, and it showed really the kind of a really strong beginning of this Public Health Committee and the legislature to recognize the importance of professional health and wellness. And one of the ways to encourage that was to try to have professionals less afraid to access care and treatment for themselves by removing the shame, stigma, and the prospect of licensure discipline if they needed to have health accountability. So we were created in 2007. It was a collaboration of multiple membership organizations. In 2015, there was another significant legislation that you all enacted, which did both create a mandated reporting if there was a concern for professionals who needed help, since there was a way to get them confidential help. And they also in that year created a professional assistance account because it was recognized that Haven really could not exist without better sustainability. Compact licensing, we're very, very grateful to be included on these potential working task groups. Our concern is that it has the potential to impact both our mission and our ability to deliver the services. I think the easier one is on the delivery of the services. It's going to follow that fewer people, professionals, are going to need to be licensed in Connecticut as their home state. And the sole funding for the professional assistance account is a $5 licensing fee. So if there's less licenses under that home state license, then there's going to be less resources. Already, we are really strapped on the resources that we have available to us. And so it would require creativity with the Department of Public Health. I'm not sure how they're considering making up for the deficit with the licensing, but we would have to change statute and we would have to accommodate for the potential loss to resources for our program as well. The mission, though, is really more concerning to me. The mission right now, the compact contract that I'm most familiar with is the nurses one. In the compact, it appears to have created a kind of consistent criteria for licensing for the professions, but it hasn't created any consistency for the alternate programs that are in each state, and they vary widely from state to state. So as a result, the compact contracts for licenses do not allow a professional who's in an alternative program like Haven to even to obtain a compact license. Worse, if a professional is determined that they need our health support services, they might have a substance use disorder, they might have a mental health condition, they might have a chronic physical illness condition, which includes aging, and they get referred. Once they're referred to the alternate program, their compact license is automatically deactivated, and they have to return to their home state. Thank you. So this violates the confidentiality and the protections that were so essential to the statutes that created Haven. And I think the task force and the voice in any report would need to recognize that. So thank you for the opportunity to testify.
Thank you, Ms. Dinnan. That's very interesting, and I appreciate you bringing that to our attention. I see a hand, Representative Pettit.
Thank you, Madam Chairwoman. Maureen, thank you very much for taking the time to testify, and thank you for all that you and the organization does to help impaired providers in many, many categories throughout the state. It would seem to me, I guess nothing's probably ever simple in Hartford, but it seemed to me that a small adjustment in the fee could go a long way to helping with the financial issues. The $5 a year is really a tiny amount, with the licensing fee being up close to $600 per year. And also perhaps could be appended onto anything that the compact decides to do. Your second issue is probably a little more complicated. From there, I wonder if you think the makeup of the group, do you think the makeup of the group needs input from other people than what are listed in the bill? I don't know if you had a chance to take a look at that specifically.
You know, I think the makeup of the group, what's worrying me about the task force is I do think it's very appropriate who you have on each task force. What's worrying me is that I had a little agita when the gentleman from the Department of Defense was testifying, because he was listing so many different professions that have potential to apply for the compact. And we're going to have to do an individual analysis for each compact contract. And we're going to have to be comparing each one of those. So in theory, my organization, where I only have 12 employees and I have no one to designate this job to, we could be in a lot of different working groups. And I'm worried that the time frame, so less so the people at the table, I'm more worried about the time frame of these work groups starting in July and having to have a full-fledged report ready for January, when there may need to be legal research on whether or not the compacts are going to be violating confidentiality or other protections that are in our current state statutes.
I appreciate that. Probably be a little more complicated than we think it will be. So that gives us more to think about, and perhaps somebody from Haven or somebody from one of the societies can be quote the representative from a appropriate state professional association. But I guess that remains to be seen. But thank you for taking the time.
Thank you.
Thank you, Ms. Dinnan. I don't see any other hands. Thank you for your time and your testimony.
Thank you.
Next up is Tom Kassan.
Hi, good afternoon, everyone. Chairperson Abrams, Chairperson Steinberg, and the members of the Public Health Committee. My name is Tom Kassan. I am an active physical therapist, and I am Public Policy Chair of the Connecticut chapter of the American Physical Therapy Association. I am here today to testify in support of HB 6449, particularly the Interstate Compact provisions in Section 2. The APTA of Connecticut strongly supports Connecticut's participation in this PT Compact. For reference, a PT Compact is an interstate agreement between member states to provide a state-developed collaborative structure to protect the public by increasing consumer access to PT services, by reducing regulatory barriers to interstate mobility and cross-state practice. Currently, we have 21 states currently active in the PT Compact already, with another 8 states having passed the necessary legislation, just still in the implementation phase. So it definitely seems the direction that the rest of the country is moving towards. PT and PT assistant licensees who meet all eligibility requirements can purchase the compact privilege in a compact member state, and in most cases are able to start practicing PT in the other state almost immediately. The online system makes the process of purchasing and renewing the compact privilege in other states pretty simple as well as making it easy for patients and consumers to verify the status of the compact privilege for their healthcare provider. As others have mentioned today, the onset of COVID-19 pandemic, we've seen a tremendous surge in the use of telehealth, myself included, in PT and across many other disciplines. It's shown the value of digital technologies as a complement to any in-person or hands-on PT care. It's also exposed an opportunity in some situations where the current licensure structure could be improved upon to just further provide better access to patients for PT services. For example, if Connecticut joined the compact, patients would be able to continue care with their providers if they were to be on vacation or traveling out of state for any extended periods of time. This could be the difference in a patient making a faster full recovery and getting back to work sooner, also preventing any nagging conditions from becoming more chronic, which would require further additional healthcare services and utilization of the system. We've also seen this interplay with PTs who practice in school settings, whose students go to school in Connecticut, but they move back home or are out of state due to digital services, and those PTs have been unable to reach those children due to current compact issues. Second situation, specifically regarding travel physical therapists, the lack of a state compact complicates practice for these clinicians. It's very difficult, time-consuming, and financially taxing to practice in multiple states currently. Many states who need PTs to practice in rural or underserved areas, these PTs face severe challenges filling these needs because of the difficulty, time, and financially in obtaining licenses in other states in a timely manner. In order to work in that environment, a PT might have—
hit your 3-minute mark if you wouldn't mind concluding your remarks.
Absolutely. We'll have to just hold numerous PT licenses to be able to practice in as many states as possible, which creates financially taxing for both the provider and reducing access to patients in need. Finally, the compact would provide flexibility for CT facilities that provide PT to fill short-term staffing needs for emergencies, maternity leave, et cetera. PT providers would have additional flexibility to find quality short-term staffing in a pinch to meet these patient care needs. And Connecticut would be a more desirable location for PTs to move to reside, since they would have easy access to the licensures in 29 states and counting. Again, thank you for the opportunity to testify, and we look forward to working with you all throughout the session to address this issue.
Thank you, Mr. Casson. I don't see any hands raised, so thank you for your time and your testimony.
Great, thank you. Have a great afternoon.
You too. Next is Janet Kling.
Hello.
Hello.
Hi, dear Madam Chair, Chairman, ranking members, and esteemed members of the committee. I am Janet Kling of Darien, and I am testifying against Bill PHB 6424. I find this bill's requirement of Connecticut health providers to collect data, including but not limited to race, ethnicity, and primary language, very concerning, particularly in today's post-COVID environment where Asian Americans have experienced a large increase of racially motivated hate crimes and violent attacks due to misunderstood association with the COVID-19 virus. I know ethnicity data is collected at the federal level. However, that is a uniform data collection for inclusion in surveys conducted by the HHS. Unlike this bill that makes health providers collect ethnicity data at the individual health record level. This poses huge privacy concerns, especially when outside vendors are used to maintain the health information exchange system. There is no language in this proposal that addresses any data privacy or security issues. Having this data collected at the individual level could subject the patient to systemic racial profiling for life. From Ms. Veltri's testimony earlier, she stated that Connecticut's disaggregation of data would be going even deeper than current federal efforts and requirements. The further dissection within each race is what's very dangerous, in my opinion. Even though she said no groups are being singled out in this effort, yet she used Asians as her first and only example. Is it because Asians represent newer generations of immigrants, so we're less American than other demographic groups? Also, Ms. Veltri's answer to Representative Foster's question earlier that she wasn't aware of any instances racial and ethnic data collection negatively impacting groups of people. I want to again remind her and the committee what Senator Tony Hwang had reminded all of us that about the history of state-sanctioned discrimination against Asian community and the on-the-record education discrimination of Asian American children. And now post-COVID, I feel that we're in an even more vulnerable position to be targeted from a health perspective. There's also growing anti-China sentiment in both the US and globally due to its authoritarian government's actions. So you'll forgive me if I'm dubious of how this data collection proposal will not lead to discrimination of Asian and Chinese Americans in particular. There is tremendous unintended consequences from this proposal. And even though Ms. Veltri alluded earlier to following privacy standards, there's currently no detailed guidelines or standards developed to combat risks such as this data being hacked or illegally obtained. Further, she stated that there hasn't even been a set of standards developed for exactly what demographics will be disaggregated upon, even though she claims it's her goal to do so for all races. Without doing it for everyone, we will absolutely feel singled out because, as we've heard even on this hearing, that only the Asian American race is being further dissected at a more granular level using ethnicity currently. So this bill needs a lot more work before it can be considered, in my opinion. And to Senator Sommer's point earlier, this data collection needs to be opted in as opposed to having to be opted out from. So I urge the Public Health Committee members to reject this bill as it stands. Thank you so much for listening to my testimony.
Thank you, Ms. Kling. We do have a hand raised. Senator Hwang.
Thank you, Madam Chair. And Janet, thank you very much for your testimony. And I see the New Year's celebration is up. And thank you very much for sharing that special New Year celebration. Let me get to the point. From the standpoint, we had talked about your children being of mixed race background. I think one of the most powerful things is we have always taught our children, my children as well, that they should be judged on who they are and the content of what they bring to the table, not by their race and ethnicity. And how do you answer that question of kind of looking so hard to define by race and ethnicity in this entire conversation?
Well, yeah, I mean, at the high level, I am personally against any identity politics, because I do believe that we should be judged not by the color of our skin, but by the character of our character. But I heard a lot of testimonies by health officials earlier, and I understand their intentions of getting this data in order to identify certain diseases that are that could be identified more using ethnicity, that because they're the origin of their ethnicity do contribute to higher instances of such illnesses. However, I feel that either you do it for everybody, if that is your goal, then it needs to be done. It needs to have very, very detailed mapping for every single ethnicity. And I don't see that currently in the plan. And I feel that, to answer your question, Senator Huang, I don't know how to answer, if one of my children asks me, why am I, identified as Chinese American versus, another type of Asian American, I don't even think that they should be identified solely as Asian American. But, if we're going to identify further, I think it's even more problematic that we're now pitting one Asian American against another in the name of, for health equity, that I don't really think is there.
I appreciate that, and I think sharing common heritage and sharing the experience, we fall under sometimes the guise of the model minority perception. And but at the same time, as Dr. Everett said earlier, what you see in the model is not understanding each individual's background, right? I myself immigrated this country, lived in a federal housing project, grew up in a very urban setting, was a Head Start kid. You know what? At the end, I take great pride in being a Chinese American, but I take greater pride in being an American. And that being said, I'm not looking to get segmented. I'm not looking to pit one ethnic group against another. And my concern, as well-intentioned as this data may be used in some ways. And I think another basis of that is the fact that we cannot always trust data. There's a history of governmental malfeasance. And in some cases, that there's a tremendous distrust. Where is this data going? Do you share those kind of viewpoints?
Absolutely. I think it is. I feel that within this bill, there is no clearly spelled out formula or ways to address security and privacy concerns. There's no guarantee that we will be protected from such ill-intentioned hacking of this data. And on top of that, I feel that dissecting it further down to within the Asian American community by like 17 different countries is not only not helpful, I think it's misguided. Even if you're saying, or within China, just because someone checks off Chinese, China has so many different indigenous groups within China, and they all have different DNAs. I mean, are you just assuming they're all Han Chinese? This is a really slippery slope. How far are you going to go? There are so many minority groups within the Chinese, ethnicity. So I don't even think it's helpful, for the intended goal.
Yeah, it's interesting. You bring up actually an interesting point. Why not consider religion as a segmentation? And we have seen evidence where data hacking has occurred, the best of intentions, when those data go out, and we have seen documented cases. And for many of the Asian Americans that are opposed to this, it's not just an extension of disaggregation of this data, but they have seen proven evidence that if this data is used elsewhere, that it could be used in college and school admissions standards. And that is also a whether it's a relevant correlation or not, it's a real perception. So I wanted to point that out, that many of the advocates who oppose this see this as a potential slippery slope, that data could be collected in other areas that could create some opportunities to be able to discriminate against them. So I thank you very much for your time on this. And thank you, Madam Chair. Thank you for coming to testify.
Thank you for listening.
Thank you, Senator. Thank you, Ms. Kling. I don't see any additional hands, so thank you for your time and your testimony.
Thank you.
Next up is Richard Marianos.
Thank you very much, committee. Can you guys hear me?
Yes, we can. Go right ahead.
Thank you very much this afternoon for giving me the opportunity to speak to you in opposition of House Bill 6450. I'll try to make this as brief as possible because I agree with the governor's assessment of prohibition does not work in trying to ban flavored products and specifically trying to look at ways we can make the situation better without losing $130 million of our state budget by throwing the baby out with the bathwater. What I wanted to talk about that's important when we look at the flavor bans, and specifically so you can understand that this is the real predators in this marketplace, the real predators to the kids and our children are the ones that are manufacturing liquids and high nicotine value liquids disguised as Captain Crunch, Cherry, Skittles, anything that's out there that's appealing to some of these kids that is going into these open systems to include THC and marijuana. And I think that what I would like to stress here, make a suggestion, is if we could use some of our efforts to concentrate on who the predators are and who the violators are, instead of trying to throw out the entire initiative and hurt the state's financial resources, I think we could probably do a much better job. My background is I'm a 27-year law enforcement and veteran. I retired as the assistant director with ATF, and I currently work at Georgetown University, where I teach classes and do case studies in the new face of organized crime, which is contraband and criminal tobacco trafficking. And what we're seeing lately as we're watching people devolve and trying to, change their vape portfolio or their vape initiative is counterfeit vape products that are coming from all over the United States. I have a list here of hundreds of thousands of disposable vape cartridges or open system vape cartridges exceeding the amount of millions of dollars that are being trafficked into some of these states. And I just ask you to please take this into consideration without throwing a prohibition in and trying to come up with a compromise to really go after the predators and not hurt business and your financial situation in the state. And I look for any questions, and I'm honored if you have some to answer them to anybody. Thank you very much.
Thank you, Mr. Marianos. I don't see any hands, but we have your testimony, and so folks can circle back if there are any questions.
Thank you very much, and thank you for putting this together. I know this was a lot of hard work on your part.
I would thank the staff. Thank you. Have a great day.
Have a great afternoon. Bye-bye.
You too. Next is George Lopez. Oh, you're muted, sir. Oh, try again. You're still muted. There you go.
Okay, great. Thank you very much. My name is George Lopes, and I live in New Haven. 4 months after contracting COVID-19, I'm still battling symptoms: a lingering cough, sore throat, shortness of breath, fatigue, and memory loss. I often lose my voice mid-sentence, become winded after climbing the stairs, and rely on an inhaler, which I never needed before. But I'm not complaining. I'm one of the lucky ones. 902 Black Connecticut residents have lost their lives to COVID, including 3 of my close friends. I had text one of those friends, Danny, to check in. I asked how he was doing, and he said he was okay, but he was in the hospital fighting the COVID-19 virus. Knowing his pre-existing health conditions, I became concerned, but also encouraged that he wrote he was okay. I wished him well, said that I would pray for him, and signed off. After a week later, I again reached out to Danny to see how he was doing, and he told me he was at home, and of course I thought he was COVID-free and said, great. He then told me he wasn't out of the woods yet. He told me he still had COVID and that he still needed my prayers. I said that I will, and we signed off. After 4 days later, I texted him and didn't get a response. A few days later, a mutual friend of both Danny and I told me that Danny died at home from COVID-19. At that point, I became angry and I left, and I'm left with more questions than answers. Why was Danny released from the hospital after spent his previous days relying on a ventilator to breathe? Why Danny had been prematurely released had he been white? Would he have received better care? Would he still be alive? I don't want to speculate. I shouldn't have to speculate. If Connecticut collected standardized data by race, ethnicity, and language, then I wouldn't have to guess and wonder. We could know definitively who by race, ethnicity, and language is receiving adequate care and whose quality of care needs to be urgently improved. Danny was only 50 years old. He should still be here. Healthcare disparities in Connecticut have existed long before the COVID crisis. My family has experienced this firsthand. Both of my daughters and one of my grandchildren have asthma. My oldest daughter went to the hospital almost every month the first year of her life because we later found out she had severe asthma. When my youngest daughter was born, we realized she too had asthma. Both of my daughters are young adults with severe asthma to this day. One of my grandchildren also was born with asthma, and when she was a little older, she couldn't use her inhaler at school unless a nurse was present, and there wasn't always a nurse at her school. Asthma is
Mr.
one of the,
Lopes?
yes,
Mr. Lopes, you've reached your 3 minutes if you'd like to conclude.
okay. By collecting standardized race, ethnicity, and language healthcare data, we can identify and address racial inequities across healthcare in our state. This is truly a matter of life and death. I urge you to vote yes on HB 6424 so that we can understand unequivocally who is suffering from poor health outcomes and provide targeted interventions to tangibly improve the healthcare for hundreds of thousands of Connecticut residents. Thank you very much for your time.
Thank you, Mr. Lopes. And I'm glad you're feeling better. And I'm really sorry to hear about the death of your friend, Danny.
Thank you. I appreciate that.
We do have a question. Representative Pettit.
Thank you, Madam Chair. No, just a comment. The same thing, Mr. Lopes, very sorry for the loss of your friend, and I encourage you to continue to reach out to the medical community because the whole science of prolonged COVID is under active investigation. There's new therapies every month evolving. So I wish you the best and hope you can continue to be in contact with the medical system to get the best possible care. Thank you, Madam Chair.
Thank you very much. Appreciate that.
Thank you, Mr. Lopes. Thank you for your time and your testimony.
Thank you.
Next, we'll hear from Roxanne Rotondaro. Don't know if I pronounced that right.
Good afternoon. My name is Roxanne Rotondaro. I'm from Hartford Healthcare. I'm the Senior Director of Population Health and Patient Safety for the medical group. And I'd like to say good afternoon to the senators and representatives and members of the Public Health Committee. Thank you for the opportunity to testify on House Bill 6424. We are testifying in favor of this bill for the healthcare providers to participate in the health information exchange. As Vicki Veltri reported earlier, in 2018, Hartford Healthcare Medical Group received a grant from the Office of Health Strategy under the State Innovation Model Program, in part to support the development of a uniform method of collection to get expanded race and ethnicity information reported by our patients into our electronic health medical record. We also used the race and ethnicity information to identify health disparities within 12 of our offices within the medical group, focusing on diabetes. And we created interventions because we did find disparities. And we used this intervention to get care management and behavioral health services to the target population in order to connect them with services and provide support to help improve their outcomes. Hartford Healthcare has continued to collect demographic information system-wide. We also have an office on health equity led by Vice President Sarah Lewis. Over the past year, this data became the basis of a dashboard developed by Hartford Healthcare to track how COVID has impacted patients by race and ethnicity. This data is also being used to help us target the HHC's testing and vaccination outreach efforts to communities of color, and to also track the uptick of the COVID-19 vaccine among demographic groups. The COVID-19 pandemic has given our organization a renewed sense of urgency around the responsibility to root out inequities, break down barriers, and foster trust in the underserved communities. We look forward to working with the Office of Health Strategy to operationalize the requirements of this bill. Thank you for the opportunity to express our support.
Thank you, Ms. Rotondaro. We do have a question from Representative Pettit.
Thank you, Madam Chair. Thank you, Mrs. Rotondaro. I wonder if you could comment about the frontline or nuts and bolts aspects of this. There's been testimony earlier today about people suggesting perhaps there should be a opt-in, that there could be a box that's other, that people didn't need to do that. Is there anything that HHC is doing along those lines voluntarily already in terms of allowing people to opt in or to make sure that people's privacy is protected?
Yes, thank you for the question. When we implemented this, we are allowing people to opt out. We also have, we have a selection of patient declined. We also have a selection of not collected in case it's not collected. And we allow for multiple choices. So one doesn't need to choose one specific, they can choose multiple selections to truly identify themselves with how they identify.
Meaning that there's another and then a fill-in if they don't feel like they see what's there, that you can fill in what you think is the appropriate description?
Right. So the database that we took to expand our race and ethnicity was from an agency or an organization within the state of Connecticut that looked at the demographics of the state and said, here's the most popular race and ethnicities broken down into detail across the state of Connecticut. We built our choices based on that, but we also have other. So if I wanted to say that I am African-American from, I can't even think of a good example, but if I wanted to say I was from multiple backgrounds, if I wanted to say that I was Chinese, African-American, and Hispanic, I could say all of that. And it would break down into more levels below that. I can't hear you.
You're muted.
Have you had feedback from the people who collate the data that there's been any issues created by allowing people to create their own categories, if you will, or to fill in the box, or has it been pretty smooth from the point of view of the people who collect and then try to analyze the data?
Well, we started with only 12 of our offices in the medical group, so it hasn't been widely expanded. And before we actually implemented it, we did do training with the staff. Just like Dr. Everett had said, we really need to teach people how to ask the questions. And we did it on paper before putting it into Epic because we wanted to know if it was actually, if people were going to participate. And we did find that people were participating and wanting to identify with multiple race and ethnicity. So when we did the paper survey, we had over 50% of the people who filled out the survey identifying with multiple race and ethnicity. So that was very interesting to us, but it hasn't been in place long enough. We haven't looked at the data in detail yet.
Just one more. Did you get, not to throw anybody under the bus, did you get any pushback from office managers or people in busy practices going, oh my God, you're asking us to do one more thing. We don't have the time to do this. People have to sign 10 pieces of paper to come in. Did you get much pushback from the front lines?
We sure did, but we overcame.
Thank you, and thank you, Madam Chair.
Thank you, Representative. I don't see any other hands. Thank you so much for your testimony and your time.
Thank you.
Next up is Angela Harris.
Good afternoon. Can you hear me?
Yeah, go right ahead.
Okay. Good afternoon to the chairs and members of the State of Connecticut Public Health Committee. I am Angela Harris. I am the chair of the Phillips Metropolitan CME Church Health Committee. But more importantly, today I come to you as the North Hartford Promise Zone NRZ resident liaison for the Health and Wellness Initiative in the Promise Zone. We are here in the state of Connecticut, which is really two Connecticut's. There are huge disparities that we have been unveiled during this pandemic. And I come in support of House Bill 6424 to ask you to move this bill forward to passage. This is a critically important tool in the toolbox to addressing some of the inequities and disparities that have been identified. We don't have time to waste. This bill has been before you before, and it is during this pandemic that I'd ask you to lift this up to passage. REL data can inform preventative care. It can inform further connection to medical homes. It can inform insurance enrollments. It can even inform research and clinical trials. We, as the state of Connecticut, have the opportunity to lift up the measurement and use of data towards improving health outcomes, as well as leading with the focus on equity in again, a tale of two Connecticut's where we are listed as one of the most, one of the richest states per capita in the union, but we have some of the poorest cities in the nation, thus the designation of the Promise Zone by the United States Housing and Urban Development. We don't have time to waste. Our lives depend on the decisions that you make here today. We don't have the luxury of putting this off and tabling it until another day. Connecticut can lead and provide an example for the nation. There are other states that have already adopted the standardized use. And again, this is voluntary data. Hospital systems, if I switch from, Trinity Healthcare to Hartford Healthcare, they need to be able to transfer my medical records and provide the broad view, and the systems be using the same methodology to track the information.
Ms.
Right
Harris,
now,
you've reached your 3 minutes. If you'd like to conclude.
yes, right now we're living in a time where life expectancy is huge. Between 3 miles away at West Hartford, there's a 16-year life expectancy gap. And until such time that there aren't disparities, this wouldn't be important. But since it is, we need you to act now and put the resources where they need to go, and the ability to communicate what resources are available in our communities of color. So I thank you, and I'd be happy to answer any questions as to how this plays out in communities. Ready to take any questions you might have.
Thank you, Ms. Harris. I don't see any hands raised, but folks can certainly follow up because your testimony is posted. So thank you so much for your time today. Next up is Zhen Wu.
Can you hear me?
Yes, we can. Go right ahead.
All right, thank you. The esteemed member of Public Health Committee. My name is Zhen Wu, and I'm a resident of Avon, Connecticut. I oppose HB 6424. Firstly, it's misleading to use race and ethnicity to solve social problems. Medical care help is targeted to individuals who need it instead of people checking the same box. It is illegal for healthcare providers to refuse services based on race and ethnicity. All patients should be given equitable treatments regardless of their race and ethnicity. It is unnecessary to collect such catalyzing information. Secondly, race and ethnicity is not an effective diagnostic criteria. Even the FDA does not approve race-specific drugs. Hospitalization and death disparity in COVID pandemic are due to other underlying conditions that affect health, including income, access to healthcare, and exposure to virus related to occupations, such as frontline, essential, and critical workers. How to help a patient? Just examinations, tests for diagnosis and medical treatments. It makes no sense that doctors treat the patient by asking their ancestors' origins. A lot of Asian Americans are very upset to be singled out as Korean, Japanese, Chinese, Filipino, or Vietnamese. Any government effort to do such data disaggregation would be a waste of taxpayers' money. Thirdly, HB 6424 will put the state in huge liability in data security and training personnel to handle those data. I did not see any detailed policy to protect and secure the collected data. Furthermore, I wanted to point out the big difference of HSOMS, that's the statewide health information exchange. HIE is not a survey. The patient's demographic information will follow the patient's medical record lifetime. There's a huge risk of data leakage. I'm concerned raised sensitivity data is used for something else. We, over 100,000 Asian Americans in Connecticut, are super upset and angry for dividing us with our taxpayers' dollars through such dangerous bills like HB 6424. Thank you for your time to hear my voice. I urge you to vote against HB 6424.
Thank you, Ms. Wu. I don't see any hands raised, so thank you for your testimony and your time today.
Thank you.
Next, we're going to hear from Stephen Karp.
Thank you, members of the committee. My name is Stephen Weinstein Karp. I am Executive Director for National Association of Social Workers, Connecticut chapter. We are the largest organization of social workers in Connecticut. We're here in support of 6449. In the field of social work, regardless of where you get your degree, your MSW degree, you have the same core curriculum, you have the same competencies, because the National Council on Social Work Education approves and accredits all programs. No matter where you take the exam for social work throughout the country, you're taking the same set of exams, because the exams are all done through the Association of Social Work Boards in every state utilizes them. No matter what state you look at for licensing of social work, all the states have either very similar or greater requirements to the state of Connecticut. So when we look at individuals coming in from out of state, they've already been licensed somewhere else. They've been documented as having the experience necessary. They've taken the exam. They have the degree that's recognized across the country. It makes no sense for us to create barriers and obstacles for those people. You know, we hear from people all the time moving into Connecticut. Some have a few years experience. Some of them have multiple decades of experience. For these people to try to find supervisors from 20 years ago, documentation of employment hours from 20 years ago, is just very difficult. And it's really an obstacle, and it really makes it, it doesn't make us very welcoming, and it doesn't protect the public in any way, because these folks are already experienced, they're already licensed. They've already been documented as such in another state. We have shortages in certain aspects of social work practice in Connecticut. In the field of aging, and Connecticut has a very high aging population, we do not have enough social workers in the field of aging. We don't have enough social workers in the field of addictions, and we very much do not have enough bilingual social workers in Connecticut. If we were to make our requirements easier for people to move into our state, we might be able to address some of those workplace shortages. We note that the governor's executive order sort of sets some precedents, because the governor's executive order allows any licensed healthcare practitioner to treat an individual in Connecticut, regardless of what state that person's licensed in. We've not heard of problems arising from that or difficulties that have been created for public safety. So it seems to us that if we're already allowing this, that 6449 is a very sensible approach. And again, for the field of social work, where there's such similarities between the states, we really strongly urge this committee to pass this bill. Thank you.
Thank you, Mr. Karp. That's very helpful to add to the conversation. I appreciate it. I don't see any hands, so thank you for your testimony and your time.
Thank you.
Next, we will hear from Cal Patel.
Senator Abrams, Representative Steinberg, Senator Summers, Representative Pettit, and esteemed members of the Public Health Committee, thank you for the opportunity to offer testimony regarding Senate Bill 922, an act concerning revisions to the statute pertaining to discharge in residential care homes. My name is Cal Patel, and I am the past president of Connecticut Association of Residential Care Homes, also known as CARCH. I have a residential care home in Essex, Connecticut. CARCH has been in discussions with the administration, including OPM, DPH, and DSS for several years now on how to ensure that our model of care could be considered a home and community-based model under federal regulations. Understanding the utility of the services being provided on the waiver, we propose a two-tiered model of residential care homes. Unfortunately, that is not in the legislation in front of you. Most residential care homes are a small communal living arrangement, averaging about 24 beds, with most bedrooms being shared and often shared bathrooms. It is a congregate setting with meals and other activities done together. The great majority of our residents are low income with mental or substance abuse disability. As you can imagine, the home is a community, and one disruptive resident can have a great negative impact on other residents and the staff. Our residents are not in private apartments, but the bill would apply the tenant lease laws to our residents and allow the appeal to Superior Court. Our understanding is that this appeal could take up to a year from when the final discharge is determined appropriate by the Department of Public Health. Instead, we would propose a final appeal to the Department of Social Services or another agency once a final discharge decision is determined by the Department of Public Health. This would provide a comparable appeal while avoiding a costly delay. I want to emphasize the federal regulations require a comparable procedure, not the exact procedure. In an email last year to DSS, a CMS official wrote, in terms of compliance with the settings criteria, CMS required that the state assures that the agreement provides protection that address eviction process and appeals that are comparable to those provided under the jurisdiction of the landlord-tenant agreement. Residential care homes do not want to involuntarily discharge residents and only try to do so if serious circumstances are warranted. When a residential care home undertakes the current process for involuntary discharge, it is usually because a resident needs a higher level of care, as residential care homes do not provide medical services, or the resident is affecting the health and welfare of other residents. In the past, some examples of residents across the industry being discharged involuntarily have included residents who smoke continually in a room and literally created a fire in the home, or other fire risks, or residents who have been made physical violent threats to staff and other residents. Unfortunately, a resident with a mental disability can be refusing to take medications and sadly conducting himself or herself in a way that is disruptive to the lives of other fragile individuals. Again, I want to
Mr.
emphasize
Patel, you've
our
reached your
residents.
3 minutes if you'd like to give a conclusion.
Our residents are not living in an apartment by themselves. We understand the dynamics of this issue can be confusing. We have outlined current discharge process. Finally, I want to note that this is being done in the name of the home and community-based waiver. This was the deadline for compliance was extended to March 2023. We eagerly are willing to work on the nuance of the Superior Court portion of it with the appropriate agencies. We do have till 2023. Thank you. I appreciate the opportunity.
Thank you, Mr. Patel. I don't see any hands. Thank you for your testimony and your time.
Thank you. Appreciate it.
Next up is Adam Bentley.
Hi. Thanks again for having me. Chair Abrams, Chair Steinberg, Ranking Members Wong, Summers, and Pettit, and members of the Public Health Committee. Thank you for the opportunity to testify. My first time ever. And today I come in support of House Bill 6449, and it's accepting an act expanding economic opportunity for occupations licensed by the Department of Public Health. So my name is Adam Bentley. I am the manager of optical field operations for Warby Parker. I'm a licensed optician as well in New York, Ohio. I'm also registered in California, and I'm currently working on licensure in Connecticut as an out-of-state licensee. My goal is to be able to come to support my team in Connecticut and help Connecticut consumers as a practitioner. You know, Warby Parker currently has 3 retail locations in the state. We have in Greenwich, Norwalk. We just opened our new store in West Hartford and West Farms Mall. You know, we would like to expand further, but have found that the laws and regulations governing opticianry have presented some challenges. You know, we support House Bill 6449 because it would make it easier for the Department of Health to approve licenses for Connecticut residents or the spouse of active duty military personnel stationed in Connecticut who are licensed in other states. You know, however, when it comes to the licensing and regulations of opticianry, you know, we wish the legislation went further. And as it was shared previously, in opticianry, Connecticut's education and licensing requirements are outdated and among some of the most demanding in the country. Like the apprenticeship hours are 8,000 or 4 years versus 2 to 3 years in other regulated states. The Department of Public Health is limited in approving optician licenses in other states unless their state's requirements are greater than or equal to Connecticut's. So this forces qualified opticians licensed out of state to take the Connecticut's licensing exam, which also has a failure rate significantly higher than national exams or exams in other states. And then contrary to ensuring a high quality of service or care for Connecticut consumers, the current regulations have led to a shortage of opticians in the state, you know, coupled with regulations that we believe force optical stores to close when an optician is not on site. Warby Parker stores can't provide the vision services to our customers 7 days a week and have had to close intermittently due to the routine absences of opticians for illness, personal times, etc. So as the committee knows, Warby Parker is committed to working with the Department of Public Health, other stakeholders in this committee on comprehensive updates to Connecticut's optician statutes. House Bill 6449 is an excellent first step to help meet Connecticut's optician needs. Still, you know, we respectfully request the committee consider going further to update the code and improve optical services for Connecticut consumers. Thank you.
Thank you very much for your testimony today, Mr. Bentley. Appreciate it. I don't see any questions, so have a nice day.
Okay, thank you.
You're welcome. Next is number 57, Suhuna Zia. And please, I apologize if I'm saying your name wrong.
Oh, no problem. Hi, can you hear me?
I can, go right ahead.
Oh, all right, thank you. Hi, thank you, the Public Health Committee and all the congressmen, congresswomen. My name is Sehua Shah, and I'm a resident of Orange. I have submitted my testimony to online, and it's online. Now I will just give some explanation of my testimony. The first thing I want to say is that there's a lot of statistical minority in a huge data set. Okay, so for example, if white is majority, right? However, if you look at a white male age 90 and over, that's a minority. And same like for Chinese, they're majority in Chinatown, but Chinese can be a minority in Woodbridge or Orange or somewhere else. So even you have data, you have millions of people, but given this new technology and this AI algorithm, it is very easy to identify the statistical minority. And then once you identify that, right, and the more social demographic factors, those things you put in the data set, it will be more easier. It will be easier for the using the algorithm to identify those statistical minorities. And then the patients, the health information privacy is in great danger. And when this HIE system is available to so many people, like healthcare providers and the business entities and all kinds of organizations. And the second thing I want to mention is the, yes, this HIE project, the state is not going to fund it, right? And then the HIE project has generated revenue. And I see that they're already selling these data for profit reasons to those different business entities. And we know for insurance, the bigger the pool, the more cost sharing is. And when you give those insurance companies all these data, they can price people on their socioeconomic factors. And then they can cherry pick the low risk groups and charge high price on those high risk groups. I think this is not what we want to, right? So this social demographic data being available to so many like business entities, to those people who pay for it, right? I think this is not a good idea. And also, at last, I want to say that for this bill, asks the state to adopt the standard developed by U.S. Department of Health, Human Service, and Office of Minority Health. This standard was used, is developed, still is, for the health. This is called the National Health Survey. So this is used for survey, and survey is a random sample of population. But if you use this standard in this medical database, essentially it will follow everybody, right? And everybody will be racial profile for the rest of their life once they are in the database. I think this is not right. And I want to show you that this is,
you hit your 3
okay.
Thanks.
All right. So this is the standard you will see in the healthcare department, right? And you see, and this is a standard used for the racial profiling, right? I think if Asian Americans, they see how they profiled versus the rest of the those other races, are more likely to get a heart attack or something like depression, rather than feel they are taken care of or protected. And that's all I want to say. And thank you very much for giving me this time to testify.
Well, thank you so much for taking your time to come and express your views to us. We do really appreciate hearing from you. I don't see any questions, so have a nice day. Thank you for being here.
Thank you very much. Thank you.
Next is Mark Spellman. Mr. Spellman, go right ahead.
Hi, thank you. I'd like to thank the committee for hearing our testimony. I'm speaking as a psychologist. I'm an executive member of the Connecticut Psychological Association. I'm in private practice in New Fairfield, Connecticut. I'm also licensed to practice in New York. I want to address just one specific element of House Bill 6449, and that's to urge the passage of PsychPact, which regulates the interstate practice of psychology across state lines. For some professions, there may be the need for further study for how to best do telehealth across state lines, but we've been studying this as a profession since 2015. In 2016, the first state, Arizona, adopted PsychPact. 15 have adopted it now, and another 15, including Connecticut, are considering legislation to join PsychPact this year. PsychPact's good for the Connecticut resident. It improves consumer protection and increases access, especially to specialty care. It's good for our patients. It lets them see us as they move around the country. And in times of COVID, people are moving around a lot. It enables us to do transition planning, gentle termination and handoff for 30 days across state lines. And, you know, we often testify for what's good for Connecticut citizens and what's good for our patients. But we particularly need this for us, psychologists. It's the Wild West out there in interstate practice. Please be the sheriff, protect us, pass PsychPact. Thank you.
Thank you, Dr. Spellman. I want you to know that when I looked at this bill, I had the same reaction because I know that PsychPact is further down this road than some of these other areas. So
I'm so glad to hear it.
I am advocating as well.
Thank you.
Thanks for being here with us today. Next, we have Anita Shepker, number 60. Oh, I'm sorry. Is Bo Yang there? No, I don't see him. So we'll go to Anita. Anita Shepker.
Good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Anita Shepker. I'm an attorney and a lobbyist, and I'm here on behalf of the Connecticut Psychological Association testifying on and using Drs. Russo and Bunk's testimony from the Connecticut Psychological Association, asking you to consider the passage of PsychPact this year. You've heard a lot of testimony about licensing. I think what's different about SciPact is right now, as you know, pandemic aside, we've known that there's been this need for behavioral health services. Right now, traditional telehealth talks about Connecticut providers providing telehealth to Connecticut residents intrastate, within the state. What SciPact does is two things. It allows for a patient who is, let's say, gone to college in Illinois to be able to continue to see their Connecticut psychologist, have a continuity of care and access, only if that state that that person has gone to also is part of SciPact. So telehealth across state lines, following a Connecticut patient to another state. The second thing that SciPact does, which is a little different from the other licensures that you've been hearing, is it gives a temporary license, if you will, or temporary pass for a psychologist to practice in another state that's authorized, again, in the compact, to do face-to-face consultations for a period of only 30 days, a day defined as if you work for 2 hours in one day, that day counts as a whole day. But for temporarily to work face-to-face in another state. And this happens all the time with psychologists who do consultations, et cetera, without them having to get another license. It in no way, SciPact does not require or allow you to practice full-time, face-to-face without a psychology license in any of these states. So I just wanted to clarify that. I do think that you heard from Dr. Spellman, 15 states have now passed SciPact. 15 states are considering SciPact, I think largely because of what we've seen during this pandemic and the need for continuity of care and behavioral health services. You've also heard a little bit about Haven, and we'll be talking to Maureen Dinnan about Haven. The way that SciPact works is it can't revoke a license, but what it can do is suspend it if somebody says or we're notified that they're in an alternative program and they need a break. But we don't suspend anybody's license, nor does the compact have the authority to do that. And the last thing I would bring up is that SciPact does require, the one requirement on the state, you can charge psychologists each $10. The state is allowed to charge them for being a member of SciPact. But it also does require the state within 10 years to say that any psychologist who is entering the marketplace and licensed in Connecticut must engage in a background check and fingerprinting, probably at the cost of that psychologist. But I just wanted to put that out there so you would know that. So I thank you. I'm glad to answer any questions. Again, it's a little different than full licensure, but I think it's an important additional tool for people seeking behavioral health services. Thank you.
Thank you very much. Representative Pettit.
Thank you, Madam Chair. Mrs. Shepker, thank you. How many, I may have seen it, but I don't recall, how many of the surrounding states are involved in SciPact?
You know, I have to look at the list. I think New Jersey is in. You're taxing my memory. This is why Doctors Bunk and Dr. Russo were supposed to testify. Let me just try to call that up for you.
And do you think one of the things we've also discussed is a need for more mental health professionals, as you referred to? Do you think this would be a positive recruitment tool? I assume it would be, unless we are surrounded by states that are all in it, in which case it might not make much of a difference.
You know, I'm looking now, I see Illinois. We don't have a lot of surrounding states. I think New Jersey is the closest right now, but there are pending surrounding states. I do think there's a dearth of these professionals. We are backlogged with folks. COVID notwithstanding has had its own toll on behavioral health, as you know, people dealing with PTSD, people, healthcare providers, first line workers, people staying at home, dealing with depression and anxiety. I do think it is something that will increase access and very necessary. And I'll get back to you with the states. I apologize.
Well, it's okay.
I knew you were going to ask me a hard question.
I was just data. And you talked to the license suspension, so you don't think the issues that Mrs. Dinnan brought up in terms of Haven and people who have issues would be very complicated given this kind of arrangement.
I do think they can be worked out. I can speak now as a lawyer, not as a psychologist. I do think that SIPAC goes out of their way to make sure that they do that whatever agreement we reach does not conflict with any state law. And so I think we could definitely work that out.
Thank you. Thank you,
You're
Anita. Thank you, Madam Chair.
Thank you, Representative. And thank you very much for your testimony today. I do know, I was approached on this years ago because of having some colleges in my area and psychologists who were working with students and then they leave. And I think that your point about the continuity of care is so important because if a young person is able to connect with somebody and they continue to need that support when they're back home, it's really important that they can get that. So
right. And I think college is the perfect example because oftentimes young adults go off to college and the resource that's made available to them in terms of behavioral health may just be the school's behavioral health, and they don't have that relationship necessarily with the provider that they've been seeing. So that remains really important.
Right. Yeah. And even in the summer, some kids go away with their families to a different state or, go to do something else out of our state. So it's important that we provide that mental health, those mental health services. Thank you so much.
Thank you. Have a good afternoon.
You too. Next is Ray Tao.
Hello, this is Ray.
Go right ahead, sir.
Yeah, I'm here. I'm strongly against the proposal PHB 6424. First thing, I think this is totally wrong. You connect the medicine disease related to the race. This is totally wrong. And secondly, if you have to do the research, you have to divide by more like basically you should not target on Asian. This is totally wrong. I just cannot understand why you connect this data collection with Asian. Why not other race? I feel offended and I'm strongly against this proposal. Thank you. That's all.
Thank you very much for taking your time to be with us today and to express your opinion on this bill. It's important that we hear from you, so thank you for your time. Next is number 62, Michael Madden, or Dr. Madden.
Yes, thank you, and good afternoon. My name is Michael Madden. I'm a physician and former chief medical officer of a multi-state Medicaid company. In my 36 years in practice, I've worked extensively on public health issues like opioid addiction, HIV, and smoking. While Reynolds has compensated me for my time in preparing my testimony, the opinions expressed here are my own. I've also submitted written testimony that provides additional detail and references to support my comments. Meaningful public health policies should be based on evidence and a careful balance of the needs of various demographic groups, rather than emotion, anecdote, and reaction. To date, there is no published data that flavor bans decrease youth vaping. Therefore, I oppose Governor LeBlanc's proposal to ban the sale of flavored electronic nicotine devices ENDS in Connecticut, and I urge you to consider the practical evidence-based use of ENDS for tobacco harm reduction. At the very least, the policy should include exceptions for both mint and menthol flavored ENDS and for ENDS approved for marketing by the FDA under the pre-market tobacco application or PMTA process that is currently underway. Harm reduction is a public health principle employed to mitigate deadly health risks. Examples include methadone for opioid addiction and helmets for motorcycle riders. While they don't reduce the risk to zero, they substantially improve safety and save lives. Smokers die prematurely not because they consume nicotine, which is not a carcinogen, but because of how they consume it in smoke. The FDA has recognized that there's a risk continuum across tobacco products, and public health researchers estimate that ends are 90% less harmful than cigarettes. Further, a recent study in the New England Journal of Medicine found that smokers who use e-cigarettes while quitting were nearly twice as likely as those who did not to be smoke-free 1 year later. Flavors are important in tobacco harm reduction. The FDA has recognized the availability of flavored tobacco products may help smokers move away from combustible cigarettes. And industry data demonstrate that more than 53% of adults choose flavored products when they make the switch from cigarettes to ends. Governor Lamont's proposal includes an exception for products approved by the FDA under the Modified Risk Tobacco Product Statute. However, it should also include a similar exception for flavored vapor products approved by the FDA through its pre-market tobacco application PMTA process. Products approved through both of these processes will be recognized by the FDA as appropriate for the protection of public health. Further, by banning mint menthol ends, you decrease the likelihood that menthol smokers may see less harmful ends as an acceptable substitute to menthol cigarettes. And you may drive them back to using combustible cigarettes even after they've switched to a safer end. I urge you to consider the public health benefits of implementing a robust tobacco harm reduction strategy and to decline Governor Lamont's proposal to ban all flavored ends. Alternatively, the flavor ban must include a common sense exception that includes mint and menthol ends and products approved through the FDA's PMTA process. Thank you. Happy to answer questions.
Thank you for your testimony, Dr. Madden. I don't see any questions at this time, so have a nice day.
Okay, thank you very much.
Thank you for being here. Next is number 63, Monty Dew.
Yes, I'm here. Thanks.
Go right ahead, sir.
All right. Honorable members of the Public Health Committee, good afternoon. My name is Monty Dew. I'm a resident of Wilton. I'm testifying to oppose Raise the Bill 6424. I understand the bill intends to promote health equity among minority groups. However, good intents can sometimes lead to unexpected results. I am concerned about the particular language in the bill which says it will collect ethnicity and primary language-based information. Unlike race, which is a well-accepted concept, Black, white, Asian, etc., and you can almost guess it anyway, ethnicity and primary language are much more private and detailed. And ethnicity is not a real well-defined thing. So when it comes to mandating data collection based on ethnicity, a very strange thing usually happens. Asian Americans are usually singled out and subdivided into numerous subgroups. It's called Black, white, Asian, etc. And you can almost guess it anyway. Ethnicity. Something is in echo, but so a very strange thing usually happens. It's singled out. It's called we call it Asian registry. I would like to display a few samples of government forms to illustrate it. These are from like states such as Rhode Island, California, and Oregon. For example, this one. You can see, if you could see, you are either white or African American or Native, or you're one of all these. Chinese, Japanese, Koreans, Indian, I mean, you name it, you got a mouthful. I don't understand it. And in fact, earlier today, Vicky Valtri, the executive director of OHS, specifically talked about subdividing Asians emphatically. You see, when it comes to ethnicity data collection on public officials automatically think about subdividing Asians, a very small minority indeed. Wow, Asian Americans must be weird. Well, that's a joke. But seriously, we are Americans. I might have an accent, but I'm American. My children are born here, they are American. We need to be treated as Americans, not strangers. This is particularly important in light of the recent wave of anti-Asian American violence and prejudice. Not to mention what had happened to Asian Americans in history. Chinese Exclusion Act, Japanese internment, you name it. I recently read an article, this is important, the article in Washington Post, the title is Judaism, Ethnicity. In this article, it detailed the level of scrutiny and concerns among Jewish Americans. Quote, throughout Jewish history, categorizing Jews into separate groups has led to othering and sometimes violence. Any good faith attempt to protect any minority from anti-Semitism or violence is a good thing. However, we're just cautious about government defining who we are and government defining who is part of us. So this article echoes a lot, within Asian Americans. By the way, Judaism is not a category on government forms for data collection. But like Jewish Americans,
you hit your 3 minute. You wouldn't mind concluding?
We'll be done in a couple of seconds. Like Jewish Americans, Asian Americans are also very worried about governmental defining who we are and who is part of us. You might need to be an Asian or Jewish to fully understand our feeling, but I do hope we understand. Please do not create an Asian registry in Connecticut. Thank you.
Thank you, sir. Senator Haskell.
Thanks so much, Madam Chair. I don't have a question. I just want to comment and thank Mr. Du for making his voice heard. It's good to see you, sir, and I appreciate your perspective on this bill.
Thank you very much, Will Haskell, for your help.
Representative Foster.
Hi, Mr. Du. Thank you so much for testifying today. I have a question. As you brought up these examples of other forms that look at ethnicity, and you're worried about things being broken out. I'm trying to really wrap my head around and understand the concerns and be able to balance in my decision making and voting on this bill, promoting health equity, and also taking into consideration the concerns of communities who are worried about being minoritized or marginalized with this data being collected. And I'm sympathetic to the concerns that you've raised as Jewish women. And also, it's interesting, you referenced ethnicities being broken out, and I am Cuban, and in our conversations about, as we've talked about Asian categories being broken out, I can empathize with concerns about that as someone who's Latin American, presents as white, and having conversations about that. So I guess what I'd ask of you, and I know that this is sort of an unfair ask in some ways, so feel free to tell me you'd rather not speculate, but since we understand that health equity is something that needs to be addressed and different groups have disparate risks of disease, there might be a case in time where people of different Asian descent we could learn something that would promote their health and well-being if that was categorized. Do you think that there's a place for that and there's a way to measure that appropriately? I think about a friend in grad school who is of Cambodian descent, and when people left Cambodia during wartime, they might have different health risks that are observed in US populations, and they have disparate health outcomes. And sometimes knowing and understanding and being able to sort of document that is important, because then you can tailor interventions to specific communities. Do you think there's a place for that and there's room for compromise? Is there a certain level of protection that could be added to this that would make you feel safe and comfortable with it?
There are a few things. Thanks for asking this question, Representative Foster. I know Cambodian Americans, and I know there are organizations who will say this is important to them. And I know organizations get funding by doing that. And I know my Cambodian friends couldn't care less about that. You got to distinguish between the organizations who feed on these things and the real people in real life. The other thing is, I'm glad that you mentioned that you are Jewish, if I heard it correctly. Would you want to see the Jewish be a box that you have to check on the government forms?
I see your concern there, but oftentimes when you have a hospital or a medical stay, they ask about your faith so that they can accommodate faith-based preferences in food and medical care. So it is very often in a healthcare sector, which this would be collected, and that's already categorized. So when I stay in a hospital, they often ask, "Are you Jewish?" It's part of your intake forms. And then I always hope that the next question is, "Do you keep kosher?" Because I anticipate that that's what they're trying to get at by capturing religion data is that they want to make sure that they can accommodate food needs. But I don't want to minimize the concerns that you have, that I think that they're very real. I know that there's important use for this data. In my mind, I'm always thinking towards a compromise. Is there a way to get the information that we need and make sure groups that are worried about minoritization are given the protections and safeguards that they need? Is there room for compromise? And if so, what stakeholders do we need to include in the table to have that conversation and sort of figure out what that compromise is?
I'm not against medical providers to ask what your religion is. Does that affect the treatment or food or drugs, whatever? They always do. There's a difference between this and the government mandating to collect this information. And I did not get an answer from you whether you support to put the Jewish as a box on the government forms. There's something else that I want to mention. Well, I lost my train of thought. I'll give you a chance. Maybe I'll pick it back up.
Well, I appreciate you sort of going through this exercise to think about this with me. I think that it's important that we're talking about collecting it in a medical setting, and the data would be disaggregated, non-identifiable by the time the data would be used by an organization that would want to benefit from the data. So it's not. So I think that there's a step there that provides a level of safety, but it sounds like that's not enough for you, is what you're saying. But I'd love to. I mean, I really do want to know and understand what compromise exists in this situation. So I would love, if you, after your thought comes back to you, if you want to reach out, I'd love to know what the answer is, because I do think in a healthcare setting, for healthcare providers to be able to provide appropriate care, it's important for us to know and understand groups that have different pre-existing conditions. I mean, if we want to use the Jewish example, we talked about Ashkenazi Jews and disproportionate risks of breast cancer earlier, but there's also Tay-Sachs disease, and there is also there's an allergy to sulfites in wine that is associated. And those things we would never know, learn, and understand if we didn't have good data collection to help us understand who is disproportionately impacted. And so I think that there's my gut going into this conversation before. This is the first time I've heard this debate, though I was informed about it prior. My gut was that the benefit is greater than the risk, but I'm listening, I'm hearing your concerns, and I'm trying to make sure that I can understand it. So if something like this is voted forward, that the appropriate safeguards could be put into place. But I really appreciate you talking.
Thank you, Representative. And I think you brought up an important issue. And I want to point out, though, there's a certain disease that's tied into certain type of Jewish people. Doctors know that before Jewish ever become a box on the government form. Okay, so therefore you are agreeing with me, putting Jewish on a government form is not necessary for the doctor to know that. Okay, that's a slippery slope. And it is also a slippery slope in a different sense. For example, I think some of the previous testifiers already said, there are a total of 56 different ethnicities within Chinese. 56 officially recognized. There are actually more. There are more in India and Russia. Where do we stop? This is a slippery slope. And that's a slippery slope that no one of us would want to get on, including you, Representative Foster, I believe.
You've given me much to think about, so I appreciate you testifying here today. Thank you.
Thank you.
Are you done, Representative? Thank you so much, Mr. Du. Thank you for being here today and representing your point of view so eloquently. We appreciate it.
Thank you very much, Senator.
Next is number 64, James Icabellis.
Thank you, Senator Abrams. Good
Hello,
afternoon.
go right ahead.
Thank you. Good afternoon, distinguished members of the Public Health Committee. My name is Jim Icabellis. I'm the Senior Vice President of Government Relations for the Connecticut Hospital Association. And I'm here to testify with concerns over HB 6488. This is the Office of Health Strategies bills concerning recommendations for facility fees. Just want to spend a minute before I get into 6488 and acknowledge the work that hospitals have done over the last year with respect to the COVID-19 pandemic. They have acted as a critical partner to the state. They've expanded capacity. They've established countless pop-up testing sites and now are a critical component of the vaccine program in Connecticut. The work that they have done and are doing is just amazing. It's also important to note that with respect to House Bill 6488, hospitals are not against reporting information with respect to facility fees. We've been doing it since 2016. The Office of Health Strategy has been putting out reports since 2016. We are opposed to this bill as drafted and the burdens that it places on hospitals and the sort of the confusing language that is in the bill. And let me just point out three things. And there was a conversation that Representative Zutkis had with Vicki Veltri about provisions related to the notices that hospitals were required to provide patients. And as currently written, this bill requires hospitals to have each notice printed in the top 15 languages. We are pleased that the executive director said, well, that isn't, the intent really is taglines, and that is a significant difference. So we appreciate that. We also need to work through the changes that have happened on the federal level with regard to reporting the 15 languages and how we can gather that data. In the last 6 months of the previous presidential administration, significant changes were made in the information that is provided. So we're going to need to work through that. There is a second provision that I want to highlight that talks about and requires hospitals under certain settings when they are to provide notice to patients. And the details of this bill as written says that hospitals must provide the number of patients in which they provided the notice. They must provide the different methods by which they provide the information, the number of patients that were provided each type of notice, and then the date on which they were provided each notice. The extent of this requirement doesn't appear to be balanced against the policy need to say, you have a requirement, hospital, to provide the notice. Did you provide the notice to the number of patients, and what are the various methods you use? I'm not sure what the policy purpose is to know that there were 25 emails and 275 letters. It seems to not balance the importance of providing the notice, and it is much more of a burden than I think it gives us a benefit to the patient, which is the importance of all of this. What is being given to the patient? Do they have the information? The last issue that I just want to highlight here today is a section of the bill that requires hospitals to report the number of patients that have required a reduction in a facility fee, what the outcome of that has been, and the sort of the changes in the bill. The way in which a hospital receives information as a concern about bills is various. The issue is going to arise rather quickly. What are the magic words that comply with this statute? If a hospital receives a direct request through its patient representative line or on a billing line that says, we have a concern about a facility fee, that I think is clearly within the lines of the statute. Other than that, any other request about their bill makes it extraordinarily difficult to determine how to comply with this. So we have real concerns on how you can comply and what are we requiring healthcare workers in the hospital to discern from their conversations. I want to end to say that we are balancing all legislation this year on the burden that it's going to place on healthcare workers versus the overall benefit, this and a variety of different bills. But it's important to notice that we have the utmost respect for Executive Director Vicki Veltri, We work with her in partnership. As a matter of fact, this week I have 3 different meetings with members of her team who are terrific. But we, on this one, just disagree on the bill as drafted, the burden that it places on hospitals. So thank you very much, and I'm happy to answer any questions.
Thank you so much. Representative Pettit.
Thank you, Madam Chair. Thank you, Mr. Acabellis. I think you make very valid points. Do you think there could be relatively small changes in the language that would allow the bill to still carry out the spirit of the law without the details that I agree some of them are probably a bit excessive in terms of reporting?
Yeah, I think the best way for me to answer that is, of course, we're willing to have conversations about this and every other bill. Obviously the effective dates on when they become effective. We are 1 year into a pandemic when it is all hands on deck. Granted, some of these provisions have effective dates which are out in the future, which we, but of course we're willing to have conversations and to figure out whether we can get there and then put the changes in this bill in context with everything else that we continue to see. So of course we would be.
So as I hear your testimony, it's mostly about sort of the extent and the details. Are there any specific things that you think would not be helpful in terms of evaluating the healthcare system and making decisions for the future that may be data, but you wouldn't use them for any particular purpose?
Yeah, the provision about providing the notice to patients. Let's say that a hospital has acquired a practice with 300 patients. The purpose of the notice is for those patients to recognize that the practice is now become part of a hospital system, and that may mean there are added costs to that. So the purpose of the notice is to let the patient know that. I'm not sure what we benefit from a policy to know that 200 of the patients got it by mail, 25 got it by phone call, another 25 got it by email, as opposed to know that the patients were notified. And most of the documents that OHS sends out require an attestation. And that becomes important because we have worked with OHS and they have been good partners on this, is that you're going to have somebody who's going to say, to the best of my knowledge, all 300 patients got this. We can't tell you that 299 did and one is lost in a mailbox or lost somewhere else. So we've worked with them to make reasonable accommodations there, but I'm not sure what the importance of some of those details are and how it then benefits the policy of recognizing patients need this information.
Yeah, I can't disagree. So, I mean, certainly someone who's in a small town, it's going to be word of mouth and social media. Someone who's got a referral practice who draws from a wide area, it's probably going to be phone calls into the office as opposed to mailing. So anyway, very much appreciate your sort of common sense approach to this. So thank you for your comments. Thank you, Madam.
Thank you.
Thank you, Representative Pettit. I don't see any other questions, so thank you for your time and for coming in and explaining all that to us. We appreciate it. And we
Thank
do
you.
appreciate all that the hospitals have done throughout this pandemic.
Thank you very much. Everybody stay well. Thank you.
You too. Next is number 65, Petrania Cash. I apologize if I mispronounced your name. Go right ahead.
Good afternoon. Can you hear me?
I can. Go right ahead.
It's Petrina.
Petrina, I apologize. Welcome.
That's okay. That's okay. Good afternoon, co-chairs Abrams, Representative Steinberg, Senator Juan, Senator Summers, and Representative Pettit, and esteemed members of the Public Health Committee. I am here to testify in support of HB number 6424. My name is Petrina Cash, and I am a resident of Fairfield. I am also a member in congregations organized for a new Connecticut through my church, First Church, Congregational in Fairfield. In Connecticut, Black and Brown people are disproportionately suffering from maternal morbidity, asthma, diabetes, COVID-19, and more. This is not okay. because Connecticut does not collect standardized data on the race, ethnicity, and language of patients, we cannot understand the immensity of the problem, nor can we identify solutions to the specific healthcare disparities that we face. As Dr. Marcella Nunez-Smith has said, the roadmap begins with data, is foundational. So, who is released prematurely from hospitals? Who has access to the COVID-19 vaccine? Who is appraised of the full range of treatment options by their provider, and who is not? Who is denied pain meds? Collecting micro-level data by race, ethnicity, and language within our healthcare system will allow us to identify who, by race, ethnicity, and language, is receiving inadequate healthcare treatment. And how can we correct it? Passing this bill is an opportunity to address the racial inequalities across healthcare in our state. I believe that any bill revising data collection requirements should require alignment of categories across agencies. Rail data is to be self-reported. The option to select one or more ethnic or racial designations and inclusion of other designation so that people can write in identities not listed. With rail data, we will know unequivocally who is suffering the most from poor health outcomes and who will be able to provide targeted interventions to tangibly improve the health care and well-being of hundreds of thousands of Connecticut residents. Thank you for allowing me to testify on this very important issue to me. Thank you.
Thank you very much, Ms. Cass, for being here and expressing how this personally affects you. I really appreciate it, and it is a very important issue. So thank you for being here and sharing your thoughts today.
Thank you all.
Bye-bye. Next is number 66, J. Paul Vance.
Hi, good afternoon.
Hi, go ahead, sir.
I'm here to give you some ideas and unintended consequences on bill number 6450. I know there's been a lot of testimony relative to a flavor ban of vape products and flavor ban of smoking and what have you. Upon reading the bill, I came up with what I consider to be some of the important consequences as a result of flavor ban. First of all, I don't believe that people, because of a flavor ban, are going to stop using their product that they're either addicted to or enjoy using. The legislature was very, very learned when they increased the age of purchasing the product at 21 years of age, which makes it an adult product. The same as alcohol in the state of Connecticut. It's been a difficult road for everyone to walk, but I think as I researched it and found out information, it appears that many of the tobacco companies have provided training to retailers to ensure that they card, it's called a we card system, that they card people to make sure that they've reached the age of 21. And certainly over 500,000 people, retailers have been trained to make sure that young people cannot gain access to these products. It's important that we keep it out of the hands of young people. I think a concentration on education of our youth to discourage and prevent their interest in tobacco. We know that smoking cessation programs and education are working to bring smoking to low levels, almost zero, to the young people in our country. You know, what's important is with an all-out ban on flavors, people are still going to access it by crossing the borders into bordering states where they're still available, these flavors, or through what's even worse, the black market. You know, the ATF, Alcohol, Tobacco, and Firearms, has said that I-95, which runs right through Connecticut, is a multi-billion-dollar smuggling route from Florida to Maine, indicating that tobacco products, vaping products are smuggled into surrounding states, going right up through the state of Connecticut. It's important also to note that there is a profit margin for smuggling. In other words, buying the products in low tax states, down in Virginia, for example, if you buy a pack of cigarettes in Virginia, you make a profit of about $8 for each pack that you sell. If you buy a carton, the profit is $88. A case, the profit is over $5,000. And certainly a truckload, 800 cases, $4.2 million in profit. Smugglers are enticed to bring the product into the states, even into the state of Connecticut, and force people that are running legal businesses to buy the smuggled product in order to compete with the stores and the convenience stores in their neighborhood or in their city or their town. And it does occur in Connecticut where these products are stolen and resold on the black market right here in our state. Recently, within the last 6 or 8 months.
Hit your 3-minute mark if you wouldn't mind concluding your remarks.
I will. In the last 3 months up in Northwest Connecticut, there were burglars that broke into a convenience store, went right by the cash register and took cigarettes and vape products, filling their garbage bags to add to the black market. We strongly recommend that the consideration be given to Bill 6450, but some of these issues and these unintended consequences should really be examined. Thank you very much for your time and for everything you've done today. It's been a long day for you folks.
Thank you, Mr. Vance. I'm not sure if you mentioned this, but just to be clear, you're a lobbyist for Reynolds American Incorporated? Is that
RAI
correct?
Incorporated, yes, ma'am.
Okay, thank you. I just wanted, I didn't know if you mentioned that at the beginning and I missed it, but I just want to make sure
All right.
that people know. So thank you so much for your testimony. I don't see any questions. Thank you very much.
Thank you.
Next is John Martin, number 67. Mr. Martin.
How did I do?
Mr. Martin, you're on mute. Go right ahead, sir.
Okay, you can hear me now?
I can. Go right ahead.
Great. Thank you, Senator Doherty. I'm here to address Bill 6450, specifically the proposed cap on nicotine concentration in vapor products. My name is Dr. John Martin, Professor Emeritus of Psychology and former Professor of Psychiatry at 2 major US medical schools. I'm also a licensed clinical psychologist specializing in addictions and health behavior change. As principal investigator, I've been awarded more than $4 million in federal and state research grants on smoking assessment and treatment, addictions, and health behavior, some of which was cited in the Surgeon General report on nicotine addiction. I've published approximately 70 scholarly articles, 20 book chapters, and 2 books in the areas of smoking, behavior, and treatment, alcohol abuse, and health behavior change. From my public health perspective, you have 6 substantial problems as well as unintended consequences with this law. First, the FDA is already reviewing all vapor products and will evaluate whether products at differing nicotine levels are appropriate for public health. This legislation is unnecessary and will undermine the process of achieving tobacco harm reduction. 2, there's a growing scientific consensus that e-cigarettes are substantially safer than combustible cigarettes. Thus, they present a real opportunity to promote tobacco harm reduction. If you constrain nicotine availability in these products, you reduce their acceptability and the public health gains from switching. 3, as a practical matter, any nicotine cap is ineffective. The amount of nicotine ingested depends upon the number and length of puffs a consumer takes at any given time. 4, capping nicotine concentration exposes users to greater levels of potential toxins, as studies show users will take more or longer puffs to achieve their desired level of nicotine, thus defeating the harm reduction benefits of e-cigarettes. 5, e-cigarettes have proven effective in smoking cessation, outperforming nicotine replacement products. By capping nicotine, you eliminate a key harm reduction treatment choice for those of us in the trenches who treat smokers through both rapid as well as gradual smoking reduction approaches. It's noteworthy that I have successfully treated the most highly addicted recovering alcoholic and veteran smokers who would likely find reduced nicotine products unacceptable as harm reduction tools, further tying our hands in motivating and treating a wide variety of smokers. 6th, and finally, capping nicotine levels creates the misperception that e-cigarettes and combustible cigarettes are equally harmful, which will deter smokers from switching or continuing to use these products. I've been compensated for my time here today by RAI Services Company, but my comments are my own. I hope that my presentation will guide your decision making on this important public health issue. Thank you for giving me the opportunity to speak to you today.
Thank you, sir. And RAI is Reynolds America Incorporated, the
Yes.
tobacco company? Is
Yes,
that
it
correct? Okay. And they're compensating you for your time today?
Yes.
Is that what you said? Thank you. Representative Pettit.
Thank you, Madam Chair. Dr. Martin, I wonder if you could give me the short version. I've heard it a few times, but a lot of people have testified or sent in the concept that a bill like this at a time when the federal government's going through the PMPAT process sort of undermines the process. And I've been a bit confused by that. Can you explain that to the committee?
Well, I could go from my my research findings and also just, as I say, being in the trenches of working with some of the most highly addicted smokers. Whenever we're restricted in terms of the choices we can give to smokers, whether they be on the gradual reduction, step down. By the way, most smokers quit by gradually stepping down, not by suddenly quitting. We like to cover both bases. So we can, by choice and including motivational procedures, we can help to step them down, to encourage them that they can choose, say, the higher nicotine e-cigarettes, which many of them prefer, especially my more highly addicted veterans and recovering alcoholic smokers, or rapidly. Either way, this is a tool that we don't want restricted in the sense that the government imposing, and by the way, a flawed scientific effort to try to eliminate this nicotine addiction, while at the same time tying our hands in terms of the choices we can give to our smokers. I'm not sure if I answered your question.
No, you made sense. I'm not sure it gets into the system that the feds, the complicated system the feds are going through. But I agree. I was always thought that you had to interact with someone 11 or 12 times to tell them to quit smoking before you had a chance to get him to quit. But you just had to keep going and keep bringing it up at every visit. So thank you.
Yeah, and don't give them the idea that that somehow the e-cigarettes are more harmful or equally harmful as the combustible cigarettes. That's not the case. It's not true. We want to tell them, look, the cigarettes are the worst. Anything you can do to get off of them, to quit, we want to support.
Well, that you open that can of worms a little bit. So presumably there's not the particulate matter with the vaping, but have the companies sorted out the issue with the superheated heavy metals and things with the vaping equipment? Has that mostly been the reloadable systems that have been the problem with that?
I think that's a little beyond my research and understanding, but I know that FDA has been investigating this and will continue, and they are the body that looks at the science, and they have not said, in fact, in some cases said the opposite, leave it alone.
Thank you, Madam Chair.
Thank you.
Thank you, Representative. I don't see any other questions, so thank you for your time, Mr. Martin, and for your testimony today. Next, we have number 69, Angela DeMello. Angela, you're on mute. Go right ahead, Angela. I think you should be okay.
I do. Thank you so much, Senator Abrams. Good afternoon, everyone. Good afternoon, Co-Chair Senator Abrams, Representative Steinberg, ranking members, Senator Huang, Senator Summers, Representative Pettit, and esteemed members of the Public Health Committee. I'm speaking in support of HB 6424, an act revising data collection requirements for healthcare providers connecting to statewide health information exchange. My name is Angela DeMello. I am a resident of Stratford, Connecticut, and the principal of the Strategies Group, a health insurance agency also in Stratford. I'm a leader with Connect, Congregations Organized for a New Connecticut. I'm a member of their strategy team and serve on their healthcare team as well. I support the bill for the standardized collection of race, ethnicity, language, REL, and as Vicky Veltri calls it, real data. The data is a critical component of evaluating health outcomes amongst various populations and ensuring health equity for everyone. The COVID crisis has made plain the health disparities in our state and the urgent need for data collection to address these inequalities. We cannot deny higher rates of infection, serious disease, and death in our Black and Latino urban communities in Connecticut. By collecting REL or real data, we will no longer be able to close our eyes to the many health disparities that exist in Connecticut. While I have become a US citizen, I am a first-generation immigrant from India. The Asian diaspora is very large and extremely diverse and includes groups that comprise of a large piece of the global population. By consistently collecting and analyzing health data disaggregated by health and ethnicity, we can evaluate who, how, where, and why disparities occur. I believe that any bill revising data collection requirements must include alignment of categories across agencies, REL data to be self-reported with the option to select one or more racial designations, and the inclusion of an other designation so people can write in identities not listed. In addition, I believe we should improve the process of data collection. While I am an immigrant from India, I am blessed to not have a language barrier, nor am I intimidated by a provider and feel reasonably capable of advocating for myself. Sadly, there are many immigrants, not just those of Asian descent, who struggle with these barriers. We really must find ways to build trust and rapport with the consumer or the patient by asking for and obtaining information in a non-threatening manner.
If you wouldn't mind concluding your remarks.
I'm sorry, I'm almost there.
Okay.
We need to get the information and it needs to be collected in a non-threatening manner. Building trust is at the base of everything we do. With HB 6424, Connecticut can improve the quality of healthcare provided to all Connecticut residents. I encourage all members of the Public Health Committee on both sides of the aisle to support this important measure. Again, thank you for the opportunity to speak today.
Thank you, Ms. DeMello, for being here today and for sharing your views with us. And I appreciate you offering some solutions to things that you think might be problems with this bill. So thank you for doing that.
Thank you, Senator.
Don't see any questions, so have a nice day.
Thank you.
Next is number 70, Elizabeth Stenger. Elizabeth, go right ahead.
Hi. Good afternoon, co-chairs Senator Abrams and Representative Steinberg, ranking members Senator Wong, Senator Summers, Representative Pettit. It's nice to see you again, and esteemed members of the Public Health Committee. My name is Beth Stenger. I'm a clinical social worker, and I'm a resident of Hamden. Through my synagogue congregation, Mishkan Israel, I'm a leader in Congregations Organized for a New Connecticut, better known as Connect. I also co-chair Connect's health and mental health team. On behalf of the 37 member congregations and institutions in Connect and the 30,000 people we represent in New Haven and Fairfield counties, I'm here to testify in support of HB 6424 for the standardized collection of race, ethnicity, and language healthcare data. Collecting race, ethnicity, and language is a critical component of evaluating health outcomes among various populations and ensuring health equity for everyone. The COVID crisis has shone bright light on the health disparities in our state and the urgent need there is for data collection to address these inequalities. The age-adjusted data we do have shows that Connecticut residents reported as Black are almost 2.5 times more likely to die from COVID-19 than white residents are. And Latino residents are dying at twice the rate of non-Hispanic whites. However, because the state does not consistently collect REL data or require health providers to do so, we are still missing huge amounts of information about the pandemic itself. For instance, as of yesterday, March 2nd, the state still lists the race and ethnicity of more than 35% of total COVID cases in the state as unknown, by far the largest group that's listed. The lack of data on COVID cases and on testing limits our ability to understand more about the ongoing pandemic and how it's impacting different communities and groups. And therefore, it limits the ability to intervene effectively to achieve better outcomes for all of us. With consistent collection and reporting of health data by race, ethnicity, and primary language, we can better evaluate how, where, and perhaps why various types of health disparities occur. There is currently a 19-year difference in life expectancy for someone residing on Colorado Avenue in Bridgeport, 70 years, and someone residing on Highwood Road in Westport, 89 years. We need REL data to more fully understand and begin to correct the health disparities at the root of this appalling discrepancy in life expectancy. With HB 6424, Connecticut can improve the quality of healthcare provided to all residents, and especially residents of color, by illuminating demographic healthcare trends across our state. With REL or real data, we can achieve better health outcomes for all of us and spend our healthcare dollars in more effective and efficient ways. I encourage all members of the Public Health Committee on both sides of the aisle to support this important measure. Thank you so much for your time.
Thank you, and thank you for being here to testify today. We really appreciate it. Representative Steinberg.
Thank you, Madam Chair. Thank you for testifying today. I just wanted to be clear. Are you representing Connect in this context, or
yes,
are you speaking for yourself?
Yes, I'm representing Connect as a co-chair of the healthcare team, yes.
Well, considering all the organizations and congregations involved, that is indeed a very strong statement. Thank you for your testimony.
I'm very proud to do so. Thank you.
Thank you so much. Oh, wait a minute, Representative Pettit.
Thank you, Madam Chairman. Elizabeth, do you think, with all the testimony that's gone today, a lot of people thought that a good option was having to opt in or not filling it out or putting other. Do you see problems with that? Would that be okay with you if a small percentage of people wanted to go that route?
I think that having the option to identify what your race and ethnicity is makes a lot of sense. I mean, as I understand it, the bill language is saying that providers are being asked to report it, but patients are not being required to answer the questions.
Thank you.
Thank you, Representative. That's my understanding as well, that you can be asked to share that information and the doctors need to share it or the healthcare provider, but the patient is not required to give it. So thank you for making that distinction. Thank you very much for your testimony today. Appreciate it. Next we have.
You went mute, Senator.
Sorry, thank you. Next we have 71, Jessica Isom.
Hello, can you
Go
hear
right ahead, Jessica. Thank you for being here.
Thank you. So hello to the co-chairs, the ranking members, and esteemed members of the Public Health Committee. I'm here speaking in support of House Bill 6424, an act revising data collection requirements for healthcare providers connecting to the statewide health information exchange. So my name is Jessica Isom. I am a practicing psychiatrist, an equity-focused medical educator, and a faculty member at Yale University. where I trained to become a psychiatrist. I'm currently practicing in Boston, Massachusetts. I support Healthcare Bill 6424 for that standardized data collection because it's really a critical component of us doing our work, not only as physicians, but as for me, I'm also a public health professional. I have both degrees. When solving any dilemma, it's really important that we define the problem because that's essential for us generating the proper solutions. And that is nowhere more relevant than thinking about healthcare disparities. Good data collection is the best tool that we have. And in my own clinic, it's something that I use to ensure that I provide equitable care. So I serve majority Black patients in Dorchester, Massachusetts. And in my own practice, I noticed that I was actually prescribing more stimulants to white patients. Most of my patients that had an ADHD diagnosis and that were receiving medication were white. I also noticed that mostly English speakers were receiving those medications as well. ADHD is a diagnosis that is across all racial groups, across all languages, so that disparity was concerning to me. This is a similar disparity to what's actually shown in the data, that there is a difference between who's diagnosed and not by racial ethnic group membership and also languages spoken. So what I did is I used the data in my own clinic to change how I approach diagnostic evaluations to make sure that more people were having access to that diagnosis. And I also paid attention to when I was speaking to a patient who did not speak English to make sure that I was screening them for that diagnosis. Without disaggregated data, those kinds of opportunities would not actually present themselves. And for me, imagining how this bill could be helpful is that there might actually be identified improvements in mental health and physical health across the state if we use this data to inform the kinds of solutions that we offer. So as a physician who's focused on health equity, this would be essential to the work that I do and essential to the success that I have in my patient population. So I support House Bill 6424, and I encourage you all to support it as well, no matter what side of the aisle that you're on. It's a very important measure for physicians like me, but really for patients in the state. So thank you.
Thank you so much, Dr. Isom, and thank you for giving some real life examples of how this can be impactful and what this legislation can mean moving forward. So I really appreciate that very much and appreciate your time today and for sticking with us all day to get your chance to testify. Thank you so much. Have a great day. Next is our last participant today, which is number 73, Rabbi Ellenson. Rabbi?
Thank you, Senator. Thank you, representatives, for having me. I'm here also to speak about House Bill 6424, as the last few participants have, on race, ethnicity, and language, healthcare data collection and standardization. So quickly, I wanted to share a couple of stories to understand this issue. I'd like to share my experience as a white male in the healthcare system as juxtaposed to the story I'm about to share with you from my colleague, Reverend Philippe Andal of New Haven, Connecticut, where he serves as the senior pastor of the Community Baptist Church. I also, not sure I said, I'm a rabbi in Cheshire, Connecticut at Temple Beth David. As the pastor, so this is from Reverend Andal, his story. As the pastor of a historic Black church in New Haven, healthcare disparity and race disparity is not just a data point on paper. It's an experienced reality that continues to result in disparate and deeply felt loss. One such loss is one of our members, Mr. Robert Johnson, Jr. On April 12, 2020, Mr. Johnson went into the emergency room at Yale New Haven Hospital with 103.3 degree fever and difficulty breathing. His chest x-rays showed signs of pneumonia. Despite suffering with these symptoms as a 49-year-old Black man, along with other risk factors, including hypertension, diabetes, and a dialysis 3 times a week, Mr. Johnson was not tested for COVID-19 and was sent home. That was Easter Sunday, the highest and holiest day in the Baptist Church, when they celebrate Jesus' resurrection. Unfortunately, Easter Monday did not come for Mr. Johnson. Mr. Johnson died at home that evening at home by himself. On Tuesday, April 21st, 2020, standing 6 feet apart, wearing masks and gloves with no tent to protect them from the cold downpour of rain, the Johnson family and Reverend Andal buried Mr. Johnson as best they could with the dignity he deserved, despite it being denied when he was sent home without being tested. Conversely, I'd like to share my story in the healthcare system. I suffered from dilated cardiomyopathy. It's where your heart is not pumping as much blood as it should. And similar to Mr. Johnson, I had shortness of breath. I was lethargic. I could barely move. It was 6 o'clock at night. I had to ask one of my fellow rabbis to take my class as I rushed around to find a clinic, any clinic that was open. And I rushed around and I found a clinic, and they saw me almost instantly. They performed a series of tests on me, some more invasive than others. To be honest, I won't get graphic, but just to say that they did x-rays, they did a full workup and discovered my heart condition. I've heard so many stories like Mr. Johnson's, and I think about my own experience in the hospital for 30 days and the great care that I got. And I just can't believe it's coincidence anymore that my skin color and gender affect how I'm treated when I go in. And this type of data collection will really shed light and awareness on what we're doing well and what we're not doing well. And I understand that awareness can make us uncomfortable. It forces us to face past mistakes that we've made, perhaps out of ignorance, most likely out of ignorance, and that can make us feel so terrible. However, awareness and this bill are not about shame, but about reshaping the future. And as humans, we're called on to continually improve. It's our sacred obligation and privilege to make the world better than we left it. We plant seeds so our children may enjoy the fruit of the future. HB 6424 is a seed we plant for our children. Thank you.
Rabbi, I feel so fortunate to have you be the last person testifying today. Very, very effective testimony. I couldn't agree with you more in that many of us have had experiences. First of all, I hope you're okay now. I hope your health is good. And,
I am. I take my pills every day. My doctor's very happy with me. So
good. So I think a lot of us have had those kind of experiences that give us pause. And it's one thing to know anecdotally what we suspect to be the case. And this bill would give us the opportunity to see it quantitatively, whether or not what we suspect is really what is happening. So I appreciate so much you sharing those stories. And I agree, sometimes it's hard to look at what we're doing because we might feel some blame in that and maybe should, but it's the only way to move forward. So thank you really very, very much. And I feel so grateful that you're our last person today. So.
Well, thank you for that, Senator. I appreciate it. I appreciate it. And thank you all for your time, really, and all the work you do for our state. I just want to say, just as a citizen of Connecticut, how much I appreciate all of you, and that we're really blessed to have such wonderful leaders such as yourselves taking, as I now see, really all day to listen to a lot of people. And
well, for this, so that you know, for this committee, this is a very early day. This has been a very easy lift for this committee. We are used to going well into the morning and sometimes overnight. So, so the people on this call, the committee members are all thinking this was a very easy day. So
okay, well,
we appreciate your comments, and thank you very much.
Thank you so much. And if anybody has any questions, of course, I'm always happy to talk and answer anything, either here or offline.
Thank you, sir. Okay. Madam Administrator, I think, is that it for today?
Thank you. And do you have an opinion on 949?
Yes, it is, Senator.
Okay. Thank you. And thank you, everyone. Again, as you
Madam
know,
Chair, if I might interrupt, I just want to remind committee members, we have a committee meeting on Friday at 9 o'clock and a public hearing on Monday, the 8th at 9 o'clock. So don't go too far.
Yeah. And also, so that you know, we're doing a lot of bills on Friday. So we might be there a while, maybe not, but we might. So just so we have a heads up. And I just want to say that after our last public hearing, I was so exhausted that I didn't remember to thank our staff, and they've done an incredible job. So I want to remember to do that this time and every time. So thank you so much for all you've done, and thanks to all the members of the committee. Really appreciate your time, and a special thanks to Representative Gilchrist for being so helpful today. Thank you, everyone. Enjoy the rest of your day.
Thank you.
Thank you. Bye-bye.